23-year-old male patient reported to our outpatient department with a chief complaint of pain and bleeding in the lower front tooth region since 6 months. On intraoral examination, we found a periodontal pocket depth of 9 millimeter in the distal aspect and 8 millimeter in the buccal aspect of port 2. Presence of gingival inflammation and bleeding on probing was also present in respect to port 2. Pulp vitality test was confirmed in the port 2 region. So IUP revealed a deep intrabony defect on the distal aspect of port 2 and widening of the face. So preoperative parameters took of periodontal pocket depth of 9 millimeter in the distal aspect, 8 millimeter on the buccal aspect, and 3 millimeter in the mesial aspect. So coming to the surgical procedure, so before starting of the surgery, we have a pre-surgical oral prophylaxis was done before 1 to 2 weeks before the surgical procedure with ultrasonic scalings, and instrumentation was done first 2 to 3 millimeters of the pocket, so that there was no to avoid any possible shrinkage. So the surgical site was anesthetized first. So only one horizontal incision was apically was done on the buccal mucosa as far as possible from the interdental papilla and marginal tissues. The soft tissue was then reflected apicocoronally by a full thickness flap, which exposes the coronal defect of the intrabony defect, keeping marginal tissues intact. So then the root planing was performed. Soft tissues that were not attached to the root were then removed carefully with the curettes. The area was then rinsed with the saline, and on PRF and the bone graft was then placed. Finally, a single horizontal matrix suture was placed. So patient was then given medication of 625 mg of amoxicillin with Zerodol P for 5 days. Patient was then asked to refrain from any mechanical oral hygiene for 4 weeks post-operatively. During this period, he was asked to rinse with 0.12% of the chlorhexidine twice daily, and the suture was then placed 1 week. The suture was then removed 1 week after the surgery. So post-operative views after 1 month, there is a complete wound healing of incision area was seen, and excellent state of interdental papilla with the marginal tissues was then seen. Patient reported no pain and discomfort. We can say we saw there is a after post-operatively 3 millimeters of periodontal pocket in the buccal aspect and 4 millimeter of distal aspect, and 3 millimeter in the mesial aspect. This is a picture after 3 months. So coming to the conclusion, direct apical approach provided good clinical and radiographic results. Minimally invasive approach resulted in a soft tissue preservation. Thank you, sir.
Technical team will start with the other one directly, or Dr. Guruprakash, how do we proceed now?
So we have to move on the next poster.
Yeah, Ravinderji, please play the next poster.
Say after 3 minutes, automatically you can change because we are not seeing the timer. So if the candidate is exceeding the time, just remove the poster.
Noted, sir. We'll do that.
Can the candidate start because he or she is wasting the time?
Hello, can I start, sir?
Yes,
Definitely
yes.
without wasting any time. You are losing on your time.
Good morning, everyone. So, the poster which I'm presenting today is based on a topic which is quite trending, that is in cosmetology. We are starting with something known as Botox and fillers. So, I'll be taking up filler as my topic of treatment in gingival recession. Fillers we know provide a volume contour. They try to augment features. They try to restore the smoother appearances. So hence, we are trying to use them to treat black triangles and gingival recession. So it may be fillers could be made of different materials like hyaluronic acid, calcium dihydroxyl apatite, polymethacrylate, etc. But from these, the HA is the only one which is naturally occurring linear polysaccharide, which is present in the extracellular matrix of synovial fluids and other tissues, mucosa and dermal areas. They are also quite biocompatible, hygroscopic in nature, and the most important physical property is the viscoelasticity, which we are going to use in this case report. Now, fillers were first actually introduced for aesthetic purpose in 1997 to treat black triangles in dentistry, but these conventional fillers show effect only from 6 to 12 months. So we have also introduced the new cross-linked HA fillers where the chemical bonding is done for individual acid change that will pull out the gel form and will last longer than 12 months. That is almost for 1.5 years or two. The two cases presented in the poster were injected with 2 ml of HF fillers at the baseline and after 7 days. While injecting, we have applied LA topically and injected amount almost of 2 ml amount. Now, actually, the drawback over here due to patient non-compliant, since patients were non-compliant, the drawback remained that I couldn't make a standardization. So I have used a pedontal probe to evaluate them clinically. Also, after 3 months, we see the gain in tissue, soft tissue was quite good, but not significant enough. But the significant excellent results were seen after 1 year. So 1 year follow-up of black triangle as well as the class 1, class 2 case recession patients showed excellent results for fillers. So hereby I conclude that why not to use minimally invasive techniques which could be clinically significant, and the new generation of cross-link HF fillers which are much more durable and efficient than the conventional ones for the perioesthetic treatments. Thank you. Can we have the next presenter, please? And the next slide. Uh, yeah, because the previous one didn't attend. She will be joining in next 2-3 minutes. So we'll have the next one now.
Okay.
So this is
the one
fourth one.
Fourth. Yeah, the third. Just play the fourth one, Ravinder ji. इसके पहले वाला play कीजिए. हाँ.
This one is the third one.
Yeah.
So they are still not there.
No, we'll play the
Fine.
fourth one.
Right.
Yeah.
Intentional replantation. Okay.
Dr. Satish, you can present.
Okay. Good morning to everyone. Today, my poster topic is about intentional replantation, a change in position. Intentional replantation is the intentional removal of tooth and its reinsertion into the socket after endodontic therapy. In this case report, a 33-year-old male patient came to the department with a chief complaint of bleeding gums along with rotated tooth in the lower front tooth regions. On intraoral examination, it revealed generalized bleeding on probing along with generalized increase in probing depth, and OPG reveals generalized horizontal bone loss. Based on these clinical and radiographic findings, we conclude with the diagnosis of chronic generalized periodontitis. Since the prognosis of 4-1 was poor, so the patient was advised for extraction of 4-1 followed by fixed prosthesis. Since the patient was not willing for extraction, so the alternative treatment plan formulated as full mouth flap surgery followed by intentional replantation. The first picture, which shows the preoperative image in which we can see the rotated 4-1, and second and third image, which shows the postoperative image after scaling and foot planning. After non-surgical periodontal therapy, full mouth flap surgery was carried out on subsequent visits, which is followed by intentional replantation. In intentional replantation, CGF preparation was done, in which 10 ml of intravenous blood was collected from the patient, and then it is placed in a centrifuge machine. At the end of the process, 3 blood fractions was obtained. The upper layer consists of platelet-poor plasma, and the lower layer consists of red blood corpuscles, and the middle layer consists of CGF. The CGF was placed in a membrane layer to make the CGF membrane of uniform thickness. Moving on to surgical procedure, the first image shows the preoperative image, which was rotated 4-1. After achieving adequate anesthesia at the site of surgery, 4-1 was extracted, and then root canal treatment was done extraorally. And then socket preparation was done to remove any granulation tissue. And then the socket was filled with CGF membrane and bone graft. The tooth was repositioned in the socket. Initially, the tooth was stabilized with the help of GIC splinting on the labial aspect. After 1 week, the tooth was the GIC splinting was removed, which is replaced by fiber reinforced composite splinting. And the IOPA image, which shows the rotated 4-1, and the second IOPA image, which shows the new position of 4-1. Moving on to conclusion, in the presented case, the tooth was rotated in its position, which was of aesthetic concern to the patient, along with its mobility. The patient was not ready to compromise its teeth. In such a case, intentional replantation is suggested a treatment option. And the success of intentional replantation is directly related to selection of cases based on clinical and radiographic evaluations. Thank you.
Dr. Aniket, you can start, please.
Hello, sir, can I start? Hello?
Yes, please start.
Yes, Aniket, your timer has already started.
Good morning, everyone. Today's poster presentation on prevalence of fenestration and dehiscence in the dry skulls of central India. Introduction. Fenestration can be defined as an isolated area in which root is denuded of bone and root surface is covered only by periosteum. That is, it is only blanketed by periosteum and overlying gingiva. In this area, the margin bole is intact, and dehiscence is defined as a denuded area extend through the margin bole. That means the thin layer of the bone over the root surface is destructed. That is the cortical plate, and it extends towards the there is complete extension of the destruction of the marginal bone. So aims and objectives of my study was to evaluate the prevalence, fenestration, and dehiscence in central India dry skulls. Material and method. It was done by visual examination from central. We have taken all the dry skulls from central India, that is 200 maxilla and 200 mandible in and around the Durg city. So the visual examination was done in 200 maxilla and mandible. So results, so the results we obtained here, canines and first premolars were the most common teeth that were associated with fenestration. Canine central incisor and first premolar were the most common teeth that associated with dehiscence. Both of them were present bilaterally in most of the skulls. Fenestration occurred more in the anterior region. Dehiscence occurred more in the posterior and were present in most commonly in the maxilla. So in conclusion, the potential of developing fenestration and dehiscence must be carefully evaluated through dental surgical procedure. Hello.
Yeah, you can go on.
Just finished with it. So we can go on to the next one.
Go to the next one.
Good morning, sir. Can I start?
Yes.
My topic of the presentation is a task supportive periodontal therapy, a task achieved with two different local drug delivery agents in the treatment of periodontal disease. Periodontal disease is an inflammatory disease of the supporting tissues of the teeth caused by an array of microorganisms resulting in progressive destruction of the periodontal ligament and alveolar bone with pocket formation recession of both. Host defense system aggravates the production of cytokines and other mediators, which progresses towards alveolar bone resorption and irreversible bone loss. Local drug delivery agents have been proven as a beneficial treatment modality for the residual pockets. The treatment method was pioneered by Max Goodson in the year 1979. Effectiveness of this therapy is that it reaches the base of the pocket and maintains the antimicrobial concentration for an adequate amount of time. Tetracycline fibers have been used to treat the periodontal disease due to its unique ability to reduce the degeneration of the collagenous matrix and inhibiting the matrix metalloproteinases. On the other hand, bisphosphonates are important inhibitors of bone resorption and osteoporosis. In this case, we have taken in case 1, we have taken tetracycline fibers, and case 2, we have taken alendronate gel. We have taken patients with residual periodontal pockets, 4 to 5 mm, were treated post-operatively after the open flap debridement. After the treatment, we have seen that there was a decreased bleeding on probing with decreased pocket probing depth after 1 month of SRP plus LDD. As a conclusion, we can say that there was a decrease in clinical parameters observed in both the local drug delivery agents when used as supportive periodontal therapy for residual pockets. Thank you.
Dr. Jharna, you can start.
He's not there, we can move on to the next one, right?
Hello. Hello.
Yeah.
Yes, you are audible.
Good morning, everyone. Today I'm going to present my case on Hope for the Hopeless, multidisciplinary management of teeth. Preservation of the natural dentition is a primary goal of dentistry, and patients today not only value their teeth but also express a desire to save their natural dentition in favor of extraction whenever and wherever possible. So coming to the case, a 54-year-old male patient with a history of tobacco chewing for long 30 years presented with difficulty in chewing food and feeling of a cracked teeth in its left lower back teeth region since last 3 months. So the highlights of this case, as you can see in the IOPR CBCT as well as the clinical photograph of the patient, that there is grossly decayed 3/6 with vertical crown root fracture with that teeth. There was complete obliteration of the buccal cortical plate with respect to 3/5 and 3/6. There were external root resorption with respect to 3/5 and gingival recession with respect to 3/4 to 3/6. And also there was close proximity of the mental nerve with the root apex of 3/5. So after extensive clinical and radiological investigation, the diagnosis was made as endoperio lesion with vertical crown root fracture with respect to 3/6, perioendo lesion with inflammatory external root resorption with respect to 3/5, and gingival recession with respect to 3/4 to 3/6. So coming to the treatment procedure, after a successful phase 1 therapy, the surgical procedures comprised of reflection of a full thickness mucoperiosteal flap, followed by removal of the complete portion of the medial root of 3/6, as you can see in picture 3. Then episectomy was performed with respect to 3/5, where apical 3 millimeter of root was removed. Then alloplastic bone graft hydroxyapatite was placed with respect to 3/5 and 3/6. Then you can appreciate the 15 days post-op picture as well as 30 days post-op picture and 3 months post-op picture, where there was reduced mobility, bone formation, and gradual elimination of the periapical pathology. And after waiting for 6 months, prosthesis was placed and it showed fully functional teeth with full satisfaction of the patient. So what are the different treatment options we had for this case? First, we can opt for extraction followed by implant placement in that teeth. But we all know that alveolar bone is a tooth-dependent structure. It remains and persists in the oral cavity as long as there is teeth. And even after implant placement, we know about the there is post-operative alveolar bone loss. So second treatment option was to perform hemisection of 3/6 followed by implant placement in the mesial root socket of 3/6 with episectomy of 3/5. But even after implant placement, there is alveolar bone loss. So we opted to save the natural dentition, and with the advent of different regenerative materials and techniques, we are able to perform this procedure. So coming to conclusion, the remaining teeth that a periodontist can save is not taking anything away from us, rather it is contributing to occlusion and preservation of the periodontium. Thank you.
Next participant, Dr. Prajakta.
We can move to the next one.
Dr. Nida. No. Can we have the third one? Ronak Baksh. She's here. Yeah. Dr. Ronak, you can start your presentation.
Okay. Good morning, everyone. So today I'll be presenting the case report on gingival overgrowth associated with extraoral manifestation, which is a clinical dilemma. Introduction. Gingival overgrowth or gingival enlargement is one of the clinical feature of the acute or chronic gingival inflammation. Plasma cell gingivitis is an uncommon condition characterized clinically by gingival overgrowth and histologically by plasma cell infiltration. The other terminology which previously used for this unusual type of condition enlargement were atypical gingivitis, allergic gingivitis, plasmacytosis of the gingiva, plasma cell gingivostomatitis, and idiopathic gingivostomatitis. Clinical findings: a 45-year-old female patient reported with a chief complaint of swelling in upper and lower jaw since 1 year, which was gradually increasing, due to which she experienced discomfort while eating. Extraorally, there were red lesions which were dry, patchy, indurated, and associated with itching, extending from ala of the nose to the base of the mandible. Both lips were also swollen. Intraorally, gingival overgrowth was covering more than 2/3 of the tooth. Overgrowth was dark, reddish blue, soft and edematous and flabby, extending from mucogingival junction to marginal gingiva. Enlargement was obliterating the vestibule. Bleeding on probing was present, and the probing depth ranged from 7 millimeters to 13 millimeters. Radiological findings: OPG showed subgingival flex of calculus and horizontal bone loss, indicating moderate periodontitis. Treatment and follow-up: after the initial phase 1 therapy comprising of scaling and root planing was performed, patient was advised to avoid the food products, chewing gum and toothpaste containing allergens. After a recall period of 10 days, resolution of overgrowth was not accomplished. Extraoral lesion and intraoral growth was bilaterally symmetrical and coincident. So complete one-side treatment approach was used. Flap surgery for gingival overgrowth using internal bevel gingivectomy was performed in first and fourth quadrant, and a section of gingiva was sent for histopathological analysis. Copac was placed and post-operative analgesics were prescribed. Post-operative follow-up after 3 months showed firm gingiva, and no case of recurrence was found even after 1 year. Histopathological findings revealed that dense chronic inflammatory cell infiltrate chiefly comprising of lymphocytes and plasma cells. Dense aggregates of plasma cells with no cellular atypia can be noted with dilated blood vessels and bundles of collagen fibers at the periphery. Discussion: plasma cell gingivitis is a rare condition with infiltration of plasma cell into the subepithelial gingival tissue. Its exact etiology and mechanism is unknown. Author considered it as an immunologic reaction to allergens. Allergic reaction may be considered by caused by dentifrices, chewing gums, or dietary products. Tims et al. In 1995 classify the plasma cell gingivitis into three types that are caused by allergens, neoplastic nature, and unknown origin. Care et al. In 1971 reported a case of plasma cell gingivitis due to which an allergic reaction from cinnamon used in chewing gum was Lehman et al. In 1990, in his study, found that the cinnamaldehyde intensifier is a positive agent for plasma cell gingivitis. Joshi et al. In 2015 reported bone loss in his case report in plasma cell.
Assa's time is up and your voice is also not clear. You have exceeded your time by.
Aggressive periodontitis associated with plasma
You
cell
change the poster,
gingivitis.
please.
Horizontal bone loss is seen in the.
Ravinder ji, can we have Dr. Jharna's poster? She's here.
Suggesting it for moderate period.
Should I start, ma'am?
Yeah, one needs to.
Yeah, you can mute her, please.
Yeah.
Yeah, you can start.
So good morning, everyone. I'm presenting on recession coverage in Miller's class 4. How much is it possible? Miller in 1985 gave the famous classification of gingival recession, and according to him, the recession coverage of class 4 has a very poor prognostic value. So despite knowing this fact, we still try to attempt coverage procedure, and this case report is a reflection of that condition. So a patient reported to our department with a chief complaint of long teeth in the lower front teeth region, and on clinical examination, it showed increased loss of attachment and minimal width of attached gingiva. CBCT revealed that there was enormous amount of bone loss in that area. Now, after a successful phase 1 therapy, the surgical procedure comprised of elevation of a full thickness mucoperiosteal flap followed by splitting of the flap into 2 equal halves and was sutured together with a sling suture. After that, alloplastic bone graft containing hydroxyapatite was placed in the defective area. The flap, it was then coronally pulled and sutured. The post-operative condition of the tissue profile of the patient was recorded on the 15th day after 2 months, 6 months, and 1 year. And the result, it showed 83% of the recession coverage, which was achieved on the 7th day, which gradually got decreased to 66% in 6 months. Increase in the width of the attached gingiva was appreciated from 2 mm to 6 mm, and also there was increase in the biotype. So to conclude, even though the literature says that recession coverage cannot be done in Miller's class 4 recession, but we can try and obtain a predictable result with the help of different regenerative materials and techniques. Thank you.
Is anybody left?
So we don't have the next presenter available.
Yeah, there are 2 more presenters as such.
Dr. Nida is also not. I tried calling her. She didn't answer.
And Prajakta is also not there.
Prajakta ma'am was there. I tried uploading her to the panelist.
They should have to be there at 9 o'clock itself. If they are not here, that means they are not serious for their presentation, isn't it?
I think Prajakta is there. She has. Is she among the attendees?
Yeah, I have already promoted her as a panelist.
Prajakta is saying that she is there, but she is not audible. So, can you just call her up and say that she can just exit and re-log in? Sometimes there is some problem.
I will.
And say in the meanwhile, if you want, we can. GP next में क्या करेंगे यार साथ साथ ही आंसर्स पूछ लेंगे यार कोई वो तो है नहीं.
Right, sir. as it suits.
क्योंकि वो ना फिर कंफ्यूजन रह जाती है, बाद में याद ही नहीं रहता यार क्या पूछना क्या नहीं पूछना.
We have to write the questions and then come back. It is a troublesome thing.
वो कर लेंगे, मतलब हो तो रही है टाइम वाइज, तो we are good enough. We have time, so because वो flow में हो रहा होता है तो पूछ लेंगे तो it's better. Otherwise,
right, sir. Sir, then if we don't have the attendees, we can wait for another minute or so. Then we can start.
We can start with the question and answers. If Prajakta comes, then it's fine. Otherwise, वो निडा तो है ही नहीं, तो ठीक है, छोड़ देंगे उसको.
Right, sir.
तो बीच में कर लेंगे उसको हम जो ये क्वेश्चन आंसर्स हैं तो हम कर लेते हैं बीच में.
Can we have the first presenter?
Dr. Saurav Roy.
Yes, sir. Good morning, sir. Am I audible, sir?
Yeah, you are audible, Saurav. Is it possible that we have his poster also along? Or let it be. Saurav, what was the advantage of going from an apico-coronal direction in this one?
Sir, the main motto is to preserve the firm marginal tissues, and with this.
But while going in a.
Sir, we need to approach the defect first. So for that reason, we are going apico-coronally. So for that reason, this is a reason why we incise apico-coronally.
But while going apico-coronally also, you have involved the marginal tissue, na? Because your excess which you have shown, that means you have accessed the marginal tissue anyways.
No, sir. The apical, the horizontal incision which was given, it's apical, which is far away from the marginal tissues, and the incision was made on the buccal mucosa.
That is there, but
yes,
till the time what I think is till the time you go in for microscopic views, there is no point doing this, because now you don't have direct access to the defect also. It is a blind procedure.
And yes,
until and unless you are using microscopes.
Microscope. Exactly. The
Yes,
topic
exactly.
Saurabh is minimally invasive surgery, but you have not followed the protocols of MIS, isn't it?
Sir, yeah, exactly. The microscope is also needed for this magnification. So that is the thing.
And even the microsurgical instruments also. That only then you can say that you have followed.
Gone for the yes,
minimally invasive surgery. Yes, it's right, a complete new arena right now. Now you cannot use all these conventional instruments.
Sir.
Okay, so it is lacking in that sense that you have opted for a topic for a very new surgical treatment, but you have not followed the protocol.
You see your gauze is also there from a coronal direction, so you have already gained the access from the coronal aspect, also breaching the marginal tissue. So anyways, in this case what it appears is you have given an extra horizontal incision. So whatever, it's a good attempt, fine, that you can just add on the microscopic things. You can use a loop or you can use a microscope. It takes time to adjust to that. It's not so easy. So you can try it next time once you are done.
Yes, sure, sir. I will keep it in mind.
Yeah.
Can we have the next one, please?
Thank you, sir.
Dr. Mithila, are you there?
Yes, she's there, sir.
The delegates can also switch on their camera. Those who are having the question
answer. Yes, it would be a nicer interaction in that way. Yes, you have used. Am I audible? Is she there?
Yes, you are, sir.
Hello.
Mithila, ma'am.
The candidate has to be there.
Dr. Mithila, she is present, sir.
Yeah, Dr. Mithila, are you there? Are you listening my question? Is she there, Guru Prakash?
Sir, she is there. She's unmuted, but I can't hear her. Dr. Mithila.
Dr. Manish, you have muted yourself. Someone call him.
GP next time फिर साथ साथ ही करेंगे, नहीं तो यही problem आएगी. The candidate is not available the next time.
Taking out the essence of asking an interaction.
We can move to the next one. देखते हैं फिर इसको. Ronak.
Hello. Yes, sir.
Could you complete the second
Yes,
half of the case also?
Okay, sir. Just the conclusion is left, sir.
No, I'm just asking you. You presented in your poster the first half of the patient's surgical. Na? You did it on the right side, na?
Yes, sir.
I'm asking you. Could you complete whether the patient came back and could you complete the complete surgical process?
No, sir.
Why? Patient was not compliant?
No, sir. Actually, due to this ongoing COVID, sir, the first surgery was done on 8th March. So after that, there was
Not able to hear your
lockdown.
answer.
So patient was the patient. So after then,
Some technical problem.
We are. Hello. You're not able to hear.
Hello.
You will.
Am I audible now?
Yes.
Okay. So, sir, actually, the patient was came when we went for the hematology. Her HB was 6. So, sir, we were not able to take her for this, sir.
Okay.
Dr. Ronak, was any type of mobility observed in these teeth?
No, sir.
Right.
So, Dr. Ronak, according to you, what can be the cause for both the extraoral symptoms of the intraoral gingival enlargement?
Sir, I feel this enlargement may be due to is of unknown origin, sir, because as we have seen, there is no, we have taken the detailed history of the patient, so there is no history of any allergens that can cause the enlargement. And sir, the neoplastically the lesion is not neoplastic also, so this might be an unknown origin lesion.
Sir, we have one of the presenters who has rejoined our poster. Next. Sir, I think Dr. Nida has rejoined. We can have her poster next.
GP, what we will do is we will just finish off this and Nida का फिर करके साथ ही questions पूछ के खत्म कर देंगे.
Yes, sir. Yes, sir.
वो कर लेते हैं. 2-4 रह गए. So it's fine, Dr. Ronak. Your connection was a bit interfering also. So fine, it's fine with us. We asked you whatever we wanted. So इसी का कर लेते हैं. ये जो है कौन? सतीश कुमार.
Hello, sir. It's Dr. Nida here. I was logged in before also, but I was not audible there. So can
no
I just present?
Nida. We will just finish off with the question and answer session of the few remaining, and then we will just ask you to present, and we will ask you the questions along with it.
Okay, sir.
Just wait for 5 minutes.
Guru Prakash, who is the next one?
So next we have intentional replantation. Dr. Satish Kumar. Can we have a slide also along with?
Is he there? Dr. Satish, are you there?
Yes.
Where are the presenters? Hey,
Yes,
we
sir.
are stuck to our schedule. Where have they gone?
Okay, he is there. He's saying yes, sir, but in a very low voice.
Yes,
Be
sir.
louder, Dr. Satish. Be louder. You are presenting a poster in a conference, okay?
And you can switch on your cameras, please.
Satish, according to you, is this a case of reimplantation or is this a case of using a natural tooth as a contact? Satish,
Sorry, sir.
did you get what I said?
No, sir.
According to you, this is a case of reimplantation or is this a case of using a natural tooth as a contact?
So this is a reimplantation case, sir, in which the 4-1 has a poor prognosis, sir. So we extracted and after doing endodontic management.
That is fine. We are not asking what you did now. But according to you, again, can you just change the rotation of a tooth in reimplantation? And can you reimplant a tooth if you are putting a membrane and a graft in a socket? The tooth will not go inside. If you have placed the graft in that socket, whatever the remaining socket is, as such it was periodontally compromised, and the remaining socket you are filling it up with a bone graft, the tooth root will not go inside. And if you see a post-op picture, the tooth root is totally outside. So this is a utilization of a natural tooth as a contact. So your title is wrong as compared to the treatment what you have done. As such, yes, fine. The treatment aspect, you have done it fine. No issues regarding that. But the topic and the thing is a bit, I would say, according to me.
You're very much correct, Dr. Manish. Satish, if you can elaborate what is the difference between a natural tooth ponting and in your case, what you have done replantation? Had you been allowed to do a natural tooth ponting, what changes would you have done? Do you know the concept of natural tooth ponting, Dr. Satish?
No, sir. I don't. No, sir.
Read about it, and else you have done a fantastic job in this, and this could have been the treatment of choice as such. So
one more point. What is CGF? Elaborated. Is it a PRF kind of a thing?
It's a concentrated growth factor, sir. It has a dense fibrin matrix compared to PRF, sir. So it contains a more amount of growth factors.
Okay.
CGF contains dense fibrin matrix, sir, compared to PRF.
Okay.
Dr. Satish, I have another question. Since you related to the topic you selected, that's reimplantation. So what is the viability? For how much time are the periodontal ligament cells viable extraorally?
The treatment should be completed within 15 to 20 minutes. It is done under a saline, sir.
Okay.
You had to do RCT as well, no? Isn't it?
Have debrided the root also. The root tip would have a lot of calculus in this case, which you had to debride. Fine, good.
And after how much time this printing was removed?
So after 1 month. Sir.
Just after 1 month, and you could get the. Could you check the mobility post-op? What was the mobility index?
बाद में डॉक्टर विवेक इसने फाइबर reinforced किया हुआ है पीछे से.
I can see in the preliminary slide, but in the last slide, he's saying that he removed the splinting.
GIC splint हटा के बाद में वो किया है fiber reinforced.
fiber reinforced remains in place for a long period of time. Now that's what
वो तो रखना ही पड़ेगा, वो तो लाइफ लॉन्ग ही रखना पड़ेगा, हटा ही नहीं सकते उसके बाद.
He removed it 1 month, na, he's saying.
Fiber reinforced also, Satish, you removed it.
Whether he did fiber reinforced or not, you are saying.
He said it. He said it while presenting.
So you can't remove it after 1 month.
That's it.
Anyways, okay.
Chalo, the next one. ये आ गई क्या? मिथिला आ गई क्या? नहीं, चलो fine. This one. Aniket?
Good morning, sir. Yes, sir.
In which city did you did this study?
Sir, Durg city and the colleges around this, we have collected the dry skull samples, and then we checked upon the
That is fine. Do you know the average population of Central India?
Sir, in
how
average,
many districts it has?
Sir, it has around like if we take Maharashtra as well as the Chhattisgarh.
No, my basic point is, just by evaluating for 400 skulls, you cannot generalize it as Central India.
Okay, so because we have also
say if I am based in north of India and I do an epidemiological study of 500 or 1000 patients, I cannot generalize it to whole of North India.
Yes, sir. Yes, sir.
So Central India is a big thing.
Yes, sir. Yes, sir.
Not written in a poster, how many skulls have you studied?
Sir, 200 maxilla, 200 mandible. So it was done by visual examination according to the fenestration and dehiscence found in right and left side of maxilla and mandible, according to tooth region and according to anterior and posterior region of jaw. Sir.
What was the ages of these skulls?
Sir, the inclusion got the date of the date of the deaths placed in the interval of 1999 to 2090.
But again, it depends, na, the age. What was the age of the person when he expired?
Yes, sir. It did.
It would be age related also, na?
Yes, sir. It did, sir. But
so it's difficult to determine
so
that.
You
have to determine it from the skull itself.
Yes, sir. It was a little difficult to determine that. But whatever I tried to get it as much as possible. So I tried hard to get. Yes, sir.
So it's overall a good study if you go in for as such a forensic odontology type of a thing. But you again need a bigger sample size.
Yes, sir. I tried to do as much as possible, but
you can continue with this with another increasing the sample size and involving say a forensic odontologist along with you.
Yes, sir. But it varied from geographical regions. Means the results varied very differently from geographical regions. So I stick to Central India, like around the Maharashtra, Vidarbha region, the Chhattisgarh, and around these regions I stick to it. Yes, sir.
Any kind of a statistical analysis that you could do, because your poster presentation is a very simple poster presentation, and you should take home a message that such kind of poster presentations lacks the scientific knowledge. You are just putting down some pictures and writing down introduction, aims, and results in few lines without any data. Where is the data?
Sir, if I go for the statistical analysis, sir, the frequency of fenestration found in right and left maxilla was higher in the canines and first premolar.
You have done a data analysis.
Yes, sir. 120.
You should have posted in your poster, isn't it?
Yes, sir. Right maxilla showed 60%, right mandible showed 56%, and left maxilla showed 63%.
You are only reading and telling us, but what your poster is it is incomplete in that sense.
Okay, sir. I would.
Results are only theoretically written, but where is the data to support it?
Yes, so the statistical data, yes, sir. I have it with me, but couldn't.
What is the significance of a dehiscence if you encounter anything during your periodontal surgery?
So sir, if there is any horizontal or vertical fracture, sir, it might cause the dehiscence, because the the marginal bone is completely destructed because the thin layer of the bone which is over the bone is completely destructed. That it's very thin, and that causes denudation of the marginal bone, and that may hamper our future periodontal regeneration. Any surgery if you do.
Yes,
So
mainly the
Daysons need to.
implant surgery.
Yes,
Mainly
sir.
the
Yes, sir.
implant surgery.
And for this, we use different PRF, and with hydroxyapatite crystals, we use the PRF coating. So to get the regeneration of the periodontal root.
Okay.
Yes, sir.
Fine. GP, आपने पूछना है कुछ?
No, sir, we can move to the next one.
Sorry,
Right.
sir. We'll present statistical data next time. Sir. Sorry, sir. Yes.
Dr. Nida's presentation, sir.
We will just do it after we finish the question answers of the remaining. Dr. Priyanka, are you there?
Yes, sir. Good
The
morning.
Priyanka.
Yes, sir.
Good.
Priyanka, what do you mean by supportive periodontal therapy?
It's a therapy which we give in patients who are not ready for any surgical procedure. So who are not ready for surgical procedure, we give like scaling root planning or else local drug delivery.
Supportive periodontal therapy, you are saying it is done in patients who are not ready for surgical procedure, and your methodology is of surgical procedure. Contradicting them.
No, she has not done any surgery.
Sir, methodology में surgery के बाद remaining 4 to 5 millimeter pockets में ये डाला हुआ है. It is a residual pocket of 4 to 5 after OFD. तो surgery तो हुई है sir.
After OFD, she has taken up the patient to do her cases.
LDD के लिए फिर.
Okay. Surgery, what were
Dr. Priyanka, I wanted to start with this and ask you the difference between a normal LDD and the thing what you have done. So, but initially only you like it's fine, and say in your case 2 post-op, there is so much of bleeding. So once you have done with your phase 1, you have finished off with your OFDs, you have finished off with the SPT also, then the bleeding should not be there, because bleeding on probing is one of the major signs of gingival inflammation.
Yes, sir.
So if the patient is now periodontally healthy, then the bleeding on probing should not be there. Fine, residual pocket might be there, but that should not bleed.
Yes,
if a non-bleeding residual pocket is there, I am very happy with my treatment.
And you have opted for 2 test materials. One is tetracycline fibers and other is alendronate gel. Could you make it as a control group or a test group, or both of these are test groups? Are you understanding me? Both of the groups are test groups, or you compared one with the other?
Sir, test group, sir.
Both are test groups. You could have taken one control group with a golden delivery agent. If I ask you what is a golden delivery agent, local drug delivery, to compare with?
Sir, tetracycline.
Be loud to answer the question.
Tetracycline, sir.
Tetracycline, according to you, is the gold standard.
Yes.
So this could have been your control group if it is the gold standard, and as per the tetracycline group, how the alendronate tested in your case, was it better or was it equal?
Sir, tetracycline was better.
In terms of?
So, pocket reduction, sir.
Alendronate gel as a local drug delivery. Okay.
Dr. Priyanka, what's the reason for you using that stent?
Why have you used a stent? Dr. Guru Prakash is asking.
Dr. Priyanka, are you there?
Yes, sir.
In which year are you right now of your post graduation?
First year, sir.
All are
So basically, this is not your study.
Correct.
Dr. GP, ये भी ध्यान रखना है यार. ISP में ये भी बात करनी है. We always say that the study has to be completed, but that study has to be done by the student itself.
Yes.
किसी मतलब senior obviously senior की लेके कर दी तो she won't be aware about what SPD is, what LDD is, what आपने जैसे पूछा Dr. Vivek gold standard का. So obviously it's fine, Dr. Priyanka. Good.
So we can move to the next one.
Okay.
It's running short of time.
Yeah. और next में cover up कर लेंगे कोई.
Yes.
The candidate is there.
Yes, sir.
Next is
Sir Jharna Bharali.
Jharna, grade 4, class 4 attempted, and you could get 83% coverage observed
Yes,
on the 7th day.
Yes, sir.
What
But it
after,
gradually decreased.
what after 1 month, 3 months, or 6 months could you follow the patient?
Yes, sir. Actually, after 6 months, it was almost the same, nearly like 66%, then 63, 60. But it was gradually decreasing in a mild way, sir. Actually, the decrease was seen from 83 to 66 from 7 to 6 months, 7 day to 6 months. Then after that, the decrease of the
Was it really a class 4 Miller's recession, Dr. Charna?
Sir.
It is seemingly like class 3 also. What is the difference between 3 and 4?
So actually, there was a confusion in here as well. In class 3, the recession is beyond mucogingival junction, but there is a little migration of the teeth, and in class 4 there is severe migration of the teeth. But as per discussion with our staff and all, sir, we decided to
It is not migration, it is malposition.
malposition. Yes, sir.
I don't find the tooth to be malposed here in the poster. So I have doubts about the classification, and just Miller's classification, you relied the case on Miller's classification. There are several classifications that you could have attempted because Miller's is a very
Yes,
age
sir.
good, although the conventional and the very useful one. But can you throw some light on other classification systems for recession?
So, other than Miller's, we can follow Caro's classification of 2011.
Do you know who gave the modification for Miller's classification? No?
Sir, I'll have to look for it. No, sir.
You could have come completely thorough with the topic of root coverage. Okay, so read. There are many classifications. There are many modifications for Miller's classification, and anyhow.
In this case, which type of flap did you raise?
Sir, sir, here normally we have just given the clavicular incision and reflected the flap. After that, sir, from the mesial part of the canine, from 3.3 and 3.4, we have just pleated it, and then we have brought it together and sutured.
So basically, as such, you have not done any. So you raise the flap beyond the mucogingival junction.
Yes, sir.
So as such, I would say you have done a flap surgery, and the resultant root coverage is a sequel to it. Grade 4, first of all, you are saying class 4, where minimal width of attached gingiva. Class 4 is beyond the mucogingival junction. So
Yes,
as
sir.
such, zero attached gingiva should be there.
You are in first year, na, Dr. Sharna?
No, sir. Actually, I'm in final year right now.
In final year, okay. That's so good. That's why you had somebody been in first year. This would have again questioned the poster presentation of a surgical of root coverage in first year. Okay.
So sort of, but you raised the flap from 3.3 to 4.3, na?
Yes, sir.
And suture you placed just between 3.1 and 4.1.
Yes, sir. So there was a doubt, like if we keep the canine portion exposed, there will be a gain of the tissue or not. But thankfully, there was the gain of the tissue in that area.
Okay. So you can then change the flap design. So what I asked you, it is a different type of a flap design, I would say. The suturing
Yes,
part is different, so you should stress on that.
Yes, sir. But I was searching for a name to be given for
You
this
will not
flap
get a
design,
name.
but
You will not get a name anywhere in literature for
no,
this.
sir. No,
You have
actually,
to tell your, you have to give your name to this.
so hopefully, I would love to, sir.
So it's fine. It's fine. और पूछना GP आपने पूछना?
So we can move to the next one.
Right.
Thank you, sir.
एक रह गया बस.
Good morning, sir.
Okay. Hope for the hopeless.
अभी hyaluronic acid वाला भी रह गया है.
Yes.
Dr. Golder, why did you say it is a periendo in 3.5?
There was no caries or anything like that, but it might be because of two reasons. It might be because of the excessive masticatory load that are acting on.
Was there a periodontal pocket present in that?
Yes, sir. Yes, sir. Distal to 3.5, there was a periodontal pocket of more than 7 millimeters.
But not reaching the apex. Was the tooth non-vital?
The tooth was completely non-vital. We have performed RCT and followed by flap surgeries.
Okay.
You've done a hemisection for 6 now?
Yes, sir. For 3.6, we have removed the mesial component of 3.6.
Okay. No post-operative radiograph after the prosthesis placement, how the prosthesis is working?
Sir, actually, because of the COVID condition, we have placed the prosthesis, and after that, we couldn't follow up the patient.
Was it a 3-unit?
Sir, it was from 3.4 to 3.7 joint crown placement.
4 unit.
Yes, sir.
Okay. And this is a CT scan or
a CBCT.
Dr. Any coverage procedure in 3.4 and 3.5?
Sir, we have attempted on the first surgical trial how much root coverage we gain in the first during the flap surgical procedure, and we thought that after 6 months or even after process placement, we will try for again coronally pulled flap, because there was minimal amount of attached gingiva present.
You have followed up this case for how many months?
Sir, we have followed up for more than 1 year. This is the after processes placement. It was time duration of approx 1 month, 1 year, 2 months.
So did the periapical lesion in relation to 3.5 also subside more?
Sir, it's completely healed. You can appreciate in the left most lower IOPR, it has completely healed.
It has not healed in that one. So it is, I think,
it is a healing lesion.
Yeah, it's a healing lesion still there.
Yes, sir.
So 3 months you have shown it there, no?
Sir, it's yes, 3 months IOPR we have given.
IOPR. So you are saying 1 year. So 1 year it would subside, and there are occlusal load symptoms also which are seen in the IOPR in relation to the distal root of 6. So might be it was TFO. The patient was a pan chewer. It has fractured.
He was a tobacco chewer for long 30 years.
Yeah. And so once you have balanced out the occlusion with the prosthesis, this all will subside of its own.
Sir, we have flattened the cusp, and we have given the 0-degree cusp in this case. So to minimize any sort of jiggling forces on this tooth.
Okay.
Good surgical case. Okay.
Right.
Okay, carry on, Dr. Guru Prakash, the next presenter. Hyaluronic acid 1.
Hello. Hello.
Dr. Mithla.
Yes, sir. Yes, sir.
Yes, you're audible.
Hello.
Can we have our poster, please?
Dr. Mithla, which type of syringe did you use to inject the HA?
Sir,
First of all, did you do these cases or there are somebody
yes,
else
sir.
cases?
No, no,
You did
they
it.
are my own cases.
Okay.
I've done
So-
it in 2020 itself.
So which 2020? Okay. So which syringe did you use?
So the 27 gauge needle. And actually what I did was the filler came in a syringe which was very big and not indicated for the injection. So I transferred, I changed the needle of that syringe. So
Which filler did you use?
27
Which filler?
filler, HA filler, sir, cross-linked HA filler
Which
from
company?
Genfil.
Okay. So and did you find any use in the recession part?
Yes, sir.
The case two.
Speaking of the truth, sir, actually, in the black triangle case, it showed great results, quite excellent, quite significant. But in recession case, initially, I didn't see any changes up till 4 months. After 4 to 5 months, it started showing some results, and I got almost 60 to 70% coverage, not 100%.
But in recession case, where did you place the filler?
Sir, on the facial surface itself, and the
Facial
attached
surface, the tooth
gingiva.
is there.
I mean, sir, in the attached gingiva, in middle third of the attached gingiva.
No, Dr. Mithla.
Sir,
your topic
I
is of
also
gingival
considered
recession.
the.
Your topic is of gingival recession, and you talked more about the black triangle treatment, isn't it?
Yes, sir. So, actually, sir, coming
And
on
say
to
for
gingiva.
recession, you have written the patient in this case was non-compliant towards the orthodontic treatment due to COVID-19. Okay. Okay. So what,
Sir, I've
what Dr.
also
Vivek is
considered the
asking, it should be more
gingival
on-
biotype. Yes, sir. Sorry, sir.
What Dr. Vivek is saying, it should be more on the black triangles because you don't have a closed cavity to fill it up in the case of recession.
And we cannot appreciate the recession in the preoperative photograph. Where do you find the recession?
Sir, it's on 3-1 actually. It was very mild. So I've considered the Miller's class 1. And sir, I also considered the gingival biotype, and then I have selected the case. So given a thought, I wanted to try it for gingival recession because a lot of times patients who are undergoing orthodontic treatment are not opted for such procedures. So why not to go for something like fillers and create the aesthetic?
For recession, Dr. Mithila, injecting that into a sound attached gingiva, it's not possible. For black triangle, yes, it is. You also know you would be doing it. So how much ml of the filler would you have injected in the black triangle?
Yes, sir. Yes, sir.
Barely it goes. It forms a bleb, and over a period of time, that bleb subsides.
Sir, it was much easier for black triangle. It was very difficult for the recession. Also, what I realized is in recession, I may need multiple sittings. Just 2 sittings were not enough.
For recession?
Yes, sir.
Yeah, sometimes for say the black triangle also, depending on how much the black triangle is, you need more sittings also.
Yes, sir. But what I realized was the filler gave me great results in black triangle, which has been already experimented. So
yeah,
I
you could
wanted to
have
try
chosen
in
your
recession.
topic quite sensibly then. Like gingival recession, उस हिसाब से choose करते थोड़ा सा.
Yes, sir. But I
चलो
just
good
wanted.
है ना. GP आपने विवेक सर कुछ पूछना है GP?
No, sir. We can move to the one we already.
Dr.
Thank you
Nida,
so
na?
much, sir. Thank you so much.
Yes, sir.
You can have the 9th poster, 9th or 10th. Is anybody there?
Dr. Nida is there. Na?
Dr. Nida.
Sir, my presentation is left for the poster.
Yeah, you do that.
Please.
But
So 2 were left, 9 and 10.
huh?
So
The 2 were left. Dr. Prajakta and Dr. Nida.
Prajakta was okay. But GP Dr. Nida's topic, what we have got is different as compared to what she is presenting it here.
Sir, actually, it's the same, but only the title was changed due to, we were expecting it to be a bit more eye-catchy, so we put in like pathway from brown to pink. Sorry for that.
You can't do that, Nida. So you can't do that. Once you have sent it, you can't do that.
So,
you
sorry,
could have done
sir.
it before sending.
We are having this poster. We are having this poster in session 2. I can see the topic in session 2.
From brown to pink?
Yeah. No. For pink aesthetics, again a changed one. No.
वो एक और है, 2-3 है depigmentation पे sir.
वो
Nida present it because we would be sending the same topic because we have got the list of the same topic, the previous one.
Yes, sir. Yes, sir.
Right.
Sir, sorry about this.
So, Prakash, what is the previous topic?
वो है sir, comparison of gingival depigmentation techniques using burr, scalpel, and electrosurgery and laser.
Okay.
So to begin with, one of the essential components of an attractive smile is the gingival appearance and health. Thus, achieving acceptable aesthetics along with addressing the biological and functional concerns is a great challenge. Sometimes it poses as a great challenge. So gingiva is most frequently a pigmented intraoral tissue, and common aesthetic concerns require the patient to seek some cosmetic treatment. So the basic factors responsible for pigmentation are the number and size of blood vessels, the epithelial thickness, quantity of keratinization, or pigments within the gingival tissue. So the current poster depicts the comparison of different gingival depigmentation techniques using scalpel, burr abrasion, laser, electrocautery. So the patients were selected between the age group of 18 to 35, and they typically complained of dark pigmented gingiva, and they were evaluated on the basis of gingival pigmentation index by Perrin et al., given by Perrin et al. In 2014, which is an index that ranges from 0 to 10. And then so starting with the treatment plan, we performed at least 20 depigmentation cases, 5 by scalpel, 5 by laser, 5 by electrocautery, and 5 by diamond burr abrasion. So 11 and 15 number blade were used. This technique was basically first proposed by Dummett and Bolden in 1963. The idea was not only to achieve acceptable aesthetics, but also to rule out that which method was most appropriate in concerning to relapse, because most of the patients, comparatively, they were females and they were highly apprehensive of the relapse thing that was happening. So this was the concern also. So we used Nd:YAG lasers and electrocautery tips. Loop electrodes were used and diamond burr abrasion. So in electrocautery, loop electrodes were used in light brushing strokes, and this was kept in motion all the time to avoid overheating of the tissue and destruction of the tissue. Then diamond burr abrasion was taken into consideration. So we concluded that the case series depicted the outcome, patient compliance, and probability of relapse efficiently, and laser was more beneficial in terms of patient compliance as it provided us with a bloodless and painless surgical field. Electrosurgery was another method that was well tolerated. However, some of the cases relapsed within 6 to 8 months, and a few cases we lost due to COVID-19 also. And then burr abrasion technique and scalpel were equally effective and yielded minimal rate of relapse, but did not facilitate much of patient compliance because of the bloodless field. All the patients were given with a periodontal dressing for a week, and after that they were with post-operative medications. And then after that, after a week, they were instructed to use chlorhexidine mouthwash for adequate healing and adequate oral hygiene. So thank you.
So according to you,
Dr.
laser
Neda, can you tell me what do you call this the design of the study?
Hello.
Neda?
Yes, sir.
So what was your study design?
Sir, it was a comparative evaluation of different techniques.
Dr. Vivek, you were asking something, please. You may continue.
Yeah, I was asking you. So you found in your study, the comparative study, the laser as the most efficient one.
Yes, sir. Laser was comparatively the most efficient one because of patient compliance, and it also provided minimal rate of relapse when compared to electrocautery. However, personally, I felt was when I used scalpel or burr abrasion, they provided the most bare minimal rate of relapse. But laser, according to patients, it was very well tolerated.
Now, what were your criteria of evaluation?
Yes, this is what I was asking, that any objective method that you could have evaluated, only on subjective, that it is a personal preference, or we could see some relapse for this.
No,
that.
Dr. Vivek, personal preference also, but there has to be criteria, na? The index, whatever the visual analog scale, while pain, whatever
There has to be some
criteria.
objective methodology.
Yes, sir. For pain, we used the visual analog scale. However, they were all administered with anesthesia. But we used visual analog.
Dr. Neda, it is a post-operative pain we are bothered about.
Yes, post-operative discomfort was seen much more in scalpel and burr abrasion technique and was least seen in lasers.
You never mentioned all those things, huh? You are now saying because laser was better because it showed less of relapse. Then you are saying that you found less of relapse in scalpel and burr. So there have to be fixed criteria, fixed indices which you would have used to determine all these things.
Yes, sir.
Okay.
Healing ka hota hai, healing, how do you assess the healing in these cases? It's not just by the visual examination. Laser में जल्दी heal हो गया, cautery में ज़्यादा देर लगे. So it has to be fixed criteria for healing also. And Nida, for future things, you are not supposed to show your college name on your poster.
Yes, sir. I'm sorry, sir.
And why did you selected 5 patients only in each group?
Sir, it was a study conducted, but we were losing a lot of patients due to the pandemic also, because here in Bhopal, they come from different districts also, like Vidisha, Satna and all.
So basically it was a short study type of a thing.
We had to cut it down to 5 patients only.
Okay, right. Fine.
Okay. Thank you, sir.
Is anybody left from this session?
Yeah, as such, Dr. Prajakta is there. Pouch and
Good morning, all. Am I audible?
Yeah, you are.
Good morning, all. My presentation topic is management of gingival recession defect using pouch and tunnel technique with connective tissue graft, a case report. First is gingival recession is the displacement of soft tissue apical to the cemento-enamel junction with exposure of the root surface. Then history of CTG. The CTG was first introduced by Edel in 1974 to increase the width of keratinized gingiva. And then the use of CTG to cover the gingival recession defect was begin in 1985. In the year 1985, scientists Restek et al. Use the connective tissue graft, modify the connective tissue graft as envelope technique. Then Allen in 1994 modify this envelope technique to tunneling technique. Then case, a 36-year-old male patient reported to the department with a chief complaint of sensitivity in maxillary first posterior region. On clinical examination, the Miller's class 2 recession was recorded with respect to the first and second molar. scaling and root planning was done, and patient recalled after 1 week. Revaluation after 1 week, the surgical patient prescribed to surgical procedure. 2% chlorhexidine was a patient asked to rinse with 2% 0.2 plus percent chlorhexidine to rinse prior to the surgery. 2% lignocaine with 1:1 lakh epinephrine was administered. Then tunnel was prepared using tunneling knife, which extend beyond the mucogingival junction and leaving the interdental papilla intact. Then all the attaching muscles and the collagen fibers are resected to on the inner side of the flap to get the mobile flap and helpful in the its coronal advancement. A proper template was used to harvest the graft from the palate. Place the template over the palate and using 15C blade, a horizontal incision was given perpendicular to the bone surface, which is 3 mm from the gingival margin. Then two vertical releasing incision was given from mesial and distal end of the horizontal incision. Then using the blade, the connective tissue was harvested. After that, the donor site was sutured and stent was placed. After harvesting the graft was placed into the prepared tunnel and it is stabilized with the suture, 50 absorbable seal suture. Then after that, the flap was positioned coronally and it is stabilized with the composite stop suture. After the and patient advised, then periodontal plaque dressing was given, and patient patient asked the patient to maintain the oral hygiene and recall after 1 week. 1 week after 1 week, the suture was removed and revaluation after 2 weeks. A complete root coverage was obtained and the complete healing was also observed. Then the result, 99% was root coverage was obtained at the end of 2 weeks. And the conclusion, the pouch and tunnel along with CTG can be successfully used as a treatment modality for multiple gingival recession defect. The advantages of the tunneling with CTG is that it is the tunnel technique is it decreases the incision and it provides the due to preservation of the interdental papilla. It provides blood supply to the graft. Due to the creation of the tunnel, it is helpful to stabilize the graft. And disadvantages of this technique, it is.
Thank you, Dr. Prajakta. We are beyond time. We can just get to the question answer for your poster.
Yes, sir.
You are in which year?
Sir, second year.
Okay, you have attempted connective tissue graft harvesting surgeries?
Yes, sir.
Which is the donor technique as such which you used? You have described in detail, but what is the name of that technique?
Sir, trapdoor technique.
Dr. Prajakta, what's the advantage of using pouch and tunnel technique?
Sir, it is helpful to stabilize the graft by suture.
Anything else? Any other advantage?
Minimal invasive.
Minimal invasive.
Okay.
Fine. GP will start with the second session straight away because we are short of time now. We have to rush up.
Yes. We can, Sijal, can we have the poster for the next sessions, please? Straight away, we can move to that.
Sure. Session 2?
Yes, please.
Yeah. Can we have the first poster, Dr. Arya?
Sijal, for these, we will have the question answers along with the posters only.
Okay, done. So, candidates?
Dr. GP will rush up now.
Yeah, so we will be having the question and answers after each poster.
Yeah.
Yes, please.
A very warm good morning to all. Am I audible?
Yes,
please, you can start.
Myself, Dr. Arya Ravindranath, presenting before you my e-poster titled Regenerative Therapy for Intrabony Defect using platelet-rich fibrin with 5-year follow-up, a case report. Before starting with the presentation, I would like to give you a brief introduction about
What is periodontal regeneration? Periodontal regeneration means reproduction or reconstruction of a lost or an injured part in a manner similar or identical to its original form. In periodontics, it refers to formation of new bone, cementum, and a functionally oriented PDL at a site deprived of its original attachment apparatus. So the aim of this clinical case report is to present the successful outcome of periodontal regeneration with PRF alone in the management of intrabony defect over 5 years of long-term follow-up who was on regular periodontal maintenance therapy. A 35-year-old female patient was referred to periodontology department GDCRI Mangrove with a chief complaint of bleeding gums and pain in relation to lower left back tooth region. No significant medical history was given by the patient. On clinical and radiographic evaluation, an intrabony defect extending up to apical third of the left mandibular first premolar with a probing depth of 10 millimeter using Williams periodontal probe was measured. The pre-operative radiograph is shown in figure 1. The diagnosis was periodontitis stage 2 grade A with localized incidental attachment loss. Initial therapy consisted of oral hygiene instructions, scaling and root planing of the teeth were performed, followed by a modified flap operation. In surgical intervention, a full thickness mucoperiosteal flap was raised after early administration and all the granulation tissue was thoroughly removed and root surfaces were planed using hand instruments. For PRF preparation, 5 ml venous blood was drawn from the patient. It was centrifuged at 3000 rpm for 12 minutes. PRF was then placed into the defect. The flap was repositioned to its pre-surgical levels and silk sutures were placed in interrupted technique. The picture A and B shows the follow-up radiograph of the case. A shows 1 year follow-up and the picture B shows 5-year follow-up. Thus, there was a significant improvement in clinical parameters such as probing pocket depth, clinical attachment level, and radiographic parameters such as defect fill indicated the success of the regenerative therapy. Thus, this case report demonstrated that PRF is a very effective preparation for periodontal regeneration therapy. Such significant results were also obtained because the patient strictly adhered to the regular periodontal maintenance therapy. Thank you.
Again, in this also, GP, the topic what we got and the topic in this poster is different.
So we can take a note in the evaluation.
Yeah, it's almost the same, but a bit different.
Dr. Arya, can you tell me about any third generation platelet concentrates?
Yes, sir. In third generation, we have titanium induced platelet concentrates and advanced platelet rich PRF. Sir, in advanced platelet rich PRF, the RPM was set to 1500 RPM for 8 minutes. And in titanium infused platelet rich PRF, we used titanium coated tubes and also IPRF is also there.
Who pioneered the second generation platelet rich fibrin?
Sir, second generation platelet rich fibrin was given by Chokron et al. In 2001.
Okay.
Do you think that a combination of bone graft with a PRF would be a better choice, or just PRF would be a better choice in future?
Yeah, yes, sir. Combination with bone graft will be a better choice, but because bone grafts will also provide little bit space maintaining this thing, and it will also induce the bone generation. PRF also acts as a same thing. It also acts as a biodegradable scaffold. It has growth factors which will induce the microvasculature. I feel that with bone graft, it will be a better choice for future.
Good. Great. We go on to the next one.
Good morning, sir. Am I audible?
Yeah, you are.
Good morning, everyone. This present Yes, sir, I will start. Good morning, everyone. This present post case report has shown about the effectiveness of Caldula officinalis when combined with porcine-derived gel form, that is Cura sponge, in assessing hemostasis and early wound healing at the free gingival graft donor site. So coming to the introduction, we all know the FGG is a simple predictable technique for increasing the zone of attached gingiva, and one of the major complications associated with free gingival graft donor site is excessive bleeding and post-operative pain. So in this case report, what we have planned, we have combined the gel Cura sponge, that is gel form derived from the porcine, and we have combined this Calendula officinalis, which has a good medicinal values, and they have used in the Fokker system. So we have combined both in FGG donor side. So coming to the clinical presentation, the 23 years old female patient had reported to the clinic with long tooth in lower front tooth region. On examination, we have found its grade 1 mobile, and that is class 3 gingival recession, and there is an inadequate vestibular depth in relation to 3-1 and 4-1. So we have planned for the conventional vestibuloplasty with FGG. So in the case management, we have prepared the donor site, and a 10 mm free gingival graft was procured. Followed by that, Caldula gel 10% was applied on that area, and gel foam was placed, and sutures were given. So post-operative instructions were given, and post-op was checked at 10 days. After 10 days, we have seen the color match with the adjacent tissues, and we have used the healing index, that is laundry tumble index, and we have found that there is less than 25% of red gingiva was seen at the 10 days, and we have taken that verbal rate index, and the patient was given one that is indicating the mild pain. So this is the post-operative view after 10 days. So coming to the discussion, this is the first case report where they are using Caldula gel and the Cura sponge in that FGG wound donor site. So we have compared with some other studies we have already done. They have used PRF, they have used erythropoietin, topical erythropoietin. And while comparing to PRF, in this TPRF has shows the good efficiency as a good donor wound site healing material. And while comparing to other amnion membrane and all, this Caldula has shown a good effect. So coming to the conclusion, this case report shows this Caldula gel when combined with that collagen sponge, it shows faster and continuous hemostasis and make a positive contribution to the early soft healing. So thank you.
So doc, your main objective was hemostasis, or your main objective was better wound healing?
Sir, main was better wound healing, sir. But one of the disadvantages of Calendula is when we are applying the gel in the donor site, there is a high chance of diffusing with the oral fluid, sir. So we have used the gel foam as a scaffold and also this gel foam has good efficacy in controlling the in the bleeding, sir. So we have used that also.
That is but your title says achieving hemostasis.
Yes, sir. So we have so we place the jello.
So it should be assessing the healing.
Yes, sir. Yes.
Because hemostasis can be achieved by n number of ways. Yes, one of the ways is this also. But if it is hemostasis, then your stress is on hemostasis only, not on healing. Then.
Yes, sir. We have checked the both, sir. Like.
Yeah. So I would say it increases the healing. It increases the patient comfort, because the FGG donor site is quite problematic to the patient sometimes. So all these things, either a PRF or a sponge itself, it aids in the patient comfort also.
Yes, yes.
And aids in healing. Yes, definitely it aids in healing. Right.
How many cases have you done of
Sir, actually we did 3 cases, sir. In the 2 cases, follow-up was not there, sir. So we didn't able to present that.
And did you find any inconvenience in the retention of the sponge as well as the gel?
No, sir. Actually, this sponge has good color match also, sir. In the third picture you have seen, we have placed the sponge. It is very good to adapt in that area, sir. Actually, the sponge is so thin. When we are applying in that area, it has the ability to fill that area, sir. I didn't feel any difficulty while placing.
You need to apply suture as well. I can see you in the picture.
Yes, sir. We place suture and we have given periodontal pack also, sir.
Okay, periodontal pack also.
Yes, sir.
Periodontal pack was retained by what means?
Sir, we have given retention by means of this adjacent teeth only, sir. This 6-5 we have.
Palatally, it's quite difficult to
Yes, sir,
attain that retention for the whole area.
Yes, sir. We have extended that into the near the teeth and also
Okay,
in
good, good, good.
Okay.
Good.
Can we have the next one, please?
Sir, am I audible?
Yes, you may begin.
You are.
Yeah. Good morning to one and all. Today I'll be presenting a case report, aesthetic smile designing and planning. As we all know, as recent days, young adults are mostly having this gingival exposure, and they usually consider it as a problematic condition or aesthetical condition which has to be treated. As we know, excessive gingival display is a common condition where overexposure of the maxillary gingiva on smiling occurs. It is a multifactorial condition where it is associated with dentoalveolar extrusion, short upper lip, hyperactive elevator muscles, altered passive eruption, and excessive vertical bone overgrowth. Sometimes these factors are dependent on multiple treatment modalities. So always we need a multidisciplinary designing and planning necessary for better treatment outcomes. So this is a current case report of a 21-year-old female patient with a chief complaint of excessive visible gums, prior orthodontic treatment, and post-orthodontic treatment. In this case, the patient also presented with a marginal gingival enlargement at the post-orthodontic treatment. This is the clinical photo where the patient presented with a short clinical crown, enlarged marginal gingiva, and adequate sufficient keratinized gingiva. The first management included continuous external epidural gingivectomy from canine to canine, followed by gingival depigmentation. Post-operatively, after 2 weeks of treatment, the patient relieved midline diastema and a slight flaring of the teeth. So we had to stop further lip repositioning treatment, and the patient was advised 6 months removal orthodontic appliances to close the midline diastema and to get adequate midline closure. After this, the patient was planned for the lip repositioning post 6 months, where the later laser-assisted modified flap repositioning was done for the initial incisions, and modified lip repositioning was done. During this modified lip repositioning, we had to spare the labial frenum as enough to get the tissue stability and to avoid asymmetrical gingival exposure on smiling following surgery. So following this treatment, the patient has a better satisfactory outcomes, and the post-gingival exposure or excessive gingival display reduced from 8 mm to 2 mm. This favorable treatment outcome was mainly obtained when we had a combination of orthodontic combined with periodontical treatment and correctly planning the time and the duration of the treatment. As initially the patient also presented with orthodontic and flaring teeth, and the patient had to go for it, and later we had to plan the lip repositioning, but later again the patient presented with the midline diastema. So we had to later plan again 6 months removal orthodontic appliances, and the patient was planned for lip repositioning. These were the treatment modalities. This was prior to 1.5 years. This was prior to 6 months when we did crown lengthening and gingivectomy, and this was after lip repositioning was done. Post totally the treatment was 1.5 year almost. Thank you, sir.
You just did a single case with this, or have you attempted others also and they're still moving on?
Sir, actually, we planned a lip repositioning to be done as an initial treatment procedure, but the patient was more building towards orthodontic treatment. Along with the gingival exposure was her main treatment also. So we had advised her braces for 1 year. Later, she came with us for the treatment, but she presented with this marginal gingiva enlargement. So we did external gingival gingivectomy. Later, after 2 weeks, we planned for lip repositioning. And the patient later, after gingivectomy, 2 weeks healing, she again presented with midline diastema. So we again advised her removal orthodontic appliances, and the midline diastema closure was obtained. And this was the exposure post-orthodontic treatment, and adequate, we can see here, sir, midline diastema was closed almost completely. And then when we did her laser-assisted modified lip repositioning with the sparing of the labial frenum, so that we have adequate tissue stability and asymmetrical, to avoid asymmetrical gingival exposure on smiling. It was actually a procedure of 1 year to 1.5 years it was followed, sir. This case was.
You said modified modified lip repositioning. What is conventional lip repositioning?
So conventionally, we usually Actually, this conventional lip proportioning was considered by mainly a medical plastic surgery, sir, by Robinson, where they basically said that we, instead of sparing the labial frenum, a continuous incision was placed along the mucogingival junction, including the labial frenum was supposed, we were removing even the labial frenum along with that continuous incision. Instead of sparing labial frenum, we were doing a continuous incision of the mucogingival junction.
Okay, so patient was given at least 2 years of time, roundabout.
Yes, sir. Yes, sir. Almost 2 years of time. This was all the 3 phases of the treatment, where we had to do gingivectomy. Again, we waited and for the mid and diastema closure, and then we gave this was a recent one with the orthodontic ablation after obtaining a smile.
Okay.
We can have the next poster, please.
Good morning, everyone. Am I audible, sir?
Yes, you are. You can talk.
Thank you, sir. Myself, Dr. Kanimali, I am going to discuss about a case report on reimplantation, which creates a hope to an hopeless teeth. Intentional reimplantation of a tooth is a procedure which is anticipated to retrieve a hopeless natural tooth in the oral cavity by its extra or intraoral endodontic manipulation, followed by reimplanting it in the alveolar socket. A 27 years old male patient reported with the chief complaint of increased mobility in 2-1. On intraoral examination, we found 10 mm probing depth in 2-1 along with grade 3 mobility, and significant bone loss was found. We followed a non-surgical periodontal therapy. After that, the surgical therapy was followed. In the surgical procedure, atraumatic extraction was done, followed by an apicectomy. 2 to 3 mm of the root tip was removed, and it is filled with MTA, which acts as a biocompatible material, and then it is preserved in a tetracycline with saline solution, followed by an corticotomy and reimplanting it carefully into the socket. And then splinting was done along with regenerative materials were placed, which includes a sticky bone and amniotic membrane. Then next, the sutures were placed. This is a post-operative view after 6 months. Here we can find a significant amount of bone growth in that area. This is a procedure where we have to check for an following condition, which includes an atraumatic extraction. We have to extract the teeth by holding it in the crown so that we prevent destruction to the PDL cells and the following sockets, which helps for an regeneration. Next, root conditioning. Here we preserve the tooth in the tetracycline plus saline solution, which removes the smear layer and also increases the open up the dentinal tubules and also responsible for the fibroblast attachment and also prevents a root resorption. Corticotomy. Here we reduced the socket by means of corticotomy, so that which increase an osteogenesis potential and helpful for an proper regeneration. Next, we placed an reimplant in the position. Next, which includes an regenerative technique. Here we used an PRF along with the sticky bone, along with then a bone graft, cybograft, which creates a sticky bone and placed by means of amniotic membrane. And next, less intraoral time, which is the critical case where we have to done a procedure within 20 minutes so that we can maintain the cells in the viability and it increases the regeneration capacity. So intentional reimplantation is considered as a last resort treatment alternative to delay extraction of the periodontally compromised teeth. Thank you, sir.
So according to you, doctor, like what can be the reason for such an extensive loss in just a single tooth?
Sir, this is a case of localized aggressive periodontitis, sir, where the patient is about 25 years old, so that we have planned for this procedure, sir.
And what was the role of corticotomy?
So corticotomy, which creates osteogenesis potential, sir, which increases the bone fill there, which increases bleeding over there, and also it helpful for osteogenesis potential.
Patient was 25 years old?
Yes, sir.
So he said, and he is happy with the virus splints facially. And till what time have you planned to place this splint or any changes in the splinting?
Sir, this is a case with the 6 months follow-up, sir. Up to 6 months, we have placed the splinting, sir. Because of this situation, we not able to do a review, sir. Once on next review, by assessing the mobility, we can discuss about the splinting, sir.
But say the splinting also disturbs the oral hygiene, and especially at 6 months, you can see extensive plaque deposits also. So because the oral hygiene would be impaired. So again, that is detrimental to the periodontal health. So you have to reinforce the oral hygiene instructions again and again in these types of patients. But else, like it's a good attempt, and the results are good, I would say.
Okay.
Right. The next one. Yeah, Dr. Janvi, are you there? Dr. Janvi, are you there?
Yeah, sir, she's there.
Just ask her to start, like, yeah.
Yeah. Dr. Janvi?
Yes, ma'am. Can you hear me?
Present. Yeah.
So we will have to.
Respected panelists and my dear delegates, a very good morning to all of you all. Today, my topic for the case report is gingival depigmentation for pink aesthetics. Lately, aesthetic dentistry has gained much importance in the recent past as it plays an important role in accentuating a person's personality and uplifts the self-confidence. Gingival depigmentation is one of those cornerstones of excellence in aesthetic dentistry. As in this case report, a 20-year-old male has presented with a chief complaint of dark gums since his childhood, and we have taken a medical history which is non-contributory, and there was no relevant habit history. So we have performed at a scalpel technique, and this is an image of immediate post-operative. And this is a post-operative image at 1 week, where we have later performed on the lower arch. And this last image is the post-operative image at the 3 months. So I would like to compare the present case with the other options, alternate options that are available. First, before talking about scalpel, I would like to compare it with lasers. Lasers are relatively less painful to the patient, and which increases the compliance. And also the bleeding is less, which improves the visibility during the procedure, and only the side effects could be the delayed healing, expensive, and it could be technique sensitive. The other two techniques of electrosurgery and cryosurgery and ascorbic acid are also being used lately, of which cryosurgery is found to be having major advantages of rapid healing, inexpensive, and it also has shown long-term superior aesthetics. And even ascorbic acid is found to be a less invasive method. So with these conclusions, we could say that conventional scalpel has been having more advantages. That means the advantages are overweight as compared to the disadvantages. And in my case, the patient had only pain for 1-2 days, and later he said that he did not need any pain control. And also it is seen that like another case of laser that I performed, I've seen that I've personally experienced that laser is taking a longer time of healing when compared to this conventional scalpel. With this, I would like to conclude saying, and also reaffirm saying that conventional scalpel is the gold standard. Thank you all.
Doctor, can you elaborate something on ascorbic acid utilization for depigmentation?
Yes, sir. So ascorbic acid is used like intradermally, and also topical is also studied, sir. And even the systemic administration is also found that it is showing equivalent, comparative results, sir.
Systemic for depigmentation?
Yes, sir. There were studies which were done, sir. I have included them in my
systemic use of ascorbic acid, and you can get rid of gingival depigmentation.
Yes, sir. There were the studies which were done, sir. Sir, I can give you probably the reference also.
Manish sir.
Go on to the next one.
Okay.
Dr. Bhavneet?
Yes, good morning, sir. Should I start?
Yeah.
So good morning to everyone. So as we know that beauty is power and smile is its sword. So lip and gingival tissues constitutes the macro element of dentofacial aesthetics, along with the face and teeth. And the pigmentation of gingiva and lip is just not has an impact on the aesthetics, but it also creates psychological negativity. Pigmentation can be defined as darker gingival color beyond what is normally expected. So a wide array of pigmentation techniques are available, such as gingival abrasion, scalpel surgery, stripping, electrosurgery, cryosurgery, laser, etc. But due to the scarcity of literature that guides the clinicians to choose the most appropriate technique, in this case that were done by us, we took in the department we took 4 patients with gingival and lip hyperpigmentation, who were between the age group of 18 to 50 years, without any underlying systemic disease, and they were all non-smokers. Any pathological conditions such as Addison's disease or Peutz-Jeghers syndrome was also ruled out after taking a detailed medical history of the patients. We use diode laser, which exhibit at 980 nanometer exhibit enhanced hemostatic activity, good visibility at surgical site, and has fewer post-operative complications such as pain, bleeding, edema, infection, and impaired wound healing. It is an effective and safe treatment modality with ease of access to interdental papilla, and it has a low rate of reoccurrence. So after this, we applied application of periodontal pack was done in case of gingival depigmentation, and patients were given post-operative instructions such as to avoid spicy and hot food and to have cold beverages, and they were given painkiller in case of any pain. Then the patients were recalled on the 7 and 21 days to review the healing. It was found that that there was an impressive effect of depigmentation without causing any adverse effect or damage to the lip or the gingiva or the underlying tissue. Lip and gingival hyperpigmentation is an aesthetic concern as it masks the overall appearance of an individual. The diode laser seems to be an effective and safe technique for melanin depigmentation. This technology reduces the level of anxiety and stress in the patient with better post-operative outcomes and brings about real comfort to the practitioner as well. The patient surely walks out with a beautiful and confident smile. Thank you.
So Dr. Bhavneet, the lip one, you did it in a contact mode or a non-contact mode?
Sir, we did.
So we did it in contact continuous mode in a brush-like fashion. We use the laser.
On the lip also?
And then on the lip also,
Yes, sir,
and on the gingiva also. And on lip, we did we applied laser from upper lip to the lower lip, including the commissural area.
And did you inject? It was under topical or injectable?
Sir, injectable LA.
And both were done on the same day?
Yes, sir. Both were done, upper and lower lip, both were done on the same day. And along with doing with the laser, we also use low level laser therapy to increase the wound healing in the cases of lips only, not on the gingiva.
This last pick is of what time period follow up?
Sir, about the lip one is about after 21 days. Sir, because we were doing this patient and then there was closure of the department and hospital due to COVID condition. So we couldn't follow it more.
So the lip wound healing was not comparable to the gingival group, because obviously the gingival would heal faster and better as compared to the lip one, I suppose.
Yes, sir.
Sir.
Yes, sir.
Yes, sir. And also gingival healing completes like full completion of healing and epithelialization, full re-epithelialization
Will take time.
Takes place
Yeah.
in 6 months.
Yeah, that's it. Chalo, that's good. Next, please. Dr. Deepika can be now. Can you be a bit fast now, please?
Yes, sir. Good morning, everyone. The topic for my poster is vestibuloplasty, challenges in the management of a medically compromised patient, a case report. So a 22-year-old girl reported to the Department of Periodontology at KD Dental College, Mathura, with the chief complaint of bleeding gums and inability to maintain the oral hygiene. Medical history showed that she was taking antihypertensives, antidepressants, and anti-anxiety drugs since 7 years. The patient also had complaint of disturbances in sleep and was not able to perform the normal daily routine due to panic disorder and frequent anxiety attacks in the night. Upon clinical examination, we found inadequate vestibular depth in the anterior mandibular region, due to which her oral hygiene was poor, which was causing gingival recession. The challenges which were faced was the patient's anxiety and acceptance to the treatment. We started the treatment with psychological evaluation and phase 1 periodontal therapy, which included scaling and root planning. After having an opinion with the doctor who was treating her, we started with cognitive behavioral therapy on follow-up visits. After 1 month of cognitive behavioral therapy, the mood of the patient elevated and the patient became more communicative, and the panic attacks also got subsided. The patient seemed more uplifted, so we proceeded with the vestibuloplasty with a Clark's technique, in which the depth of the vestibule was increased. Blood investigations were done and informed consent was obtained from the patient prior surgery. The blood pressure was monitored and kept in normal, and non-adrenaline anesthetic was used. So first of all, we measured the vestibular depth by a UNC 15 probe. Then a horizontal incision was placed at the mucogingival junction, which was followed by supraperiosteal dissection. Then the mucosal flap was sutured to the depth of the vestibule with a resorbable Vicryl 50 suture, and aluminum stent was placed to maintain the new vestibular depth. Then a copac was placed over the raw area on the alveolar bone. Then then the vestibular depth was evaluated at the time intervals of 1 week, 2 weeks, 1 month, and 3 months post-operatively. After 4 weeks of healing, mucogingival stress eliminated and the 6 to 7 mm of keratinized tissue was achieved, and the patient was satisfied with the result. Therefore, I conclude by saying that vestibuloplasty with Clark's technique can give good high results and can be a reliable treatment of choice for the patients with systemic conditions.
So it is just for the patients with systemic conditions?
Yes, sir. Yes, sir. Sir, actually, we faced many challenges while treating the patient, because the patient was already on anti-anxiety drugs, and she was in depression since 7 years. So it was very difficult to...
Dr. Deepika, I'm asking, vestibuloplasty is not a treatment of choice in patients without medical conditions then?
No, sir, it's not that, but... So the case was, I found the case to be very challenging, because the patient was very anxious and like very uncooperative before the treatment.
Yeah, that is there, but that is nothing related in this type of patient. Say doing a scaling and root planning is also you have to do it with caution only. So all
Yes,
the
sir.
treatment would be challenging in medically compromised patient as well.
Yes, sir. Yes, sir.
So had you not done vestibuloplasty, what would have affected to the patient?
So the patient was already on anti-anxiety drugs, and there was already there was poor oral hygiene, and the patient was not able to brush properly. So that is why we went for vestibuloplasty, because there was improper placement of brush, and she was also that was also leading to further gingival recession.
Hey, Dr. Way, we move on, like, because we are ahead of time now. The others are waiting for us.
Okay.
Like the next one, please.
Okay, sir, am I audible?
Yeah.
So should I proceed?
Yeah, you start.
Yes, sir. Good morning, everyone. Today, my poster is on non-surgical periodontal therapy. Is it still a gold standard? As we all know that the aim of the effective treatment of periodontal disease is to arrest the inflammatory disease process by removal of subgingival biofilm and establish a local environment and microflora which is compatible with the periodontal health. So the reduction of the probing pocket depth, maintenance and improvement of the clinical attachment level, and reduction in the bleeding on probing are most common outcome measures that is used to determine whether the treatment is successful or not. So now in the present COVID scenario, the focus should be on addressing the importance of patient-centered treatment outcomes. With this, I present you the following case series on the left column of the poster, where you can see the pre and post of the clinical photographs, the frontal view. In the first picture, it is of 34-year-old male patient showing the effect of meticulous scaling and root planing, resulting in the improvement in the inflammatory condition. In the second before and after picture, it shows the decrease in the recession with the help of the minimally invasive non-surgical approach, as well as proper instrumentation, leading to the gain in the attachment level. In the third picture, it shows the similar results of a 26-year-old male patient who was given again entitled to the structurous NSPT, sir. On the right column of the poster, the two clinical photographs of the patient is shown reflecting before and after diligent non-surgical approach, and resulting in the significant reduction in the clinical parameters like the probing pocket depth, bleeding on probing, attachment level, and also in the gingival index. We have also done the microbial analysis and compared the presence of different microorganisms by culture tests and between the baseline and after 1 month post NSPT, sir. The test results showed that at baseline, majority of the microbial samples with a predominance of 90% of Porphyromonas gingivalis, followed by 70% of Treponema denticola. And after 1 month, it shows the significant reduction in these species, like 34% of P. gingivalis and 36% of Tenella forsythia. And this also showed the statistically significant reduction in microbiota count with a p-value of 0.003. So thus, the NSPT aims to eliminate both the living bacteria in the microbial biofilm and calcified biofilm microorganisms from tooth surface and adjacent soft tissue. And I would like to conclude that the field of periodontology is continually emerging, and the dentists and hygienists must stay abreast of the latest discoveries in the periodontal treatment. But at the same time, NSPT remains the ultimate currency by which the periodontal treatment outcome is valued. Hence, it is the cornerstone of the periodontal therapy and is still considered as gold standard. Thank you.
Shreya, obviously, like NSPT is the cornerstone and the gold standard of all periodontal treatment. But as you said, like in this difficult time of COVID, can we take this NSPT as a gold standard for all types of periodontal patients?
Sir, it has been reported, sir, even in the long back, sir, the studies which are stated in the 1933, even in the advanced lesions also, sir, this NSPT in the long follow-up studies also, sir, till 5 years. It has been stated that this both the surgical and the non-surgical aspect has both the attachment, clinical attachment level of near about same with a difference of only about 0.02 mm, sir.
Depending on the pocket depths?
Yes, sir. Reduction in the pocket depth, sir. And also in the clinical attachment level gain, sir.
Say a pocket depth of 8 to 10 mm also?
So we can proceed with the NSPT, sir, and with the meticulous means maintenance of the patient, and by repetitively NSPT, we can maintain it, sir. And there are cases which have shown the promising results, sir.
Right, right.
Okay.
Next one.
So very good morning. Am I audible, sir?
Yeah, Dr. Bhavani, you can continue.
Yes, sir. Very good evening to one and all present. Myself, Dr. Bhavani. I'll be presenting a case report on Bansal technique, a surgical approach for the management of bone defect in the anterior teeth. Before we go into the details of the case presentation, I would like to give a brief intro. The essential elements to be considered in anterior aesthetic mainly includes the contour of the interdental tissues as well as the color and texture of the keratinized tissue. So whenever we are considering a periodontal therapy for maxillary anterior teeth, careful consideration has to be given for the aesthetic results along with the eradication of the disease. In the literature, there have been various surgical approaches that have been proposed to preserve the interdental tissues to obtain a primary wound closure. Such techniques include papilla preservation, modified preservation, and simplified papilla preservation flap. In the year 2009, Bianchi and Bassetti proposed a Bansal technique which is specifically designed for the treatment of wide intrabony defects in the aesthetic zone. So proceeding with my case report, case presentation, a 23-year-old female patient, healthy patient was referred from Department of Orthodontics for periodontal evaluation. The patient initially reported with complaint of spacing between her upper teeth, and on clinical examination, we noted a midline diastema. On probing, there was a 9 mm periodontal pocket in the right maxillary central incisor associated with grade 1 mobility. As such, there were no signs of trauma from occlusion. On radiographic examination, we could appreciate a vertical bone loss in relation to the mesial aspect of right central incisor. So the case was diagnosed as a chronic localized periodontitis. A thorough scaling and root planing, that is a phase 1 therapy, was carried out with proper oral hygiene instructions given to the patient. But due to the persistence of deep periodontal pockets, we decided to surgically access the area for management of osseous defect. A whale tail technique was employed for the same. After administrating adequate anesthesia, two full thickness vertical incisions were traced from the mucogingival line to the distal margin of the tooth neighboring defect on the buccal side. Then a horizontal incision joined the apical margin of the first two incisions in the form of whale's tail, and the coronal margins continued intracircularly. These incisions allowed us for the proper flap reflection and visualization of the defect. Then we debrided the area, curated and root plane. The defect was filled with an allograft material and PRF membrane was covered. The flap was repositioned back and the suture were placed without any tension. Post-operative instructions and medications were prescribed for the patient, and the patient was revisited on the 7th day for suture removal. The recall appointments then were scheduled at 1 month interval to assess for the post-operative healing and the plaque control. At 3 months post-operative review, we could see areas of inflammation, area free of inflammation without any gingivalization, and there was also a reduction of probing depth from 9 millimeter to 6 millimeter. But unfortunately, due to the current pandemic situation, we could not follow the case after that. So we can conclude that the surgical technique employed here could give good aesthetic and functional outcomes. Thank you.
Any particular reason, Dr. Bhavani, why did you choose the whale tail technique in this?
So there was a midline diastema and wide interdental space. So that seemed to be an ideal case, sir.
And what was the cause of that?
Papillum.
What was the cause of that midline diastema?
So cause as such was not noted, sir. Like there was mild tongue thrusting that was noted.
It appears to be an aberrant
people
frenum also. It appears to be aberrant frenum. I am not aware.
But no, sir, the tension test was negative.
Contraindications for whale tail technique?
So if the interdental space is less than 3 millimeter, like wherein we cannot reflect a flap from buccal to palatal aspect. So
any advantage of whale tail over the papilla preservation?
Yes, sir. Like the flap, it is more convenient to perform, and the incision, like since we are placing it at a distance from the defect area or the bone graft material, there will be less bacterial colonization of the biomaterial, sir, which most often result for failure of regeneration and which cause recession.
Go on to the last one.
Thank you.
Good morning, sir. Am I audible, sir?
Yeah, sure. You continue.
So good morning. My case presentation is on laser removal of pyogenic granuloma. Pyogenic granuloma is oral soft tissue masses. It's mainly commonly seen in 75% in gingival area and less commonly in palatal area. And then it is a conventional surgery. As a pyogenic granuloma is non-neoplastic lesion, it can be treated by conventional excisional conventional surgeries, but it has its complications such as intraoperative bleeding, difficulties in wound healing and maintenance in sterility of surgery. Alternative approaches such as diode laser have been safely indicated as it provide clean incision of the tissues, vaporization, curettage, blood coagulation and hemostasis, faster healing and less suturing was seen as its advantages. So objective of this report is to present an unusual case of pyogenic granuloma occurring in palatal aspect of maxillary right first and second molar region, outlining its clinical and histopathological features and its management with diode laser, and it with follow-up of 3 months. Methodology as gadolinium aluminum arsenide 980 nm diode laser has been used for the excision of lesion. This is first lesion is reddish pink in color and is exophytic, well-defined pedunculated growth measuring from 15 into 15 mm. It has irregular margins and its consistency was pseudomembranous and with some areas of erythema, and bleeding on probing was present. Then its management was seen that its lesion was a small, so excision of lesion with diode laser was opted using 400 micron fiber optic tip, and histopathological examination, then the lesion was sent for the histopathological examination, which suggested that its lesion is a pyogenic granuloma, and in clinical outcome, immediate post-op, it's seen that lesion was first that lesion bleeding was stopped, and then after follow up after 7 days, that satisfactory healing was seen, and in follow up of 3 months complete healing was seen. So conclusion and result of this report is that patient reported no pain after the surgery and did not use any systemic antibiotic, and healing process was desirable as seen in 7 days, and complete healing was observed in 3 months with no recurrence of the lesion. Therefore, diode laser can be effectively and safely indicated for oral soft tissue surgeries and can minimize the recurrence rate of pyogenic granuloma. Thank you.
Lavanya, while seeing the case for the first time, what was your differential diagnosis?
Sir, it's differential diagnosis can be, sir, hemangioma or peripheral pyogenic granuloma.
So if it was a hemangioma, did you do something else before starting with the treatment? Say it was a hemangioma and you started with say straight away a laser removal. So might be there would be a lot of complications which you could have encountered, or might be it's a carcinoma also.
Yes, sir.
So straight away you took it as a pyogenic granuloma, took a laser and did the excision?
Yes, sir.
So, you have to be careful in future, I would say.
Yeah,
it was your luck that it was a pyogenic granuloma, but if it was something else, a carcinoma or an hemangioma, it could have been disastrous then.
Correct. Did you encounter bleeding while using the laser on this tissue?
Yes, sir. Sorry, sir.
Did you encounter bleeding while operating on this tissue?
Yes, sir. Sir, bleeding was there, sir. Yes, sir.
Because laser has to be used very effectively in such cases, as sir said, without going for histopathological examination. You're excising the tissue.
You could have done an incisional biopsy first and checked it and then gone in further treatment. Anyways, thank you, the head office, for making us the chairpersons, and sorry Jyoti and Sakshi for eating say 15-20 minutes of your session, and I hope you will cover up the 15-20 minutes, and thank you all the participants for presenting.
No issue, sir. No issue. Good morning to all.
No issue.
Thank you.
Good morning. Good morning, sir.
For such a flawless coordination. Thank you, Wama Events. Thank you so much. And I think you, Jyoti and Sakshi, you can straight away start with the session, because technical hiccups बच्चों के साथ थोड़े बहुत आ रहे हैं. हमारी तरफ से नहीं है, वामा की तरफ से नहीं है. Right. Thank you, GP. Thank you so much.
Thank you, Dr. Guru Prakash. Thank you, Dr. Manish.
Right. Thank you, Dr. Vivek.
Yeah.
I would like to thank the chairpersons and express our gratitude for sparing their valuable time for the session. Now, moving forward to the next session, I would like to take immense pleasure in welcoming our chairperson. Our first chairperson is Dr. Sakshi Garg. Ma'am is the fellow of International College of Continuing Dental Education and has served as ex-professor of periodontology in DRS Dental College. Ma'am is the clinician presently. We welcome you, ma'am. Our next chairperson is Dr. Jyoti Gupta. Ma'am did her graduation from SGRD Amritsar and post-graduation from GDC Amritsar. Presently, she is working as assistant professor in the Department of Periodontics, Dental Institute, Punjab University since 2007. She has attended various national and international conferences and symposia pertaining to her field of specialization and has chaired many scientific sessions. She has also been an active member of organizing committee of various national symposia and conventions. She has to her credit more than 20 research paper publications in international and national journals and a number of paper and poster presentations. She has been extensively involved in epidemiology related research work and has worked as a co-investigator in different research projects from time to time. We welcome you, ma'am. I would now request our chairperson to kindly chair this session.
Good morning, Dr. Sakshi.
Good morning, Jyoti ma'am. How are you?
I'm fine. Good morning to all. I think let's quickly start up with the presentation
Yes,
session
yes.
as we are already running late. So the first presenter, please come up.
Hello, ma'am. Am I audible?
Yeah, you are audible.
Okay. Good afternoon. Good morning, everyone. Today I'm going to present a poster on the topic single-stage surgical procedures for increasing the depth of the vestibules and the width of the attached gingiva. We have done this with an aim to increase the width of the attached gingiva and the vestibular depth in vestibular depth. So a patient came with a complaint of pain and bleeding gums in the lower anterior tooth. Since last 10 days, he is 25 years old. And after going the examination, oral examination, we have found out that the patient has subgingival calculus deposits with gingival enlargement with erythematous gingiva. And we have also ruled out that there is bleeding on probing also. And there is gingival recession of Miller's class 3. Then after undergoing several examination, we have concluded with a treatment plan of oral prophylaxis with vestibular deepening. So on the first visit, we have done oral prophylaxis followed by root planning of the in these patients, and we have given gum astringents and the mouthwash. And after 7 days follow up, we have planned for vestibular deepening surgery. So first of all, we have given the horizontal incisions after the administrations of the local anesthesia and after preparing the both intraoral and extraoral side of the patient with the betadine swab. Then we have give the mental nerve block on both of the side and then followed by the horizontal incision or circular incision. Then after the circular incisions, the muscles is dissected followed by the fenestration, creation of the fenestration, and then irrigation is done in the operating site. After that, a suture is given, interrupted suture is given on this patient, followed by periodontal pick, and then the patient is sent. Then we have given the analgesic and antibiotics, and even we have given the post-surgical instruction to the patients also. And after the 7 days post-operative, we have seen that the attached gingiva, there is regaining of the attached gingiva about like 4 mm. Then after that, we recall the patients after 1 month also, and we can see that the healing is already done, and the scarring is also reduced, and healing is done by the secondary epitheliations. And in conclusion, we can conclude that an adequate attached gingiva and a vestibular depth is obtained, preventing the further gingival recession of these patients. Thank you.
Dr. Sinam, what was the gain in the attached gingiva? I mean, what was the preoperative width and what is the width now after the surgery?
Okay, ma'am. First, it is only like 2 mm of the attached gingiva width, but after the post-surgery, it is the attached gingiva is gained up to 3.5 mm.
Of 5 mm. Have you put up any, I mean, you haven't put up any slide regarding the measurement showing the attached gingiva earlier and attached gingiva after the clinical surgery. Do you have a long follow-up for this case? It's just a 1 month follow-up, no?
Yes, ma'am, we have the follow-up, but actually the photograph was not clear, so we are not able to put it, ma'am.
Was the gain what you have, what you are saying is sustained at 6 months?
Yes, ma'am. Sorry, ma'am.
The gain what you have achieved after the surgery was sustainable at 6 months follow-up?
Ma'am, yes, ma'am.
Dr. Sakshi?
Sinam, what were the problems that you were facing because of this shallow vestibule and inadequate width of attached gingiva? What was the problems that patient was facing?
Ma'am, patient was already complaining about halitosis problem also, and he was having a bleeding problem. And those are the common layman problem that they come to the office. And after that, after doing a thorough examination, we only concluded that we have to do such and such treatments. We have to make the patient sit down and understand what we are trying to say, because right away patient are not even willing to do the.
No, so my question is that you did this surgery just to treat the halitosis.
No,
No,
not only
ma'am, because of the
halitosis,
gingival
but the
recession.
patient came with the like complaint that he has halitosis and he is having gum bleeding problem. That is what patient comes to the clinic.
So what are the main problems that are faced by the patients due to these vestibular depth, shallow vestibular depth and
Since the
inadequate
patient cannot
attached gingiva?
Since the patient cannot.
What is the main problem? What is one main problem faced by a
Oral
patient
hygiene.
with shallow vestibule depth?
Oral hygiene maintenance, ma'am.
And another thing?
And recession, ma'am.
And mastication problem. So you've not used any separating media, right? I see your surgery point. You're not using any separating media, no lead foil, nothing that you have used here.
I was concerned about the post-operative sustainability.
Yeah, that's what. That's what I was thinking.
Which technique have you used here?
Ma'am, actually aluminum foil was placed before putting the periodontal peg, ma'am. But it was not shown in the photos, ma'am.
You do not have a 6 months follow-up. You do not have a picture for the lead foil. How do we see it?
ठीक है, next proceed करते हैं.
ठीक है, next चलो.
Next please.
Ma'am, am I audible?
Yes, yes.
Good morning to all and everyone present over here. I'm Priyanka from Maharishi Markandeshwar University. On the screen, you can see a poster which shows a case of surgically managed buccal exostosis. Exostosis are bony masses present mainly on the buccal aspect of premolar or molar tooth region. They are also seen on the buccal aspect of mandible or the palatal aspect of the maxilla. When they are seen on the lingual aspect of mandible, they are also known as tori. They are commonly found more in men than women and tends to appear in early adolescence. They are painless, self-limiting, which usually do not require intervention until it starts affecting periodontal health or the aesthetics of the patient. As in this case, in the preoperative view, the patient was having abscess formation in relation to 1.5 and 1.6, which provoked us to rule out the diagnosis for exostosis after detailed and thorough examination. But not every bony swelling is exostosis because it either increases very slowly in size or may not even increase. But if this bony growth has a tendency to grow in size at a much faster rate, then careful diagnosis should be done, which can be a very fibrous lesion or any syndromes related or any malignancy. In the lower left and middle part of the poster, you can see that the exostosis was removed after reflecting the flap by performing resective osseous surgery in the first quadrant of the patient, whereas the same extra growth of the bone present on the second quadrant was initially dissected and then placed as an autograft along with advanced platelet-rich fibrin membrane to cover a small bony defect present above the premolar tooth region. This case resulted in the successful restitution of the physiological bony contour without any untoward complications, with preventing further loss of periodontal health of the patient. And being in such a wonderful and versatile branch of dentistry, it's my duty to give the patient a healthy and an elegant smile. Thank you so much. That's all.
Thank you, Priyanka.
Do you have, Priyanka, do you have a pre-op IOP related to this region?
Pardon, ma'am?
Pre-operative IOP X-ray related to this region?
Ma'am, pre-operative, ma'am, I have the OPG of this. IOP also I have, ma'am, but it is not clear, actually.
So what do you do with that periodontal abscess, the abscess which was associated this buccal exostosis?
Yes, ma'am. Ma'am, when the patient first came in the OPD, he was having swelling over there. So after curettage, after 1 week recall, again he was having problem in that tooth, and the probing depth was almost around 5 mm. It was not getting resumed after the treatment also. So after thorough and detailed examination, we found that it was a deep pocket, also 5 mm, and then we reflected the flap. Then we found that there was a bony mass present in that region in
What
between.
was the follow-up period after the treatment of abscess?
Ma'am, it was actually we told the patient to come after 10 days, but then again he came back after 1 week saying that again there was pus discharge and he was having pain in that region, ma'am.
So what was the reason? क्या किया आपने? What did you do when the patient came back again after 7 days with the
Ma'am,
same problem?
Ma'am, then we after proper clinical examination, then we reflected the flap in that region. Then we found out that it was because of the food lodgement due to presence of the exostosis also.
और क्या किया आपने? Any other line of treatment that you gave?
Ma'am, for the abscess or for the exostosis?
For both. Tell me. After 7 days, both the problems were almost the same as they came as on the first visit.
Yes, ma'am. Then we thought of, ma'am, reflecting the flap and remove the exostosis with a proper dissective osseous surgery and maintaining
So
all
the
the
point is,
protocols.
जो आपने the case that you have presented, basically the line of treatment was not effective. You mean to say? After 7 days, the patient came with the same problem.
Yes, ma'am. Actually, he was having the same problem after 1 week also.
So was your treatment successful or no? Yes or no? Just yes or no?
Yes, ma'am. Yes, ma'am. It was successful. After when he came after 2 months, it was the contour and the swelling. Everything was gone on all the aspects of the maxilla and mandible, and he was having
All
a
right.
proper
Thank you. Thank
physiological
you.
well-being. Welcome, ma'am.
Thank you. Thank you. Chalo. Next,
Thank you.
please.
Hello, ma'am. Am I audible?
You are
Yes.
Respected judges and dear panelists and delegates, good morning to one and all. Today I am presenting my poster on a case report titled Localized Alveolar Ridge Augmentation Using DFDDA Bone Block Graft in Treatment of Labial Dehiscence. This is an interdisciplinary approach between orthodontic and periodontic disciplines, respectively. The alveolar bone dehiscence is a loss of alveolar bone in the facial aspect of the tooth, where the continuity of the marginal bone is lost, resulting in root exposure. This case is that of a 15-year-old female patient who had reported to the Department of Orthodontics for the management of completely impacted tooth. Upon taking an OPG, it was revealed that the impacted tooth was inverted and had crown facing occlusely. Patient gives a history of trauma to the anterior teeth region as well. And after 1 year through the orthodontic therapy, it was noticed that the teeth was not moving, even upon the application of closure. Therefore, the CBCT to the anterior teeth was carried out, which revealed labial bone dehiscence in relation to Then later, the patient was referred to Department of Odontology. Here, she underwent calf elevation through thorough debridement, and the FTBA bone block graft was placed on the exposed tooth surface of T1, followed by placement of amniotic membrane. When the flap was repositioned and sutured, the patient continued with the proposed orthodontic treatment after the healing period and exhibited movement 4 months after the procedure. Study the patient, the study concluded that the FDDA bone block graft resulted in excellent management of ridge augmentation with optimal functional and aesthetic outcomes. This patient also gave a history of trauma to the tumors.
Yes, Radhika. Was your block graft stable over the area where you had placed it?
Yes, ma'am. We have placed the block graft and followed by amniotic membrane and suture deployment. We gave vertical releasing incisions so we could stabilize it.
Is this the treatment of choice for labial plate gain? Radhika?
Yes, ma'am. Yes, ma'am.
Is this the treatment of choice?
Yes, ma'am.
What is the others way? What मतलब alveolar ridge augmentation के अलावा और क्या use कर सकते हैं आप for labial plate gain? You've treated labial dehiscence now.
Yes, yes.
So is this the ideal treatment of choice for labial plate gain?
Ideal, ma'am. We did the treatment with using this procedure.
Sorry.
Your
carried out
voice is not at all clear even during the presentation also. No, I was
your voice is crack कर रही है voice ना.
To get anything read correctly. I could only read your poster. Yes, please answer it fast.
Yes, ma'am.
Do you know the answer, Radhika? Please tell us.
Any other techniques?
No, ma'am. This bone block graft technique only we carried out now.
On this patient, this was the only treatment that could be carried on?
No, ma'am. There are
no other treatment choices. What are these? What are those? Please tell us. Thank you, Radhika.
Thank you.
अरे पीछे कौन है? बुक में से देख के थोड़ा ना बताना है.
Hello. Hello.
Yes, please. You are audible.
Hello.
Yes.
Hello. Ma'am, am I audible?
Yes, you are audible.
Okay, shall I start, ma'am?
Yes, please.
Okay. Good afternoon. My presentation is on management of peri-implantitis in aesthetic zone. We have two cases here. In both the cases, the similarity, on the left-hand side, the cases, there was an implant, a patient came with an implant fenestration on the buccal side, where once exposed, we found out that the prosthesis was way infrabony, which caused, and there was a very thin gingival tissue, which caused severe bone and soft tissue resorption. In the case 2 on the right hand side, immediate implant placement was done 1 week back, and after 1 week we found out that there was complete buccal bone loss, and once exposed, as seen in this picture, there was severe buccal bone resorption. After in the first case and the second case, we had a very similar treatment approach. Though in the first case, because the case was done 5 years back in a different institution, we could not retrieve the implant and could have done a replacement. So what we attempted to regenerate the bone using Bio's bone graft, which is an osteoconductive material. And after placement of BioGuide collagen membrane, we sutured it with a non-resorbable silk suture. In case of case 2, we because of the implant placement was done just a week back, we retrieved the implant and placed it more palatally, as the palatal bone was thick. The placement was done, as in the third picture, the placement was done more palatally, unlike which was more palatal to the socket of the tooth. And then again, similar approach as the first case, we placed bone graft placement with a GTR membrane and sutured it back. In both the cases, we have attempted to regenerate the buccal bone plate in the aesthetic zone, and unfortunately, we could not have a follow-up early due to the current COVID situation. But we are attempting to, we are hopeful to see bone regeneration, and will proceed with further soft tissue regeneration in case of the case 1 to regenerate the thin gingiva, which to cover up the fenestration. That. Thank you. Hello. Yes, ma'am. Hello.
Vidushi, can you please switch
Yes,
on
ma'am.
your video?
Yes, ma'am. 1 second.
Yeah. Hanji, Jyoti ma'am, please.
Yes, ma'am. Hello.
Ma'am, you are not audible.
Ma'am.
Ma'am, unmute karo.
Hanji, am I audible?
Yes, ma'am.
Hanji. Vidushi, I was asking you that you might be in contact with the patient telephonically at
Yes, ma'am.
least.
Yes, ma'am. Yes,
So,
ma'am.
are you aware whether the implant in the case 2 survived?
Yes, ma'am. They both of them are surviving and they're both doing well. I have been in touch with them constantly because for past 1 month I was in COVID duty, so I was unable to approach them personally through. But on video call and phone call, I was constantly in touch with them, ma'am.
Okay. So, do you think the type of defect which has been created in the case 2 could have been avoided?
Ma'am, yes, ma'am, they both could have been avoided with proper implant placement. In case of case 1, actually, ma'am, what happened, the patient had undergone this treatment in elsewhere. So when the patient approached, he approached with the
We are
gingival.
not discussing case 1 because it was not,
Yes, ma'am. Yes, ma'am.
done.
We are just attempting to.
Yeah,
Yes,
but
ma'am.
in case of immediate
Yes,
implant.
ma'am. Yes, ma'am. In case of immediate treatment, what happened was he placed it inside the socket, and there was a periapical infection in the in the tooth, which was extracted. So mostly it was because of the periapical infection which caused the bone resorption. It instead of putting it directly into the socket, it should have been placed more palatally initially itself. But because we attempted to place it inside the socket as immediate implant is done, this problem was we faced this problem. A socket shield technique could have been used, but because the tooth had a large periapical infection, we had to completely curatize the area.
Yeah, the treatment planning could have been better.
Yes, ma'am,
Right,
definitely.
Dr. Sakshi,
So
please.
Did you use any anti-infective therapy along with
yes,
this?
ma'am. Yes, ma'am. We
What?
Anti-infective
What is the
therapy.
ideal? What is the ideal anti-infective therapy which is recommended and who give it? बताओ.
Ma'am,
इस केस में क्या देना चाहिए था और what was it? Ideal क्या है?
Ma'am, systemically and locally we had done, don't know what the ideal is, but ma'am, systemically amox and metronidazole combination medication was given to the patient for 1 week. And locally, ma'am, betadine irrigation was done, and disinfection of the debridement of the implant surface, ma'am, was done. These are the 2 anti-infective I can think of, ma'am.
ठीक है, next
Well,
proceed.
that is not. हाँ, चलो ठीक है.
नहीं, please take.
नहीं, ठीक है, but it is not the right answer. But I was just saying. ठीक है, ma'am. Thank you, Vidushi.
Thank you, ma'am. Thank you.
Good morning, ma'am. Am I audible?
Yes, please.
Good morning to everyone. The title of my poster presentation is Unraveling the Pigmented Puzzle, Melanocanthoma, a Case Report. Melanocanthoma is an uncommon reactive pigmented mucocutaneous lesion that is characterized by presence of keratinocytes admixed with dendritic melanocytes. It is more commonly seen in the black populations with more of a female predilection, but that is around 1:2, and it is seen in 3rd to 4th decade of a life. The buccal mucosa is the most common intraoral site that is seen in approximately 51.8% of the population, and the gingiva is the least common site of oral melanocanthoma. The oral lesions clinically represent as a smooth macule or a papule with a color variation ranging from brown to black. Coming to the case presentation, a 60-year-old male patient reported to the Department of Periodontics with the chief complaint of pigmentation in the gums of his lower arch. He reported the pigmentation 1 month ago when there was a dislodgement of prosthesis in the forceps region. The picture A is showing the preoperative lingual pigmentation of the patient extending from 3-7 up to the 4-7. The pigmentation was smooth, non-tender with irregular margins involving the attached and the free gingiva. The picture B is showing the front buccal view in which the pigmentation was extending from 4-2 to 4-7 region. The extraoral examination revealed no findings. The patient denied of any cutaneous pigmentary lesions also. To confirm the diagnosis, incisional biopsy was performed in the region 4-2 to 4-5 from lingually, and this is the picture of gross specimen shown, and it was sent for the histopathological analysis and immunoreactive analysis. Masson-Fontana S100 and HMB45 analysis were done. And to address the patient's aesthetic concern, depigmentation with the diode laser was done under local anesthesia in the region 4-2 to 4-5 buccally, labili. In the microscopic examination, it revealed that the tissue was hyperplastic, hyperorthokeratinized, stratified squamous epithelium with spongiosis and mild acanthosis, and there were numerous dendritic melanocytes present, which were widespread and mostly densely placed in the basal layer. In the picture C, it is in the 100x magnification. We can appreciate better melanocytes there. They have a brownish cytoplasm and melanosomes. The picture C, D, and E respectively are the Masson-Fontana S100 and HMB45 positive stains. The 1-year follow-up show no recurrence. And to the best of our knowledge, this is the first reported multifocal gingival pigmented melanocanthoma reported in an Indian male. The etiology can be attributed to local chronic irritations or mild trauma. In this case, fixed prosthesis was the reason. The differential diagnosis includes melanoma, acquired melanotic nevus, oral melanotic macule, post-inflammatory lichen planus, hematochromatosis, or smoker's melanosis. This is the table of reported gingival melanocanthoma so far. And to conclude, taking everything into account, gingival melanocanthoma is an uncommon finding, and it should undergo histopathological examinations to rule out any malignancy. And this case report underlines the relevance for clinicians to consider this in a differential diagnosis of multifocal gingival pigmentation. Thank you.
Thank you, Jaya.
Thank you, ma'am.
Yes, Jaya, what prompted you to take a biopsy of this patient?
Yes.
Ma'am, because the pigmentation was widespread. Ma'am, am I visible?
Yeah, you are visible.
Ma'am, the pigmentation was widespread, and the patient was very concerned about the pigmentation, and because it was irregular and widespread both in the buccal and the lingual region, and the look is already masquerading, and the patient was concerned. What is this? And to rule out the malignancy chances or melanoma, we did an incisional biopsy.
Was it present on the buccal mucosa too?
Yes, ma'am. No, it was absent on the buccal mucosa. It was just present on the gingiva,
Gingiva and more so
lingual.
on the lingual arch.
And ma'am, it was it was involving more of the lingual arch from 3-7 up to the 4-7, and labally it was extending from 4-2 to 4-7 on the right side.
What you have presented in this table, which is just before your conclusion part.
Ma'am, these are the reported cases of gingival melanocanthoma.
Okay, so yours is the first in Indian.
Yes, ma'am, in an Indian population,
Indian
and ma'am, it is a very rare finding also, because it is very uncommon in Asian population. It is more common in blacks. Along with that, it has a more of female predilection. Approximately half, 1:2 is the ratio. And plus, ma'am, the gingiva is the least rare finding because it more commonly occurs on the buccal mucosa, followed by palate and tongue, and it is least on the gingiva. So it is a rare of its kind.
It is not the first case in India. The first case in India was reported in 2009.
Ma'am,
Alright.
it was on the buccal mucosa.
And the other thing, what did you tell ki histopathological examination mein, what did you see?
Ma'am, there was a hyperplastic, hyperorthokeratinized epithelium along with spongiosis and acanthosis. And plus, ma'am,
But generally the histopathological examination for this melancanthoma, it shows non-keratinized epithelium.
Ma'am,
if you will go through your histopathological book and details, you are saying it is orthokeratinized, but according to me, it should be non-keratinized.
Ma'am, there have been cases.
I might be wrong. I might be wrong. I might be wrong. You can please tell me.
Ma'am, there are various case reports and review of literature in which hyperkeratinized mucosa was also seen. Ma'am, it was present along with the other features.
All right. Thank you. Thank you.
Thank you so much, ma'am.
Tooth whitening.
Good morning, everyone. Am I audible?
Your title is a little different from what I have here.
No, I have sent it the same, ma'am, the comparative evaluation of efficacy of teeth whitening agent with and without diode laser, a split mouth study.
Okay, fine. Shivani. Okay.
Yes, ma'am. Good morning, everyone. I am Shivani Lanjeva. Today, I am presenting poster on topic comparative evaluation of efficacy of teeth whitening agent with and without the diode laser, a split mouth study. The Synergy gel is a new teeth whitening agent which claims to cause no sensitivity, high efficiency, and ease of handling. The gel contains carbamide peroxide, calcium carbonate, titanium dioxide. This unique combination also have high water release capacity, which helps in causing no sensitivity. Also, it generates free calcium ion, which helps in remineralization during the teeth whitening process itself. Also, titanium dioxide helps to increase in the effectiveness of the teeth whitening. The split mouth design was used for teeth whitening for better comparison. As in here, my test group is the left side of the left maxillary anterior, and I use the Synergy gel along with the indocyanine green dye, which was applied on the teeth surface with an applicator. The laser activation was done for 2 minutes of 4-volt power. On my control group, I used the Synergy gel along with the indocyanine green dye application, and it was applied on the tooth surface with an applicator tip. On the post-operative, the shade was checked with a Vita shade guide, and the result I got was A1 shade for the test group, whereas B2 shade for the control group. The 1-month follow-up was done to check the tooth stability. Here, the result I got was A1 for both the groups. Both groups showed similar tooth whitening shade with and without diode laser, indicating that laser has increased the efficiency of the teeth whitening for the short duration of the time. Here, I want to conclude that the Synergy gel enhanced the tooth shade of the patient effectively with or without the diode laser. Thank you.
Shivani?
Yes, ma'am.
It might be an over comment, but what I can see in your immediate post-operative photograph, your control group is not actually matching with B2. अभी आप टेस्ट ग्रुप में अपने A1 के साथ मैच हुआ है, So जो control group है उसमें भी B2 is a darker shade as compared to what is there in the intraoral that finding. If you can see this 1-1.
Oh, yes, ma'am. But ma'am, actually, when we compared, it was coming B2. I think the photographs are like the angulation
Probably it
of the
might
photograph.
be, it might be so, but
Yeah.
the thing which is depicted here is B2 is a bit darker shade.
I
if
can't
we
hear you.
compare.
Ma'am, am I audible?
Yes, you are audible, Shivani. Dr. Sakshi, am I audible to you? Dr. Sakshi? I think there is some problem at her end. Okay, so after 1 month follow-up, the conclusion is that
Hello?
that is not. Yes, you are audible. Yes, Dr. Sakshi, you are audible. Okay. So what is the effect of laser otherwise for tooth whitening? What is the action of laser?
Ma'am, laser, here the dye was used, it activates the dye and the more singlet free radicals are released, which help in the oxidation of the discolored molecule, which helps in increasing the tooth shade.
Okay, fine. Dr. Sakshi?
Thank you, but no questions.
Okay.
Thank you so much, ma'am.
Next, please.
Good morning, ma'am. I'm audible.
Yes, you are audible.
Yes.
Will I start?
Yes.
Oh,
Please.
Good morning.
Yes.
Good morning, to all. My case report is on socket shield technique with immediate implant placement in anterior maxilla. Case report. Coming to introduction, it is fairly common to remove a severely compromised tooth and provide a rehabilitation by means of an implant. So resorption of foliar bone after extraction resulting in the loss of bone height and width is an unpleasant sequelae causing the difficulty in implant placement. So there are also evidence on long-term predictability of socket shield technique, which enables its use in preventing the buccal cortical bone resorption. So case report, 20-year-old, 21-year male patient came to department with a complaint of loose teeth in the upper front tooth region, and also give a history of trauma in that region. So the objective of this study is to assess the role of socket shield technique in maintaining the aesthetic in the immediate implant placement. Coming to the methodology, the case report describes the rehabilitation of a fractured right maxillary central incisor using this technique. So the root was central maxillary incisor was sectioned in such a way that the fragment of the root, that is we call a shield, is left attached to the labial bone. If the remainder of the root is completely removed, and the immediate implant was done lingually to retain the root without contact with the root fragment, and the pink and white aesthetic score were assessed. So these are the pre-operative measures, and the image shows the fractured crown. So the root was sectioned, leaving a buccal fragment, and the implant was placed, and the provisional restoration was given after 2 days. And these are the post-operative measures after 4 months. Coming to discussion, so in this report, socket shield technique was used in an area where the buccal cortical plate was thin by keeping a root fragment attached to the buccal bone. The placement of immediate implant maintaining the wrist contour, and no post-operative complications was seen, and healing was eventful. So the jumping gap was less, that is between 0.5 to 1 mm. So there is not given any bone graft in the space, and the pink and white aesthetic scores was 9, 8 and 9 respectively. Coming to the results, also this case report of immediate implant placement with socket shield technique shows a good preservation of the attached gingiva in soft tissue tooth, which enhance the aesthetic. And this technique show a promising result in the preservation of the post-extraction socket and holds a significant role in implant and aesthetic bending. Thank you.
So Varun,
Yes, ma'am.
how do you how did you perform the sectioning of the root in this case?
First, the tooth was decoronated, madam. So the crown was removed, and with diamond we have vertical.
Your voice is not clear. Please be a bit loud, please.
The vertical sectioning of the root was done first, madam.
Hmm.
And the lingual portion, that is, gave a oblique sectioning was done, and the lingual fragment of the root was removed.
Okay. The results are good. Emergence profile and aesthetics are good. Dr. Sakshi? Dr. Sakshi? It's okay. Let's move on. Yes, please.
Good morning, ma'am. Can I start the presentation, ma'am?
Good. Yes, please start with the presentation.
Good morning, everyone. Myself, Dr. Pratyusha. I'm going to present case report on the treatment of the grade 2 furcation involvement with a solitary abscess. To introduce treatment of the furcation defects, especially the critical side, is a main challenge in clinical practice, and treatment options vary according to the location and type of the defects. Regenerative procedures are one of the approaches for the treatment of the furcation defects. A 50-year-old systematically healthy male patient reported to the Department of Periodontics and with a swelling in the right buccal mucosa, and it was diagnosed as periodontal abscess in relation to forceps. Abscess drainage was done in relation to forceps, and patient was recalled after 1 week. And the clinical and radiographic examination revealed that the grade 2 furcation involvement was present in relation to, and the regenerative procedure was carried out with the Korean membrane and hydroxyapatite granules and collagen bone graft, that is also known as G bone graft, and the post-operative instructions were given to the patient, and patient was recalled after the 2 weeks for suture removal and for re-evaluation. The first picture is the pre-operative view of the patient, and second picture is the pre-operative view of the IOPA in relation to forceps, and after flap reflection, G bone graft and Korean membrane was placed, and it was sutured with interrupted sutures, and the periodontal dressing was given, and the patient suture removal was given. Suture removal was done after the 2 weeks, and this is the post-operative picture of the 2 weeks, and it is the post-operative IOP after the 2 weeks. And the clinical observation is that the successful regeneration at the furcation sites is determined by the reduction of the horizontal or vertical components of the lesion. A study done by the Cotival et al. Has shown that he had treated the grade 2 furcation involvement with the Korean membrane, and he had shown that the Korean membrane has additive anti-inflammatory effect along with the improvements in clinical outcomes. Based on these results, I can conclude that the combination of the Korean and the hydroxyapatite and collagen granules, that is G-bone graft, can be successfully used in the treatment of the grade 2 furcation defects. Thank you.
Thank you so much.
Is the presentation over? Actually, I got disconnected in between.
Yeah.
Am I audible? Am I audible?
Yes, ma'am. Yes, ma'am.
Okay. Pratyusha, what was the mobility in this tooth pre-op?
Preoperatively, it was grade 1 mobility was observed.
Grade 1 mobility. Okay. So how long did you wait after the drainage? Recalled after 1 week.
Abscess drainage was done, ma'am, and the patient was recalled after 1 week, and the abscess was slightly reduced, and then again I did abscess drainage, and the patient I have given appointment after 1 week, and the patient abscess was again increased, ma'am. Drainage was done through the sulcus, ma'am. And again,
did the patient
UPA was
underlying
taken
medical condition?
at 2 weeks after the abscess drainage, ma'am. Hello.
Did the patient have any underlying medical condition?
Ma'am?
Any underlying medical condition that the patient had?
No, ma'am, he's systemically healthy.
No. And any post-operative complication that you faced? Post-operative complications.
No, ma'am.
ठीक है. Ma'am, any questions? ठीक है. Thank you. Thank you. Next.
Thank you.
Can we have Dr. Hiral's presentation? The one prior this?
Yes, ma'am. Am I audible?
Management of.
Yes, you are.
Am I audible?
Yes, madam.
Yes, 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 yes.
Yeah. So good afternoon, my presented faculty members and my dear friends. Here I am presenting the case report on the management of the papillary lesion involving the gingiva and the post-excision soft tissue deficiency correction with periosteal pedicle flap, a case report. So here the squamous cell papilloma of the gingiva is benign, asymptomatic, exophytic, non-plaque associated gingival lesion caused by the human papilloma virus, affects several areas of the oral cavity with lower predilection for the gingiva. Here, the presenting the case report on the squamous papilloma of the gingiva. Objective for this study is identification and management of the papillary lesion involving gingiva and the post-excision soft tissue deficiency correction with periosteal pedicle flap. After excision, there was no keratinized tissue and possible site for the future gingival recession and the periodontitis. So here, plan for the periosteal pedicle flap to prevent expected above problems. Soft tissue deficiency corrected with the periosteal pedicle flap and the resorbable sutures were taken. Here, the histopathologic examination confined the squamous epithelium proliferating in the form of the verrucous or the papillary projection. And he also fulfilled the criteria of the Carnio et al. Histopathologic criteria for the finger-like projections and the hyperkeratosis. Made the diagnosis on the squamous papilloma of the gingiva. On the 1 year of the follow-up, we can see the completely healthy gingiva in relation to the foci, and there is no recurrence has been found yet. Concluding, gingival lesions can be misleading, required identification using biopsy and can be corrected by the periodontal treatment.
Okay, thank you, Viral.
Can you please explain the procedure for this periosteal pedicle flap? What you
Yes,
have done here?
Yes, ma'am. So here, the first of all, a partial thickness flap was reflected by the sharply dissecting the muscle fibers and the tissue from the underlying periosteum, and the strip of the periosteum was removed at the level of the mucogingival junction, causing the periosteal fenestration and exposing of the underlying bone. So here, the care was taken not to remove the periosteal strip completely and leave it attached to the bone and rest of the surrounding periosteum. Out on the contralateral end. Thus, the periosteum remain at the level one end, and hence it's called as the periosteal pedicle flap. So the periosteal pedicle flap on the one end is attached. So it again revascularized, and the normal, we can see the after the 1 year of the follow up, we can see the healthy gingival tissue formed at the site of region of the forefive.
Okay. Dr.
Hiran,
Sakshi.
what is periosteal fenestration? Just one question.
Yes, ma'am. The periosteal fenestration is the deficiency we found at the region of the after excision of any soft tissue, we can found the deficiency at the region of the periosteum. So it's called periosteum fenestration.
Where did you read this? Periosteal fenestration यही होता है? What could be a better line of treatment for this?
Ma'am, yes, ma'am. We can also
a single step surgery. A single step surgery. What would it include? No.
Cryosurgery.
No. ठीक है, thank you.
Okay, ma'am.
Next, please, Dr. Deepika.
Ma'am, am I audible?
Yeah.
Hello.
Yes.
Jyoti ma'am, you can hear her?
Hanji, Hanji.
My greetings to one and all. Hope everyone is hale and healthy. I hereby present a case report on the management of mucosal fenestration caused by buccally dilacerated root. Mucosal fenestration is a clinical finding where a portion of the tooth root is denuded of the overlying alveolar bone, gingiva or oral mucosa, thus exposing the root to the oral cavity. It can lead to problems related to plaque control that eventually lead to root surface caries, hypersensitivity and compromised aesthetics. Case presentation. A 29-year-old female patient presented to our department for routine dental checkup. Oral examination revealed the presence of a chunk of calculus on the upper right buccal vestibular region of 15, 16 and 17. No relevant bony findings were observed on OPG. After initial periodontal therapy, that is scaling and root planing, the mucosal fenestration was exposed through which the two buccal dilacerated roots were visible. An endo-perio interdisciplinary treatment plan was considered for the correction of the defect. After initial scaling and root planing, RCT of 1/6 was performed. Then root resection followed by retrograde filling with GIC was done. The patient was then taken up for further periodontal plastic surgery. Clavicular and vertical releasing incisions were given and full thickness flap was raised in the 1/6 region. The root surfaces were smoothened and blended with the surrounding bone. A connective tissue graft was then harvested from the palatal aspect of the opposite side by trapdoor technique. The graft was positioned on the root surface, the flap was repositioned and sutured. Then a PRF membrane was placed and a periodontal dressing was given. Patient was recalled after 10 days for suture removal and review. The course of the post-operative healing was uneventful and the correction of the mucosal fenestration was noted. To conclude, the successful management of mucosal fenestration requires correct diagnosis and treatment procedures, including adequate debridement of the root canal and reconstruction of the mucosal and the bony defects. This case report demonstrates the potential of periradicular surgery combined with subepithelial connective tissue graft procedure in the management of periapical mucosal fenestration. But further research is needed to demonstrate the long-term outcome of this interdisciplinary approach. Thank you.
So this photograph clinic is after how much time?
Ma'am? Hello, ma'am?
Operative view is after how much time of your surgery?
Ma'am, the
Am I
clinical...
audible?
No, ma'am, there is a lag.
No, ma'am, you're not audible.
Yes. Have you understood the question?
No, ma'am, I didn't hear the question.
I think there is some problem with my net connection. Okay. I was asking, this post-operative view is after how many days, and do you have a follow-up period for follow-up pictures for this case?
Ma'am, the post-operative picture which is shown here is after 10 days, ma'am. 10 days after when the patient had come for suture removal. So that time this picture was taken, ma'am.
Any long-term follow-up?
Actually, the patient became pregnant and she was relocated to Rajasthan during this COVID time. So we were not able to follow up this patient after this surgery.
Okay.
Like we were not able to because she relocated to a different state.
Okay. Thank you so much.
So this is the main thing to see. Results are there, but long-term sustainability of those results is there or not. This we have to see basically in such cases, particularly in the soft tissue surgeries.
Yes,
yes, Dr. Sakshi.
Thank you, ma'am. Thank you.
Thank you, ma'am. Thank you, ma'am.
Okay, let's move on. Is there anything left?
No, I think, ma'am,
I think this session is complete.
Yeah, so we go on to session 4 now.
Thank you for the presentations and broadening our horizon. Now, straight away, we can move forward with our next session. The chairpersons for which are Dr. Sakshi Garg ma'am and Dr. Jyoti Gupta ma'am. I would request them to kindly chair this session.
Thank you, organizers.
Dr. Aziz?
Hello, who's the presenter? Dr. Aziz? Dr. Aziz?
Yes, the name is written this only.
I can see him there also on the delegate list here, but I don't know why he's not speaking up.
Please
Dr.
start with the presentation. Dr. Aziz, you are not at all audible. Please be a bit loud, please.
Louder. I can't hear him, Dr. Jyoti. Can you?
No, I'm not able to get even a single word.
Yeah, same
If there
here.
is some problem with this poster, let's move on to the next.
Otherwise, can we have the next?
Yeah, Dr. R. Nandini.
Am I audible,
Yes.
ma'am?
Yes, yes.
I'm sure I
Nandini,
start,
please.
ma'am.
Yes.
Good afternoon, everyone. Today, I'm going to tell a case report on modified graft dimensions and suturing techniques for free gingival grafting in obtaining predictable aesthetic outcome, which is a case report. Coming to the introduction, the malalignment of the lower anterior teeth, it predisposes to the gingival recession, leading to the loss of the keratinized tissue and reduced vestibular depth. Adequate attached gingiva is necessary for healthy gingival tissue and to deliver orthodontic treatment without adverse periodontal complications. Consideration regarding the normal limits need
to be taken care to avoid the overcorrection for the better aesthetic. Coming to the case report, a 15-year-old female patient was referred to Department of Periodontics with a chief complaint of shallow vestibule from the Department of Orthodontics in our college. The patient has an inadequate attached gingiva and shallow vestibule for placing of an orthodontic appliance. Coming to the aim of this case report is to assess the role of the pregingival graft dimension in obtaining aesthetic width and thickness of the attached gingiva. Coming to the methodology, in figure 1, it is a preoperative picture which is showing off shallow vestibule. And coming to the figure 2, here an horizontal incision is given along the mucogingival junction in the lower anterior teeth, and the recipient bed with intact periosteum is created. And coming to the figure 3, here the mucosal tissue was anchored at the level of the planned vestibular depth using a periosteal horizontal mattress suture. And 4 mm to 1.5 mm thickness of graft is taken from the palatal gingival graft, and it is harvested in this region. The graft is placed in the coronal aspect of the recipient periosteal bed and sutured to the intact interdental papilla and laterally to the periosteum, so that there is no immobilization of the graft. And coming to the postoperative pictures, this is figure 7 and figure 8. Here, figure 7, it indicates after 2 weeks, and after 2 weeks, the sutures were removed. And next, coming to figure 8, it is after 1 month, where we can see a proper healing is there. And coming to the conclusion, prior to the orthodontic treatment, periodontal evaluation must include not only periodontal probing, but also the position and the condition of the attached gingiva. And here the use of the pregingival graft with modified dimension resulted in a predictable aesthetic outcome. And using of this 1.5 mm thickness and 4 mm wide graft, it has resulted in a less patchy appearance, and also better healing has occurred. And the width of the attached gingiva was also increased, and there is very less shrinkage. And it is always better to correct the inadequate gingiva before starting off any orthodontic treatment, so that while doing the orthodontic treatment, there won't be any recession and further any problems won't occur.
Thank you, Nandini. Nandini, why are the first 48 hours after the gingival graft very important?
Ma'am, because during that time vascularization will not occur, ma'am. After the 3 days only vascularization will be appear. And also, so during that time, you have to be very careful, ma'am. If any immobilization will occur, then the chances of better aesthetic outcome and also better coverage will be not there, ma'am. Because of that reason.
How many days are needed to complete the normal thickness of epithelium to come back?
Huh?
How many days are needed for the normal thickness of epithelium to come?
At least it will take total epithelialization. It will take from 21 days to 21 to 48 days, ma'am. It depends on the person to person, ma'am. But it is approximate.
Jyoti ma'am, please.
ठीक है, it's okay, Nandini. Good work. Next, please.
Respected ma'am, Namaste. Myself, Dr. Amit Kumar Pushti, with the presentation on gingival enlargement through various approaches. As we all know, gingival enlargement is one of the very common feature of gingival disease. Aesthetically disfiguring overgrowth of gingiva is a significant side effect which may be associated generally with anticonvulsant or anti-epileptic drugs like phenytoin, valproic acid, and immunosuppressant like cyclosporine A, and with calcium channel blockers like nifedipine and all. So my case presentation was on study on 2 patients. One is case 1. The patient reported to our college with gingival swelling and difficulty in brushing, bleeding gums and all. So through the grading score of gingival enlargement, so the scoring was through grade 2. Enlargement involves papilla and marginal gingiva. So on my first case, my treatment was through scaling and root planning. And in my second case, I opted for gingivectomy. My main purpose was to look out the cases like there is no surgical intervention is not needed in these cases, because the patients who are in phenytoin and all, first we have to consult their physicians to reduce the dosage or to have any substitute of any drugs, so that the gingivectomy can be treated, so that the this gingival enlargement can be treated. So gingival enlargement, so to conclude with this, gingival enlargement doesn't need always surgical intervention and can also be managed non-surgically. However, a good oral hygiene procedure is needed to maintain the oral status. Thank you, ma'am.
Thank you, Amit. Thank you so much.
Thank you.
Thank you for the presentation. I think Dr. Jyoti
Thank
is
you,
getting disconnected. So let's go to the next presentation, please. Dr. Sibani Sarangi. No questions, Amit. Thank you.
Thank you.
Dr. Shibani.
Good afternoon, ma'am.
Good afternoon. Just
Am I
let me
audible?
check with yeah, just a minute, please.
Okay.
You are audible, Sibani. Just a minute.
I'm going to madam disconnected.
Okay, Dr. Jyoti just got disconnected. Can we wait? I don't think we have time enough to wait. Okay, please continue, Dr. Shivani.
Okay, ma'am. So, good afternoon, ma'am. Myself, Dr. Shivani, and I am going to give my presentation, poster presentation on the topic from dark to light. So, it's a case series representing gingival depigmentation. So, since we are dealing right now with the pandemic situation where we are facing a dark situation and we are in a silver lining of hope to just go into the light, that everything will be fine. And being periodontist also, we always deal with the dark gingiva and giving it a hope to go to light. So as we all know that gingiva participates in the process of smile with its pigmentation playing an important role, because it not only affects the aesthetic of the patient, but also psychologically affects the patient. And it can be medically defined as a deep purple pigmentation, which may be diffuse or localized, brownish or purplish and varying colors. And it may be due to the melanin pigmentation or maybe due to culmination of multiple effects. So, and obviously along with it, we have a lot of other factors also acting on it, like we have environmental factors and other actively or passively factors acting on it, maybe ethnicity and age. So today I will be discussing 3 of my cases of gingival depigmentation procedure, which is an aesthetic procedure using different techniques. Here I have presented 3 of my cases, in which one I have done with the scalpel, the other one using the burr, and the third one is using on the chemical method. So in all the 3 cases, the first case, as we can see, the patient is a 22-year female patient with the chief complaint of blackish discoloration of the gums. And the process of scalpel depigmentation, as it's already mentioned in the poster, there are a lot of advantages and disadvantages of this procedure. And there is a series of cases which is representing, like showing a series of pictures which is representing my case, that is pre-operative, then using scalpel, then how the tissue is removed, immediate post-operative, periodontal dressing, and 2 weeks post-operative. Similarly, in the burr also, we can see that there is a series of pictures representing my case. That is, there is pre-operative, then using burr, immediately tissue removed, and there is post-operative, pack placed, and post-operative. Then the chemical method that I have used is, in this condition, I have applied the TCA, that is trichloroacetic acid. And the patient is also a male patient, but he was very much aesthetically concerned, so he wanted to get it treated. So this is a series of photos where there is a pre-operative and then an application of TCA with applicator, then immediately after the scraping, and a follow-up after 2 weeks and a follow-up after 12 weeks, that is 4 months. So these are the results. So more or less in my presentation, I will like to conclude that in this process of depigmentation, some have been used recently, so some are gold standard, and some are now recently used, so they need more practice to meet up the aesthetic consideration.
Thank you, Shivani.
Thank you so much.
Okay, Shivani, the 3 treatment modalities that you have used for depigmentation,
Yes,
do you think that these are the best 3 ways to do depigmentation?
No,
What is
ma'am.
the most treatment of choice?
Ma'am.
And you haven't used it actually.
Ma'am, actually, we have we have done a number of cases where we have done the depigmentation using scalpels and burrs and lasers, and also with the chemicals.
My question is that are these 3 the ideal ways to do depigmentation, or you could use a better way?
Ma'am, yes, we are doing it also. We can use lasers also. We can, that is, I think, one of the most accepted ways nowadays to go for a depigmentation procedure. But since I wanted to compare my chemical method with the standardized gold standard or conventional technique, that's why I just put up these 3 cases just to show that the new technique, the chemical method, which is not very much used, to what level or extent it just meets up with the expectation of the conventional methods that we have been using.
But then there is no new finding in your case report. These are all previous reports and previous literature that you've told us. Nothing new in this. Anyways, thank you so much.
Thank you so much.
Next presentation, please. Dr. Chinta Kindi.
Yes, ma'am.
Swapnil, no.
Dr.
Chinta Kindi.
Yes, ma'am. Audible. Hello, ma'am.
Yeah, who's that?
Yeah, ma'am. I'm Dr. Chintakindi Nidhi, ma'am.
Yeah.
I'm yes, ma'am. Yes.
Just a minute. Can you hold on, please? Yeah, please carry on.
Yes, ma'am. Today I'm presenting the poster presentation on the topic vestibuloplasty procedure, comparison of the electrocautery and scalpel techniques, a case report. Generally, the inadequate vestibular depth results in the poor plaque control owing to the insufficient width of the keratinized gingiva. The vestibuloplasty procedure provides a necessary vestibular depth, and it can be performed by using the scalpel, electrocautery, or by the laser procedures. In this case report, 2 patients who were presented the inadequate vestibular depth were included, and the vestibuloplasty procedure was carried out in a male patient of 27 years old. The procedure was carried out by using the scalpel. A horizontal incision was made by using the number 15 scalpel blade at the mucogingival junction, and the split thickness flap was reflected by dissecting the mucosal fibers and the tissue from the periosteum. Whereas in the other patient, that is a female patient of 22 years, were treated by using the electrocautery procedure. Light brushing strokes was used, and the tip was kept moving, and application for the prolonged period was avoided so that to prevent the heat application. And the patient were recalled after 7 days, and wound healing was assessed by using the laundry wound healing index. And it was shown that the patient treated with the electrocautery showed the better wound healing when compared to that of the scalpel procedures. And the vestibuloplasty procedure generally results in the modification of the gingival mucous membrane relationship, leading to the deepening of the vestibular depth and altering the projection of the frenum, and that helps in the widening of the zone of the attached gingiva. So it was concluded that the vestibuloplasty procedure carried out with the electrocautery procedure is considered as the valid alternative to the traditional vestibuloplasty that was performed with the scalpel in relation to the faster wound healing, and it also provided the better patient perception when compared to the traditional procedure. Thank you.
Thank you, Dr. Chinta Kindi. Ma'am is there. Dr. Jyoti is there.
Yes, ma'am.
Dr. Nidhi, I want to ask you, what do you think could be the reason for better healing in case of electrosurgical procedure?
Ma'am, I think that in electrocautery procedure, both the healing and patient prescription was better, ma'am, when compared to that of the scalpel procedure. This may be because in In electrocortic procedure, the bleeding, it was a bloodless surgery, ma'am, where no sutures were placed. The intraoperative timing was less, and post-operative healing was found to be post-operative pain and discomfort was less in electrocortic procedure, ma'am. And in electrocortic procedure, the protein coagulum will be found, ma'am, over the wound. So it may act as a biological resin that helps in faster healing when compared to that of the traditional procedure with scalpel.
Did you cover both these surgical sites with the periodontal dressing?
Yes, ma'am. Yes, ma'am.
So then the protection is the same. So how come the healing is better in case of
Actually, I have placed the sutures in scalpel procedure, ma'am, whereas electrocautery is there is no placement of the sutures, ma'am.
The sutures is fine. I am asking about periodontal dressing.
Yes.
Did you use a dressing?
Ma'am?
Did you use any periodontal dressing after this? After
Yes,
both the procedures?
Yes, ma'am. Yes, ma'am.
What is this Landry Healing Index?
Yes, ma'am.
How does it evaluate healing?
Very good, ma'am. In relation to the electrocortic procedure, when compared to that of the, I have given a score of very good, ma'am, for electrocortic procedure and good for the scalpel, ma'am.
What are the criteria on which you are measuring the healing?
Depending upon the tissue color, ma'am, and bleeding upon the bleeding upon the palpation, and also the incision margins, ma'am. These are the three criteria used for the laundry.
And it is taken at what time? Post-op?
Yes, it's 7th day post-operatively, ma'am.
7 day post-operative.
Then the healing index that you have used, this Landry, I think this was one of the very, very earliest used wound healing indexes and not really now used because it has a lot of detective errors. Maybe the tissue color is not really a good way to judge the results. So, मतलब आपने ये क्यों use किया? There are a lot of detectives. Any reason to use this index? Hello?
Yes, ma'am.
Okay, thank you.
Okay, ma'am. Okay.
Dr. Jyoti, the first one is still left. We can do it in the last. Dr.
Yes, first one is still left.
Dr. Swapnil.
Oh, am I audible?
Dr. Swapnil.
Am I audible, ma'am?
Yes, you are audible.
Can you start your video, please?
Good afternoon to one and all present over here. My topic for today's poster presentation is regeneration using sticky bone graft in periodontal intrabony defect. In order to accelerate the healing of the bone graft over the defect, various techniques utilizing platelet concentrates have been introduced in the literature. Injectable PRF is a new boon in periodontal regenerative therapy. The slower and the shortest centrifugal speed, that is 700 rpm for 3 to 4 minutes, used in preparing the IPRF increases the presence of regenerative cells with higher concentrations of growth factors. In dentistry, this liquid PRF is mixed with particulate bone graft, and after approximately 3 to 4 minutes on completion of the coagulation process, a gel or putty consistency sticky bone graft is obtained. Sticky bone provides stabilization of bone graft in the defect and therefore accelerates tissue healing and minimizes bone loss during healing period. Coming on to the case presentation, a systemically healthy 44-year-old male patient reported with the chief complaint of food lodgement in lower left back region of jaw since 4 months. On clinical examination, a periodontal pocket of 8 mm was present on the mesial aspect of 3-7. The radiographic examination IOP revealed a vertical defect of 6 mm extending up to middle 1/3 of the root in region with 3-6 and 3-7. The treatment was started with phase 1 periodontal therapy. After 4 weeks, the patient was recalled and a decision of periodontal regenerative therapy was made. A full thickness mucoperiosteal incision was given, flaps were reflected. After that, a 2-wall interval defect of 6 mm depth was noted on the mesial aspect of 3-7. After complete debridement, the decision was made to regenerate it with the help of sticky bone graft. For preparation of injectable PRF, 10 ml of patient's blood was collected and it was immediately centrifuged at 700 RPM for 3 minutes. After that, the blood was separated into two layers. The bottom layer consisted of RBCs and the upper layer it consisted of platelets, plasma, and all the coagulation factors in uncoagulated form. This injectable PRF was mixed with DF-DBA bone graft. After 3 to 4 minutes after complete polymerization, it resulted in a gel-like consistency sticky bone. The graft was carefully filled into the defect area and it was covered by using chorion membrane. Sutures were given to the patient, a copac dressing was given. The patient was kept under continuous follow-up and maintenance therapy. After 6 months on clinical examination, the moving pocket depth was reduced to 3 mm. And as you can see on the IOPA, there was a radiographic defect bone fill of 4 mm in the defect area. So on the basis of clinical and radiographic results, I would like to conclude that sticky bone causes reduction in the PPD and gain in cal, as well as radiographic bone fill was achieved. The fibrin network entraps platelets and leukocytes to release the growth factors so that the bone regeneration is accelerated. Thank you.
Okay. Your name is?
Ma'am, Dr. Swapnali.
Swapnali. Okay,
Swapnali.
Swapnali, what is the advantage of this LPRF over routine PRF?
Ma'am, this injectable PRF, ma'am, as we can, as we are using slower centrifugation speed and time, ma'am, it is very rich in growth factors. It consists of various growth factors like platelet growth factors, fibroblast growth factor. It is rich in platelets, ma'am. So all these growth factors, it helps in accelerating the bone healing, ma'am, and it also helps in soft tissue healing, ma'am. And as ma'am, we are using IPRF for making this sticky bone because of its consistency, ma'am. It stabilizes the graft in the defect area. It prevents its movement from that defect area, and all this graft material is interconnected by fibrin network, ma'am. So it minimizes the soft tissue ingrowth while during healing period, ma'am.
Okay, so it basically is creating a sticky bone, right? Otherwise, what is? What is? I mistook it as LPRF. What is LPRF? You know?
Yes, ma'am. Leukocyte PRF, ma'am. Ma'am, it is prepared at 3000 RPM, ma'am, for 10 to 12 minutes, ma'am.
Okay, a little lesser speed. Fine. And yes, what is APRF? What is APRF?
Ma'am, APR is advanced PRF, ma'am.
How is it different from LPRF?
Ma'am, in advanced PRF, ma'am, the centrifugation speed used is 1000 to 1200 RPM, ma'am. And the advanced PRF, ma'am, it is reaching leukocytes and platelets, ma'am.
What layers actually form sticky bone? When you are preparing PRF,
sorry, ma'am.
What layers do actually form the sticky bone? What layers are you taking? You have written that 3-4 minutes and completion of population of gel and a putty consistency sticky bone.
Yes, ma'am.
What is sticky bone? Can you explain? What do you mean by sticky bone?
Ma'am, sticky bone, it is a bone graft entrapped in fibrin mesh, ma'am. Sticky bone is prepared by mixing injectable PRF with any particulate bone graft material, ma'am. Ma'am, after centrifugation, ma'am, for IPRF, the blood will be separated into two layers, ma'am. The upper fraction, that is the liquid portion, ma'am, it is obtained in a syringe, ma'am. And then this liquid PRF is mixed with any bone graft material. And after coagulation process, ma'am, after polymerization, ma'am, after approximately 5 to 10 minutes, will result in a gel-like consistency graft, ma'am. That is the sticky bone, ma'am.
Okay, good. Thank you.
Thank you, ma'am.
Dr. Veena Mishra.
Yes, ma'am. Good afternoon. Am I audible?
Yes, you are audible, dear.
Okay, ma'am. Good afternoon, one and all. Today, I'll be presenting a case series on the aesthetic challenges of a laterally positioned flap in Miller's Class 3 recession. We all know gingival recession, or marginal tissue recession as it is rightly called, happens to be one of the most common challenges encountered by periodontists routinely in clinical practice. And periodontal plastic surgical procedures aim to restore both gingival aesthetics as well as function in these defects. Now, this case series highlights one such technique, namely laterally positioned flap, or LPF. LPF was introduced by Group and Warren in 1956 and called it lateral sliding flap then. LPF is a pedicle flap which is used in isolated gingival recession cases with sufficient keratinized gingiva or donor tissue adjacent to the recessive defect. This study includes 3 patients with isolated Miller's Class 3 recession who reported to our department complaining of receding gums, age group between 25 to 40 years. After their successful etiotrophic phase, the patients were subjected to LPF surgery, which included the following steps. And these can be seen in the top right set of pictures. Incision and deepithelialization of the surgical site. Reduction of root convexity was done using aerotor burr. Then root conditioning with tetracycline solution. Positioning of the LPF, the flap over the recessive site, suturing 1 to 2 mm coronal to the CEJ, and finally placing a light cured periodontal dressing on the surgical site. A regular recall program can largely prevent treatment failures. So the these patients were recalled after 3 months, 6 months, and 12 months post-operatively. And the gingival recession depths obtained at baseline were compared to those values obtained 1 year post-surgery. So here in the left side, you can see the set of photographs. In case 1, initially 6.5 mm recession depth at baseline was reduced to 1 mm after 1 year. In case 2, 10 mm initially was reduced to 3 mm. And in case 3, 7 mm at baseline reduced to 1 mm after 1 year. And as for the results, in the graph, it is seen the root coverage rates achieved were between 70 to 85% in all these cases, which is highly remarkable. Also, the patients were very much satisfied and happy with the results. So to conclude, I'd say laterally positioned flap as a periodontal surgical procedure for root coverage achieved satisfactory outcomes, both aesthetically and functionally, in patients with advanced gingival recession. Thank you.
Thank you, Dr. Veena.
Yes, ma'am.
Dr. Veena, in case 2,
yes, ma'am.
As I can see, was there an aberrant frenal attachment too? Or it's just like...
No, ma'am.
But the tissue available is quite less for the laterally positioned flap. Did you manage to cover it well?
Yes, ma'am. The results were satisfactory, but however, in case 2, the recession measured initially was 10 mm. So, compared to all the 3 cases, the results obtained were comparatively less in case 2. That was 70% recession coverage only was achieved.
Okay. What could be the other methods which could be used here?
Ma'am, double papilla flap could be used. But because it is isolated recession, so rotational flap techniques.
Okay, Dr. Sakshi, please.
Thank you.
Next, please.
Thank you.
Dr. Palak Subhash Agarwal. Dr. Palak?
Yes, ma'am. Am I audible, ma'am?
Yeah, you can start your video, please.
Yes, ma'am. Warm greetings to all. Myself, Dr. Palak Agrawal, along with my colleagues, Dr. Sanika Kamble and Dr. Ketan Rajput, will be presenting a poster on a case report of rehabilitation and management of post-COVID-19 oral mucormycosis. The COVID-19 infection caused by novel SARS-CoV-2 has been associated with wide range of disease pattern, that is from mild cough to life-threatening pneumonia. A myriad of manifestation and complications have been documented with each passing day as we learn about this pandemic. One of such emerging manifestation is mucormycosis. Mucormycosis is an aggressive, invasive, or potentially devastating opportunistic fungal infection, usually affecting the patient with alteration in their immune system. Mucormycosis manifests clinically in 7 different forms, that is rhinocerebral, pulmonary, cutaneous, gastrointestinal, disseminated, CNS, and rarely miscellaneous, that is bone, kidney, cardiac, and oral. Of which the pulmonary and rhinocerebral being the most predominant one. Thereby, today we present a case of 61-year-old male patient who reported to the Department of Periodontology with a chief complaint of pain and mobility in upper front tooth region of the jaw. Patient had a known history of uncontrolled type 2 diabetes mellitus and hypertension since 10 years and also had undergone angioplasty 2 years back. The patient was recovered from the SARS-CoV-2 infection 1 month back. So intraoral examination manifests poor oral hygiene, minimal or absence of bleeding on probing, multiple mobility, multiple intraoral draining sinuses on buccal aspect, shallow to deep pockets. On careful palpation, the entire alveolus was mobile and with necrotic denudation of the hard palate. Therefore, an interdisciplinary treatment approach was formulated for the patient, and thus the patient was referred to the Department of OMFS, where the excisional biopsy was done, and the serial section from the tissue biopsy showed non-septate fungal spores. This confirmed the diagnosis of mucormycosis. So the thorough surgical debridement of the necrotic tissue was carried out under LA, and patient was kept on post-operative antibiotic regimen. After this, patient was kept on further follow-up period for 1 month, and when after satisfactory healing was achieved, the maxillary deficiency was rehabilitated with a palatal obturator after 1 month. So as we all know that mucormycosis has a poor prognosis with a mortality rate of up to 80 to 100%, as confirmed etiology behind it has yet to be established. Therefore, as of now, the possible etiologic factors are COVID-19 infection itself, uncontrolled diabetes mellitus, opportunistic fungal infection, administration of corticosteroids for COVID-19, and long-term oxygen oxygen therapy. To conclude that, we conclude that early diagnosis and meticulous timely debridement is the key for successful management of mucormycosis.
Dr. Palak, Dr. Palak, what is your role as a periodontal surgeon here?
Ma'am, as a periodontist, as there was mobility in the tooth to the patient was reported to the Department of Periodontology. So, as the disease was progressed, so our role in this case is only for diagnosis, proper diagnosis, so that a timely management can be done.
Okay. This rehabilitation part, the obturated part, it was taken care by prosthodontic department?
Yes, ma'am, prostho department.
And this extraction and alveolar reconstruction, it was taken care by oral maxillofacial surgeon?
Yes, yes.
Okay. Fine. Do you know this COVID-19 virus, it can be possibly inhabited in deep periodontal pockets too? There is a latest study published in this regard on the autopsy autopsy specimens पे है study. You can go through that as far as the perio part is concerned, because GCF and saliva, they both are exhibiting the forming a media to diagnose. So periodontal pockets can again be residual tissues. So we, as periodontists, what our concern should be more towards the, even for the routine day-to-day management in these cases, even after the treatment of COVID, because aerosol production and all, this can risk the life of the patient as well as the dental professional. So these could be the potential areas where we should look into as a periodontist. Dr. Sakshi?
Yeah, Palak, you know that mucormycosis is basically a medical emergency, as you can see. Okay, did you consult any other field for this, or did you just take care of the patient yourself? Any physician, any ENT surgeon, any
Yes, ma'am.
other doctor, any other drug therapy that you put this patient on?
Ma'am, for this patient, ma'am, only means oral surgery department and prosto was means, and there was no means maxillary sinus was not involved.
Did you get any histopathological examination done, and any
Yes,
blood
ma'am.
test or histopathological examinations that?
Yes, ma'am. Histopathological examination was done, ma'am.
Any medicine that you gave, drug therapy?
Ma'am, amphotericin B was prescribed to the patient.
How do you prescribe amphotericin B? कितना बोला खाने के लिए? कितना दिन खाना है, कब खाना है?
Ma'am, liposomal amphotericin B 5 milligram per kg per day.
ठीक है, लेमन को ऐसे समझाया था, पेशेंट को क्या बोला, क्या खाना है? पेशेंट को क्या बोला, क्या खाना है? पर केजी ऐसे बोला आपने, कैसे लिख के दिया प्रिस्क्रिप्शन पेशेंट को? If you have yourself done this case?
No, ma'am. Oral surgery department.
Okay. Then why are you presenting the case? Half part rehabilitation prostho did, other part oral surgery did.
Ma'am, actually, patient was reported first to the Department of Periodontology. Means patient was reported with the chief complaint of mobility. So as the entire alveolus was mobile, we referred it to the Department of OMFS. So proper timely diagnosis is done by is our.
So basically, as ma'am was asking, as a periodontist, what was your role? You did nothing.
Ma'am, because disease was always progressed.
You just took the case because you thought कि mucormycosis है, सब कहेंगे बड़ा अच्छा case है. ठीक है, thank you.
Next, please.
Am I audible, ma'am?
Yes, you are audible.
A very good afternoon to everyone. I would like to start my presentation by quoting Warren Buffett. Don't say what is left after spending. Spend what is left after saving. And almost amidst the current scenario, preservation of health is always easier than cure of the disease. So what is socket preservation? It is a procedure done to reduce any bone loss after extraction due to various reasons. It is a natural tendency of jawbone to become narrow and lose its architecture, resulting in 30 to 60% of bone loss in first 6 months. So ideally, this procedure prevents immediate resorption by keeping the contour of the socket intact. So how are we doing this? So for this, we used IPRF and calcium cements in this case. For injectable plasma-rich fibrin preparation, a standard protocol was followed. Equipments include PCO2 table centrifuge, and blood collection kit include 24 gauge butterfly needle and 9 ml collection tube. A sample of blood was collected from the patient without any anticoagulant in 10 ml tubes, which were immediately centrifuged. Fibrin clot obtained after centrifugation was removed from the tube, and attached RBCs were scraped off from it and discarded. Adding to the benefits of IPRF, synthetic hydroxyapatite, that is calcium tri and tetraphosphate cements, were mixed and placed in the socket. So basically, they stabilize the coagulum and aid in bone regeneration. So what is essentially happening? Mr. Selvakumar, aged about 26 years, has been referred from Department of Endodontics, who presented with a chief complaint of discolored upper left front tooth region for past 6 years. That tooth had poor prognosis for endodontic management due to severe bone loss, hence referred to Department of Periodontics. Careful diagnoses were made with the help of CBCT and a treatment plan was propagated. Initially, an atraumatic extraction of tooth 1 was done under local anesthesia. Sulcular and crevicular incisions in the adjacent teeth were given with 15C microsurgical blade, after which full thickness flap was elevated and thoroughly debrided. IPRF and calcium tri and tetraphosphate cements were mixed together and placed in the surgical site. Simple interrupted sutures were given with 5O vicryl sutures and a review was done after 1 week. So after finishing all these, where did we arrive at? Clinical and radiographic evidence suggests that there is a characteristic increase in bone level after 3 months. It was also suggestive of good regeneration achieved, which is adequate in receiving the future processes. Hence, IPRF and calcium cements are quite advantageous over autogenous bone graft, which is still being the golden standard by overcoming donor side morbidity, unpredictable bone quality, and most importantly, post-operative discomfort. I would like to conclude this presentation by saying, let us be the proud creators of world's beautiful smile. Thank you.
Thank you, Dr. Nivedita.
Thank you.
It was nice if we are not planning for an immediate implant placement.
This was done before 4 months, ma'am. So before the implant placement, due to the current situation, we couldn't place the implant, ma'am.
Yeah, this is a good thing to preserve the socket at time of extraction only, so that post implant complications are avoided.
Yes, ma'am.
That's good.
Thank you, ma'am.
Good, Nivedita. Good case.
Thank you, ma'am.
Okay, thank you.
Thank you.
Next, please, Dr. Rucha Jadhav.
Yes, ma'am. Good afternoon.
Yeah, Rucha, good afternoon.
Good afternoon, ji.
Yes, ma'am. May I start?
Yes, please.
Good afternoon, everyone. Today I'll be presenting on clinical and radiographic evaluation of peri-implant bone following immediate implant placement with immediate temporization, a case report. So patients who receive implants today are often unaware of the original loading protocols of 3 to 6 months of load-free healing prior to restorative therapy. Often when patients require extraction of an anterior tooth, they do not accept even the shortest period of partial edentalism. Thus, immediate implant placement and immediate temporization is a commonly used technique these days. The term immediate temporization is used when the prosthesis is placed on implants at some point within the first 72 hours without full occlusal contact with the teeth of the opposite jaw. So, coming to chief complaint, a patient came to the Department of Periodontology with a complaint of missing tooth in lower front region of the jaw. Upon oral examination, we saw there was missing 3 tooth, and upon RVG, we found there was a root piece with 3 tooth. So, extraction with immediate implant placement and immediate temporization was planned. This is a pre-op view where local anesthesia was administered and minimally invasive extraction was invasive extraction was performed, and this is pre-op RVG and extraction followed by implant placement and abutment placement, and provisionalization was done.
I can't hear you.
Sorry, ma'am. Ma'am, am I audible now?
Yeah, you are audible. Please continue.
Okay, so 2 parameters were measured. One is soft. Yes, ma'am.
Dr. Sakshi, your voice is not clear if you are saying something. Okay, continue, please.
So two parameters were measured. One is papilla volume, that is soft tissue, and in hard tissue, a vertical height of the bone was seen. In papilla volume, we saw based on GEMS classification in 1997, where baseline measures were grade 0 in both mesial and distal papilla. And after 3 months, grade 2 was observed. And vertical height in immediate post-operative, we saw 0.95 mm, and after 3 months, it was 0.63 mm. So coming to discussion, in the immediate loading technique, a temporary crown is connected to the implant within 72 hours without implant installation. And it has two advantages. That is reliable method. It is reliable method for developing soft tissue site of single tooth restoration, and countersinking the implant below the crestal bone is eliminated, reducing the early crestal bone loss. So in conclusion, dimensional changes to the peri-implant buccal and palatal bone and soft tissue parameters following maxillary anterior single immediate implant placement and temporization should be expected. Thank you.
Dr. Rucha.
Yes, ma'am.
Can you please explain these parameters by which you have recorded the soft and hard tissue?
Ma'am, on we did CBCT. So according the vertical height of the bone, we measured on CBCT, and papilla volume only by GEMS classification, where grade 2 is near the midline of the papilla.
Near midline of what? I mean, mesial papilla, distal papilla, this is baseline, and then 3 months, then 0, 0, and then 2, 2. Can you explain it a bit?
Ma'am, according to GEMS classification 1997, grade 0 means there is no papilla was present at the baseline. And after 3 months, half or more of height of the papilla is present. Yes, ma'am.
What is grade 1 in this classification?
Ma'am, less than half of the height of papilla is present.
And I mean, what further is there?
Ma'am, grade 3 and grade 4. Grade 4 is where papilla fills up the space between the two teeth. And grade 4 is where the papilla is hyperplastic.
Fine. Dr. Sakshi?
Yeah, Rucha, what do you mean by vertical height? What are you explaining? I can't see the table. What is it? Immediately post-operative, how much is the vertical height?
Yes, ma'am.
Can you please tell me the vertical height immediately post-operative?
Ma'am,
And
0.9.
later, 3 months later?
0.63 mm.
So what are you basically explaining? What do you mean by vertical height? Can you please tell us?
The vertical height was reduced by 0.32.
Yeah, what do you mean by vertical height?
Ma'am, means that how will you define the term vertical height which you are using over here?
Ma'am, from occlusion, ma'am. Ma'am, which I using through CBCT from the occlusal line between the adjacent teeth. From there, we measured the bone crest, the height of the bone crest.
This is your own case?
No, ma'am. Actually,
How did you find this vertical height? कैसे किया? Clinically check किया? Radiographically किया? क्या किया? Sorry? There. She's not there. Okay, thank you so much. Ma'am, one last is left. The first candidate who could we could not hear him. Dr.
Aziz.
S.K. Aziz Iqbal. Dr. S.K. Aziz Iqbal, can you please come in?
Yeah. Please.
Sir, are you using the headphones? Then I would request you to please remove the headphones and please deliver the talk. Dr. Aziz? Hello, Dr. Aziz? So we can see you, but we cannot hear you. You're not audible. Can you say? Hello? Can you present? So I believe your headphones are not working. Yes, sir.
Yes. Now it is audible.
Yeah, please present, please.
Not at all audible.
I can't hear you. You are not audible, Dr. Aziz. बिल्कुल नहीं सुन रहा.
So can you log in from the phone? Otherwise, if you're facing any issues with your laptop?
It's last.
Dr. Aziz. He's come back again.
Yeah, he's rejoined.
Yeah, he rejoined.
Ma'am.
Yeah, better.
Hello.
Yeah, sir, we can hear you now. Please present the poster.
Yeah, Aziz, we can hear you. Please, Dr. Aziz. Yeah.
Thank you, ma'am. Today I am going to present the case chronic inflammatory gingival enlargement, a case report. A 28 years male patient came to the department with chief complaint of swollen gum. Enlargement was firm and fibrotic, but at the marginal gingiva that was soft and edematous due to inability to maintain adequate oral hygiene in pre-existing gingival enlargement. Surgical treatment was done. The treatment was initially I did supra and subgingival scaling. After 1 week, the enlarged tissue was removed by scalpel under local anesthesia. The gingival margin was given form to scalloped, thin, and tapered, and internal papilla was given conical shape. Periodontal dressings was placed in that area and kept for healing. After 1 week, pack was removed and the area was checked for healing. There was no complication observed in terms of soft tissue healing. Patient was satisfied with newly formed gingival contour. So we can say that gingival chronic inflammatory gingival enlargement is caused. Here the chronic inflammatory gingival enlargement was caused by prolonged exposure to dental plaque. It can be successfully treated with local procedures and oral hygiene. And the fibrotic components was removed by surgical intervention. And we can conclude that this case is due to the poor oral hygiene in pre-existing fibrotic gingival enlargement. There was reduction in enlargement after scaling and root planing, and residual was corrected by external visual gingivectomy. Figure 1 shows preoperative condition. And figure 2 shows surgical. Figure 2, the gingival margin was made to scallop, thin and tapered form. And figure 3 is a picture of 1 week post-operative. And figure 4, 1 month post-operative picture. Thank you, ma'am.
Thank you, Dr. Aziz.
Dr. Aziz, what was so special in this case? I think it's a routine case in periodontics postgraduate clinic.
Yes, ma'am. Yes, ma'am. Mainly,
it's a very routine case. It's a simple
routine
case of treatment of an enlargement, chronic inflammatory enlargement.
Yes, ma'am.
There was nothing
Basically,
at all.
UGs even do these cases. UG case hai ye bilkul. This is not even a postgraduate convention case.
Did you go for the histopathology in this case?
No, ma'am.
Because it's a very usual case. And was the patient, maintaining well? कितना लंबा follow up है आपके पास?
Ma'am,
How
1
long
month.
follow up? Only 1 month?
Ma'am, after ma'am, the college was closed due to COVID.
Okay.
Are you a first year PG?
No, ma'am, second year.
All right. All right.
Because since it's a case of chronic inflammatory enlargement, so basically the most important thing here is the SPT. Patient should be on regular recall visits to check for the maintenance of his oral hygiene and motivation regarding that.
Yes, ma'am.
Right?
Yes, ma'am.
Okay, nothing more from my side.
Okay. Same here, same here. Thank you, Dr. Aziz.
Thank you, ma'am.
Okay, I think Dr. Jyoti, we are done.
Yeah, we are done with the second session also.
Both the sessions, and the Ashish sir is there. Dr. Ashish Kumar, I can see he's joined up. Dr. Vishakha has not yet shown up. I think she's the other judge.
With the next session.
She's not.
Yeah. Okay, thank you so much. Thank you,
Thank
the
you so much,
organizer and
everyone.
Good Prakash for being there and technical help. Thank you so much. Thank you, Dr. Jyoti. At least we can meet on online.
Yeah.
Thank you. Thank you, Good Prakash. Thank you, Vama Events.
Thank you, ma'am.
Thank you, ma'am.
Thanks.
GP sir.
Good afternoon, sir.
Good afternoon, sir. क्या हाल है GP sir?
Sir, perfectly fine. आपकी आवाज सुन के और बढ़िया हो गए.
अरे सर, अच्छा सर, ये अभी जैसे आप इंडिविजुअल चल रहा है, ऐसे चल सकता है क्या?
Yes, sir. Actually, that's what we have done since morning. When we were doing it earlier, like presentations together and then question answer, it was taking more time. So we decided to finish it off in one go only.
No, that is better actually. ना question भी याद नहीं करने पड़ेंगे.
Right, sir. Right, sir. As it suits you, it's perfectly fine, sir.
And this is good. But individual presentation and then questions that should finish off that candidate also, na?
Right, sir.
Good afternoon to all of you. On behalf of Indian Society of Periodontology, I invite you all to the 19th ISP PG Convention 2021. So moving on to the next session, the chairpersons for this session are Dr. Ashish Kumar and Dr. Vishakha Grover. Dr. Ashish Kumar sir is alumnus of Bapuji Dental College and Hospital, Davangere. He is currently working as professor and head, Department of Periodontology at Dental College, Regional Institute of Medical Sciences, Imphal, Manipur. He is also the editor of Journal of Indian Society of Periodontology. Dr. Vishakha Grover ma'am is currently working as Associate Professor in Department of Periodontics at Dr. Harvansh Singh Judge Institute of Dental Sciences and Hospital, Punjab University, Chandigarh. She has completed her graduation from Government Dental College, Patiala, and post-graduation from Government Dental College, Amritsar. She has published more than 75 scientific publications in various quality scientific index national and international dentistry and allied medical journals with significant impact She has been an executive committee member of Indian Society of Periodontology for the past 10 consecutive years. Very recently, she has been granted an approval from Department of Science and Technology, Government of India, for a funded research project on exploring periosystemic relationship in Indian population and antimicrobial peptides in oral hygiene application. Welcome, sir. Welcome, ma'am. And I now request you to take over and start the session.
Thank you so much for the introduction. I think we should start off with the first presentation. What do you say, Vishaka ma'am?
Yeah, surely, please. I'm here. Thank you, Ankita. Thanks for all kind words.
Good morning, everyone. Today I'm here for my poster presentation. The topic is management of aberrant frenum, a case report. As we know that the frenum is a mucous membrane fold that attaches the lip and the cheek to the alveolar mucosa, the gingiva, and the underlying periosteum. Hello.
Yes, please.
Please continue. Please continue.
Please continue.
The frenum, if it is aberrant, it may jeopardize the gingival health when they are attached too closely to the gingival margin, either due to an interference in the plaque control or due to the muscle pull. In addition to this, the maxillary frenum may present aesthetic problems, or they may compromise the orthodontic result and they may result in a midline diastema, thus causing a recurrence after the treatment. The management of such an aberrant frenum is accomplished by performing frenectomy. The case report I am presenting here is about a 20-year-old female patient who reported to the Department of Periodontology with the chief complaint of a spacing between the upper front teeth. Upon intraoral examination, it was observed that the midline diastema was due to the high frenal attachment. The tension test was performed and it was found positive, and it revealed a papillary type of wound. The armamentarium required for the frenectomy here was scalpel blade number 15, gauze pieces, tissue forceps, silk sutures, and hemostat. The technique followed was the frenectomy here was carried out through the classical conventional procedure. First, the area was anesthetized with the local infiltration by using 2% lignocaine. The frenum was engaged with a hemostat, which was inserted into the depth of the vestibule, and the incisions were placed on the upper and the under surface of the hemostat until the hemostat was free. The triangular resected portion of the frenum with the hemostat was removed. A blunt dissection was done on the bone to relieve the fibrous attachment. The edges of the cut was made in a diamond shape, and the wound was sutured using a plaxel with interrupted sutures. The area was covered with the periodontal pack, and the pack and the sutures were removed 1 week post-operatively. Instead of various modifications, a classical frenectomy is widely followed, and so the conventional technique it has its merits as well as demerits over the other techniques. The conventional technique is cost-effective, and it offers complete dissection of the muscle fibers of the frenum with less chances of reattachment. Also, it has good healing and good aesthetic outcome. The classical technique results in a longitudinal surgical incision and scarring, thus mandating other further modifications. The conclusion drawn here was that this case report highlights this procedure allows for tissue healing by primary intention, increased recovery, and reducing the risk of tissue contractures. In the figures, we can see the pre-operative view, then the frenum which was held with the hemostat, excised frenum, and the sutures that were placed, followed by Copac and 1 month post-operative. Thank you.
Yes, please. Shasta, am I audible?
Yes, ma'am.
Any alternatives to the method what you have adopted here?
Ma'am, I have not adopted any alternative. I have just gone for the simple classical technique.
I'm asking what possible alternative methods you could have adopted if not conventional.
Ma'am, I could have gone for the electrocautery, or ma'am through lasers, or ma'am Miller's technique.
So any particular reason for which you stick to the conventional technique here in the magnificate?
Ma'am, actually, I have decided it according to the patient's needs, and actually it was cost effective. So the patient has agreed for this surgery.
And do you think that your patient, apart from the aberrant frenum, requires any more intervention?
Ma'am, follow-up has to be done, and in this case, the patient was then referred to the Department of Orthodontics for the further treatment.
So what is your opinion about the timing of your procedure with the orthodontic treatment?
Ma'am, ideally, it should be carried out during the phase of orthodontic treatment.
So any particular reason to take up before?
Ma'am, actually the patient, I have convinced the patient to go for the orthodontic surgery. And the patient was only worried about the spacing that was present between the teeth. So I have counseled her about the main cause of this. And further, if she wants this space to be closed, then she has to go for the orthodontic therapy.
Okay, last question from my side. But are you aware of any classification for the frenum placement?
Ma'am?
Are you aware of any classification systems for the frenal positions in math?
Yes, ma'am. Yes, ma'am.
Yeah, please.
According to Classic et al. In 1974, he has given a classification system, and he has classified the frenums as a mucosal, gingival, papillary, and papillary penetrating, according to the attachment of the fibers.
Okay. And is the same system of classification applied to lingual frenums, or you have any other system in place?
Ma'am, lingual, it may be according to mild, moderate, or severe.
All right, yes, sir. Dr. Ashish, anything from your side, please?
Madam, once when you were speaking and presenting, you said this diastema is because of this frenum. So when you remove etiology, then diastema should have resolved.
Mm-hmm.
Did it resolve?
Sir, it can't be resolved, sir.
But you said etiology, when you remove etiology of any disease, it should resolve. Then why do you find that? Do you see spacing between central and lateral also?
Yes, sir. So there was a spacing. So, sir,
then why only midline? Why do you talk about midline diastema? And etiology, you said that it is the presence of frenum. And secondly, why did you say to Vishakha madam's question that you should do it during orthodontic therapy? What makes you say that frenectomy should be done during orthodontic therapy?
Sir, it can be well managed during the phase of orthodontic therapy.
Why? That is what I'm asking. Why can't you, once you see spacing between the teeth and you find that if the patient has to go for orthodontic therapy, why can't we do it before? What stops you from doing it before you start orthodontic therapy?
Sir, maybe there is chances of reoccurrence.
Chances of reoccurrence. What is periodontal scoring? Do you know? What is scoring?
Sir, I don't know.
What is pull syndrome? How do you decide whether the frenum requires frenectomy or not?
Sir, when it is aberrant, sir, then we will go for the frenectomy. When it is jeopardizing the gingival health, or when
do you have something called as pull syndrome, which you can use to see whether if the present phenum requires splenectomy or not. Do you have any idea what is full syndrome?
No,
Okay, thank you, man. Thank you so much.
We can move to the next poster, please. Yes, please, the presentee, Dr. Sangeeta. Is she here?
Yeah, she is here, madam. Dr. Sangeeta?
Ma'am, yes, ma'am.
Yeah,
Hello?
present.
Yes,
Yeah,
ma'am,
please
yes.
present your poster.
Okay, ma'am. Okay, right, ma'am. So my topic is, ma'am, surgical exposure of impacted canine and increased band of keratinized gingiva. It is a case report, ma'am. The patient referred from ortho department, 14 years male patient with impacted maxillary canine. The maxillary cuspis is the second most frequently impacted tooth, followed by the maxillary and mandibular third molars. The cuspids are generally one of the last teeth to erupt into the arch and is adversely affected by loss of the space, overretained deciduous teeth, and deflection of the lateral incisors. The first diagram, which shows the facial view showing the bulge of the maxillary left canine with palpation, and the procedure is carried out by the apically displaced flap. In that second diagram shows the split thickness flap was raised with vertical releasing incisions are given, then open technique to expose the maxillary canine. After exposure of the maxillary canine, we have placed a suture and the pack has given. On the 1 week follow-up, we removed the sutures and we place the bracket, and after 1 month follow-up there is exposure of the impacted canine into the arch, and there is an increased band of the keratinized gingiva. With this, I want to conclude that this case report shows that the mucogingival interceptive surgeries, when used judiciously and at appropriate time, can helpful in preventing the further mucogingival problems. Thank you, ma'am, sir.
Now, what surgery did you use to expose the canine? What surgical?
Apically displaced flap, sir.
What is the advantage of apically displaced flap?
Sir, first is advantage is it will increase the keratinized gingiva and width of fertile gingiva, that will further reduce the periodontal problems like recession.
Will it increase the width of attached gingiva or keratinized gingiva?
Keratinized gingiva, sir. Different, sir. Keratinized gingiva, sir.
What is the difference between keratinized gingiva and attached gingiva?
Yes, sir. Attached gingiva is from the mucogingival junction to free marginal of gingiva to the mucogingival junction. In keratinized gingiva, we also include the marginal gingiva, sir.
If you had not done apically positioned flap, what would have happened?
Sir, if we not done, there will be the plaque accumulation on the mucosal area. So there will be the periodontally compromised defect in lateral incisors tooth, sir.
Why would plaque accumulation occur in one
because
tooth
of,
just because?
Yes, sir. It's because of there is improper patient has not maintaining well, sir. So inadequate brushing techniques and.
Vishakha, madam.
That's all. I'm okay. We can move to the next, please.
Okay, ma'am. Thank you, ma'am.
Afternoon, everyone. My topic of presentation is gingival depigmentation, a case report. Gingival hyperpigmentation is a major concern in this era of young youth and beauty, especially in people with the gummy smiles. Hyperpigmentation depends chiefly on the melanoblastic activity by the melanocyte present in the basal layer of the epithelium. The melanin is the most and common endogenous pigment which contribute the gingival pigmentation. Gingival pigmentation may be due to the endogenous factors and exogenous factors. Endogenous factors may be due to the melanin hyperpigmentation, deposition, and hemoglobin and hemoglobin deposition. In exogenous factors, the amalgam tattoos, heavy metal pigmentation, and drug-induced pigmentation. To remove the gingival hyperpigmentation, the various methods, depigmentation techniques are used, the surgical techniques and chemical methods. In surgical techniques, there are conventional methods used in the scalpel surgery, which is the cost-effective and no extensive armamentarium required and faster healing. Disadvantage of the surgical scalpel technique is during the procedure and post-operative pain. Other techniques are used the gingival abrasion, free gingival grafting, and acellular dermal mechanism.
అయిపోయింది అన్ని ఆన్సర్ చెప్పిన నేను.
And laser are also used. Laser advantage is dry and bloodless surgery, and electrosurgery and radiosurgery are also used. And cryosurgery is easy and rapidly applied and does not cause bleeding and no anesthesia required. Chemical methods, 90% phenol and ascorbic acid are used to remove the hyperpigmentation. Case reported, a 21-year female patient is reported in the periodontal department with the treatment of the black gingiva and wants to correct it. We done the depigmentation procedure with the scalpel technique, in which the split thickness flap is raised from the canine to canine region after giving the local anesthesia. The site after the bleeding is stopped and co-pack is placed and post-operative radiograph of the patient. The result is based on the 3 indices: melanin indices, oral pigmentation indices, and gingival pigmentation indices. Before the treatment, the melanin index score is 2, and after the treatment, it is reduced to the 1. Domet oral pigmentation index pre-operative score is 3 and reduced to the 1 after the procedure. Gingival pigmentation index before the procedure is 3, score is 3, and after the procedure is reduced to the 1. The multiple factors with reference to the various strategies have been reported to be responsible for the influencing the outcome of the management of the gingival hyperpigmentation. Gingival biotype, clinician expertise, patient preferences, and the recurrence determine the selection of the technique. Although a wide range of the technique have been employed, surgery and cryosurgery and lasers have been reported to be superior technique with the better aesthetic results and the low rate of recurrence. Thank you.
Yes, Dr. Pradeep, how long is the follow-up of the case?
Ma'am, 3 months and 6 months for checking the rate.
The post-op you have displayed here is at what time?
Yeah, ma'am, one week. Due to the patient is not coming in the department.
Then that means actually you do not have a track of how the results are there. What is the general perception about the predictability and longevity of gingival depigmentation? How long the area remains pigment free? It is once and for all, or there are chances of reappearance?
Chances of reappearance is there in my own cases.
How long after?
Ma'am, 7 days to 7 days to more 7 years ago.
That's okay. Dr. Ashish, please.
When you decide about depigmentation, what are the other things you would consider before deciding that you should do a depigmentation in this case or not?
Well, evaluate the cases on the 3 indices, sir. The melanin index and the Domet oral pigmentation index and gingival pigmentation index scores.
Pardon, I didn't get you. Can you put your video off and then speak? Can you ask?
Gingival biotype.
And
phenotypes.
That is the only thing you will decide before deciding whether depigmentation needs to be done or not. The gingival biotype.
Age of the patient and clinician expertise or patient preferences.
Why you have written in your poster, lasers is dry and bloodless surgery. How much blood do you see if you use electrosurgery?
There is no blood.
Then why have you written only lasers as dry and bloodless surgery?
This is the advantage of laser surgery. It gives a
What is the disadvantage? What is the disadvantage of using lasers?
Depth is not controlled, and it may injure the tissues and alveolar.
Why depth cannot be controlled? It is in your hands. No, depth cannot be controlled only in chemical methods.
Yes, exactly.
It is a costly treatment, and costly armamentarium required, and
What kind of last question? What kind of healing do you see in depigmentation?
Secondary intentions.
You know what is okay? What is the rate of migration of epithelial cells over a gingival wound? How many millimeters or centimeters or kilometers do epithelial cells move from the border of the wound towards the wound to cover it up every day?
3 to 4 micron per day.
Okay, thank you so much. Anything else, ma'am, Vishakha ma'am?
No, nothing. Please go
Okay.
ahead with the next poster.
Thank you, sir.
Yes, please start presenting your poster.
Yes, ma'am. Good morning, ma'am. Good morning, sir. I'm going to present case report here. In today's world, people are more concerned about their beauty, looks, and physical appearance. One of the unesthetic appearance of oral cavity is loss of interdental papilla, black triangles. Several surgical and non-surgical technique has been proposed to treat the soft tissue deformities and to manage the interproximal spaces. Objective of this case report is to reevaluate the reconstruction of interdental papilla. Causes for black triangle may be absolute, it may be relative. Classification of interdental papilla according to Norland and Ternus 1998 based on 3 anatomical landmarks. These are interdental contact point, apical extent of facial of CEJ, coronal extent of the proximal CEJ. Here I am going to present a report. A 25-year-old female patient came to our department, a chief complaint of dark space between the upper anteriors. Tip of interdental papilla is located between the contact point and coronal extent of proximal CEJ. It comes under Ternus and Norland class 1 classification. First, exposed root was scaled and root planned. After that, semilunar incision was placed apical to the mucogingival junction. After the coronal displacement of the gingival papillary unit was done, preparation of PRF was done by Chocron phenomena and Chocron protocol. 10 mm blood drawn IV and centrifuged at 3000 RPM for 10 minutes. PRF clot separated and compressed. PRF tucked inside the pouch, flaps sutured. And this was the result after 2 weeks and after 3 months. So in conclusion, the case report shows new paradigm using PRF to regenerate loss of interdental papilla. Thank you. Thank you.
Priyanka,
yeah, please, Ashish, please go.
पूछो मैं बाद में.
Priyanka, what are the possible alternatives to PRF in such a case scenario? What else you can go ahead?
Ma'am, we can do papilla preservation flap, connective tissue graft, and hyaluronic acid, something.
Any difference between the three techniques, what you mentioned? Any salient differences between the three methods which you mentioned just now?
Yes, ma'am. Ma'am, we can do like Beagle techniques. So in Beagle techniques, there is some chances of the nerve damage. So it is not used nowadays. And ma'am, connective tissue graft, there is secondary site we have to involve. So because of this, we used PRF over the connective tissue graft. Ma'am, hyaluronic acid, ma'am, not much good results, ma'am.
Hyaluronic acid?
Not such good results for that.
No, I really don't agree with that. I have seen not many good reports published with hyaluronic acid anyhow. That's okay. That is a kind of not really such an extensively surgical option in such a situation, because the area you are dealing in is a high aesthetic concern area. So probably the approach should be such that minimal damage to the existing structures and very conservative surgery is a welcome addition. That's all, Priyanka, from my side. Please, Ashish.
Madam, what made you decide that this papillary loss is because of periodontal reason only? Because black triangle occurs because of restorative reasons also and orthodontic reasons also.
Yes.
What made you decide, on what basis did you diagnose that this is a periodontal in origin?
Sir, it may be because of any reason, sir.
You don't talk about maybe. You don't talk about maybe. You have done a surgery. You have to diagnose this first. What basis did you decide that it has to go in for a periodontal surgery to correct this? For example, if this was because of orthodontics, the periodontal surgery is not indicated in such a case. What made you to come to this diagnosis?
Sir, if tip of the interdental papilla in between contact point and apical or facial extent of CEG, that means it is because of the periodontal problem, sir.
Not necessary, madam. When the roots of the central incisors are distally inclined, or when the crown is triangular in shape, then also you will find the papilla in between the contact point and the cervical or the facial margin of the cervical line. Did you take a radiograph?
Yes, sir.
What was the distance between the contact point and the crest of the bone?
Yes, sir. From the crest of the bone, and in this case, sir, 5 mm.
5 mm, the study says it should be 100% papilla present. That means it was not a periodontal reason. The study of Norland and Tarnow says up to 5 mm, 100% of patients you will find papilla.
Yeah.
In 6 mm, they say almost 67%, and if the distance is 7 mm, it comes to 37%.
Sir, from the contact point to the bone crest.
It is not from the contact point, it is from the apical end of the contact point.
Yes, sir.
So that means you did not diagnose it properly. You don't know what are the reasons and how to diagnose what is the etiology. If the etiology is restorative, you have to treat it restoratively. If the etiology is orthodontic, you have to treat it orthodontically. You have just seen a black triangle and just tried to see it. And secondly, if the distance is 5 mm, you need not do it anything, because the 5 mm distance, anyway, papilla is always good. You should have looked for the other things also. Anyways, thank you so much.
Yes, sir. Yes, sir. Thank you, sir.
Yes, please move to the next one.
This is over.
And you move to the next.
आकांक्षा मैडम का प्ले कीजिए.
No, in between there is one more. Resolution of endoperioral lesion.
Yes.
This is next one after this is not the is PO45, I think so.
Yes, sir. PO45.
I think मैडम आपके लिस्ट कौन है वो नाम पता है?
Yes, sir. Resolution.
Yes, so it's mine. It's Dr. Akanksha and Dr. Aldridge's.
So that is resolution of endoperioral lesion, no?
Yes, sir.
But this is showing root coverage. This is the next one.
And this is the next one. There is your poster seems maybe in the sequence. Is Sejal there?
Yeah, I'm just checking.
Please.
Dr. Akanksha, can you please share your screen? In that case, if you have your presentation.
Yes, I'll just share.
Yeah.
Yes, please.
The start, please.
Akanksha.
Am I audible?
Yeah, please.
Sorry about that. Yes. Good afternoon, everyone. The poster presenting today.
Your voice is getting cut.
Titled Resolution of Endoperioral Lesions, a Case Report. The peritoneum and the hello. Can you hear me?
Yeah, please. Go ahead.
Am I audible?
Yes, please start with your presentation.
Yes.
Yeah, make
the
it full
poster
screen,
we're
please.
presenting today is titled Resolution of Endoperioral Lesions, a Case Report. The periodontium and the dental pulp share a unique relationship in terms of embryonic origin, anatomy, and function. When inflammation arises from either of the two structures, it can spread via anatomical pathways like the dentinal tubules, apical foramen, accessory canals, or through non-physiological pathways like root fractures. The term endoperioral lesion is used to designate a specific disease condition affecting the pulp and the periodontal tissue simultaneously. The different treatment modalities for endoperioral lesions include endodontic therapy, periodontal therapy, which can be either resective or regenerative, and it usually involves a combination of periodontitis. Therefore, the objective of the case report was to assess the outcome of regenerative periodontal therapy, the treatment of primary periodontal, secondary endodontic lesion. The case 1 describes a 36-year-old male with pain and swelling with respect to the lower right first molar. On examination, the tooth of interest 4-6 showed grade 1 mobility, grade 1 furcation involvement, negative vitality test, and a probing pocket depth of 10 mm on the distal aspect. Extensive radiolucency was in the apical third of the distal root. So therefore, the diagnosis was concluded to be endoperiodontal lesion without root damage in periodontitis patients grade 2 according to the new classification. So therefore, the treatment done was root canal therapy, and after 3 months, there was a persistent pocket of 8 mm. Therefore, regenerative periodontal therapy was done using PIF alone as a gradient. After 6 months follow-up, increased intensity was seen for alveolar regeneration. Case 2 describes a 32-year-old male with pain and swelling with the lower right second molar. The tooth of interest 4-7 grade 1 mobility, grade 2 furcation involvement, negative vitality test, and a probing pocket depth of 8 mm on the mesial aspect. Radiolucency around the mesial root till the middle third and in the furcation region was seen. Endodontic therapy was done, and after 3 months, the pocket was persistent. So therefore, guided tissue regeneration was done using collagen barrier membrane with calcium phosphosilicate putty. And at 6 months follow, clinical improvement was seen. Endoperio lesions present a diagnostic and treatment predicament. Periodontal regenerative therapy proved to be successful treating lesions. In one, the use of platelet as a sole graft material proved to be beneficial because the three-dimensional structure of PRF provided a microenvironment conducive to osteogenesis and enhanced the healing phase through the release of growth factors. In case 2, guided tissue regeneration using collagen membrane with alloplastic bone graft ensured the wound was stabilized and the defect was filled. The epithelial growth was prevented and
Can't hear you, madam.
Yeah, even the display also is gone.
I think there is some internet connectivity
Yeah,
issue.
there is some connectivity.
Can we move on to the next one?
Yeah, we can hear from her later, maybe. Just keep on time.
We can.
Yeah. You can move to the
Ravindra, next.
Good afternoon, all. Am I audible?
Yes, please, Shweta.
Yeah.
Continue.
Today I'm going to present a case report on an innovative technique for root coverage using pedicle buccal fat pad. So fat can change the fate of the tooth. Starting with gingival recession, it is the most common and desirable condition and is defined as the displacement of the marginal gingival tissue apical to the cement enamel junction. It causes exposure of as often leads to poor aesthetics, pain, root sensitivity, root case formation, root abrasion, plaque retention, gingival bleeding, and ultimately tooth loss. So for this case, we have used this buccal fat pad as a subepithelial graft for the recession coverage. So moving on to the anatomy, the buccal fat pad consists of 3 lobes and 4 processes. It consists of volume of 10 cubic centimeter, length of 60 mm, width of 50 mm, and thickness of 6 mm. And various surgical approaches are used, such as Matasaro's method, Stozen's method. In this case report, we have utilized this third approach by incising the superior gingival circles. Moving on to the case report, a 38-year-old healthy male patient came to the department with a chief complaint of sensitivity in the upper right back tooth region of jaw for past 6 months. On clinical examination, we can see a Miller's class 1 gingival recession in relation to 1.3, 1.4, 1.5, and 1.6, and with adequate keratinized gingiva and adequate bone support. And there's attachment loss of 2 to 3 mm, but there is no pocket and no furcation involvement, and all the tooth are vital and they are non-mobile. So we are provisionally diagnosed this as chronic localized periodontitis in relation to 1.3, 1.4, 1.5, and 1.6. So the treatment plan, the patient was put into phase 1 therapy. Scaling and root planing was done, followed by oral hygiene instructions are given, and several radiographic investigations and blood investigations were done. So the patient was recalled for surgical approach. So under for recipient side preparation, under LA, circular incision is given, anteriorly extending up to 1.3 and posteriorly extending up to 1.6, and full thickness mucoperiosteal flap is elevated. It's a type of envelope flap, and followed by roots recipient side debridement and root biomodification is done. So moving on to donor side preparation, a 2 centimeter horizontal incision is done in the highest point of vestibule, extending backwards from above the upper right second molar teeth. A blunt dissection is done through buccinator and fascia. So the body of the pedicle buccal fat pad and the buccal extension are gently mobilized without disrupting the capsule and vascular plexus. So we have the main aim is to preserve the base as wide as possible. So the pedicle buccal fat pad was spread over the roots of the right maxillary posterior teeth and canine, and it is adapted and secured tightly with sling sutures using 5.0 Vickrell suture. And elevated envelope flap was advanced, secured, and immobilized to the adapted pedicle buccal flap with a vertical mattress suture, ensuring the flap is free of tension. Then the periodontal pack was placed and the post-surgical instruction was given, and the patient was put under medication. And the patient was recalled under several intervals. So during after 2 months post-OP, we can see an attachment gain of 3 mm. So I'm concluding my topic by saying that is considered as one of the novel application for root coverage. It could increase the gingival dimension with the keratinized tissue in the upper posterior teeth. And this may also allow for the protection against further gingival recession and may be used for the bone regeneration. Thank you.
Yes, Shweta, there's one query from me. What about how does this grafted buccal pad heals in there?
The healing is, according to Fan et al., the healing is done by initially the buccal fat pad is non-epithelious. Non-epithelious, it consists of only candy tissue and fat cells. One, it is pedicled and placed into the oral cavity. So in the first week, we can see the regenerated basal cells appear on the surface of the fat tissue along with the exudated fibronectin. And the second week, we can see the regenerated epithelium is very thin and with a less obvious reticulated formation, and the fat cells are slowly start to replaced by the collagen fibers and the fibroblasts. And then the 4th to 6th week, we can see the buccal fat pad is completely epithelialized. We can see a paracarnized epithelium, and the fully epithelialized by week 5 to week 6.
All right.
Yes. What was? Yeah, madam. आप पूछ रहे हैं?
नहीं, I was calling on you only. Please ask.
What was the difference in the width of attached gingiva or quaintness gingiva did you see?
Initially, the width of in this case, the width of gingiva initially is adequate, but is increased.
How much did it increase? If it was adequate, then why did you think of Tarnow's technique? You said it is what 1 to 2 mm of recession was there.
Yeah, we can see a clinical attachment loss of 2 to 3 mm.
Yeah, clinical attachment loss is different, and recession is different. How much of a recession was there in each case? Do you think clinical attachment loss and recession are the same?
No, sir. We can see a recession of 1 to 2 mm in each teeth, sir. From
1 to 2 mm, rather than taking one more site and doing it, you could have easily done multiple single every tooth Tarnow technique. 1 to 2 mm Tarnow's technique is indicated, no?
Yes,
what
sir.
made you not choose Tarnow's technique?
Sir, but due to the length of the defect, we have used the buccal fat pad procedure, sir.
Pardon? Can you tell me again?
Sir, because it involves multiple teeth, and we can use this buccal fat pad because we have the prognosis is good, sir. High vascularity.
In multiple teeth, you could do individual to multiple Tarnow's technique also. Anyway, thank you so much.
Okay, sir.
Can we go to Vishakha ma'am? कुछ पूछना?
Yes,
we go
please.
to next one.
No, please, next one. Thank you.
Yeah. Hello. Good afternoon, everyone. Can you hear me? Hello.
Yes.
Yeah.
Am I audible?
Yes, please.
Yeah. Good afternoon, everyone. The topic for my poster presentation is direct sinus lift procedures with implant placement. It is a case report. Now, the elevation of maxillary sinus was initially described by Tatum in 1976, and subsequently it was published by Bowen in 1980. The lateral sinus floor elevation with bone graft harvested from intraoral sites was reported by Woodmore in 1998. Now, coming to the requirement, after the loss of posterior teeth, the maxillary sinus expands and lowers down. That is, pneumatization of the sinus takes place, which results in the reduced subantral bone height, which is inadequate to insert adequately long implants. Now, coming to the contraindications, the contraindications include acute or chronic recurrent sinusitis, allergic rhinitis, then maxillary sinus hypoplasia, cystic fibrosis, and maxillary sinus malignant tumors. And medical contraindications include smoking. It is an absolute contraindication. Then immunocompromised patients, medical conditions affecting bone metabolism, uncontrolled diabetes, and history of radiation therapy to the maxilla. Now, coming to the case, a 40-year-old female patient reported to the Department of Periodontology with a chief complaint of missing teeth in upper left back region of jaw since 6 months. There was no systemic relevant history, and the width of attached gingiva was adequate. I have advised patient to for CBCT, and in CBCT reports, the exact height and width of the dimensions of in the region of 4 and 5 were reduced. That is, the height in the region for 4 is 10 to 10.6 mm, and the width is 4.1 mm. In region with 5 to 5 is the height is 4.2 mm and the width was 6.4 mm. Now, coming to the procedure, patient preparation was done, and the maxillary posterior segment was anesthetized by local anesthesia with 2% lignocaine. Then, once the patient was anesthetized, the flap design was done. Then the incisions were made, Vertical incision should be at least 10 to 15 mm anterior to the wall of the sinus, and the palatal incision was made using 15 mm blade extending the distal surface of the canine to mesial surface of the molar, and a four-cornered full-thickness mucoperiosteal flap was raised. Then after elevation, a sterile HE pencil was used to demarcate the outline of the lateral window on buccal plate of the bone. The position of the window was determined by the size and the location of the sinus. The coronal outline of the window depends upon the height of the graft and the length of the implant to be placed, and the location of the posterior alveolar artery. The apical outline was approximately 3 mm above the sinus floor, and the mesial outline of the window was close to the anterior wall, and the distal outline will depend upon the number of the implant to be placed. And then initially the bone marking was done using the piezosurgical unit with the help of DS5 tape. This was followed by deepening of the mark by using piezosurgical unit with SL1 tape until bluish line is visible. The shape of the lateral window was rectangular, and all the border of the window was rounded off to avoid the sinus membrane perforation. Then fractured segment of the bone was taken out carefully and kept inside the saline. Then after the detachment of sinus membrane was done with blunt instruments, sinus curettes or membrane elevating instruments were used. The sinus membrane was elevated carefully on the sinus floor and extending to the anterior and posterior walls with the help of curettes, sinus curettes. Then final elevation was done up to the mesial wall of the height of the expected grafts to be placed. Now preparation, then sinus membrane integrity was checked by asking the patient to breathe deeply while observing the membrane lifting. Now coming to preparation of the implants, osteotomy site was done in the usual way, protecting the raised sinus lining from any damage with the implant drills. B&B company implants were used. First is the first implant was 4 mm to 10 mm in height, and second was 3.5 mm to 10 mm, and then the implants were placed. Now the bone graft was placed. Sera bone, that is natural bovine derived microporous hydroxyapatite bone, was used. 3 cc large particles of this graft were used, and after that the fractured segment of the bone was placed back, and a rapid resorbable collagen membrane, which was 20 by 15 mm, was used. Then the flap was approximated by using resorbable sutures, because the resorbable sutures. Then the first membrane stabilizing sutures were given, and then periosteal releasing incisions were given for primary closure of the flap, and post-operative instructions to the patient was given, and patient was given antibiotics and anti-inflammatory coverage, and was recalled. She was recalled after 7 days, 10 days, and after 1 month for elevation. This is a photo. This is an X-ray immediately after implant placement of the case.
Ashish, any queries?
Madam, this case was done by you?
Oh, yes, sir.
Which year are you in?
The second year.
Second year, you have done sinus lift.
Yes, sir. So I have done it just now, 15 days before.
Okay. Madam, आप पूछो कुछ पूछना हो?
No, nothing. Probably the case documentation is quite extensive there in only. Thank you, Trupti. We can move on to the next, please.
Thank you, ma'am.
Sejal, can we please move on to the next poster?
Yeah, this is the next one. Dr. Juveria?
Yeah, got it. Thank you. Yes, the presenter, Dr. Juveria.
Hello, ma'am.
Yeah, please start.
Good afternoon, everyone. Today, my presentation is on free gingival graft in the management of gingival recession, a case report. The correction and elimination of the mucogingival problems associated with lack of attached gingiva, shallow vestibule, and aberrant frenum. Various mucogingival procedures are used to correct it. Free gingival graft is among them. It is one of the most common techniques for gingival recessions in the areas of adequate gingiva. Present case report is about a systemically healthy 28-year-old male patient with the chief complaint of visible root exposure in the lower front teeth. The patient's oral health and general health was assessed. Intraoral examination revealed the poor oral hygiene, gingival recession in relation to mandibular anterior teeth. His chief complaint was related to gingival recession in relation to lower anteriors. In relation to 3-1, there was class 3, Miller's class 3 gingival recession, and in relation to 3-1 and 4-1, there was Miller's class 2 gingival recession. And the patient gave the history of trauma, which according to him resulted in the gingival recession, and mobility was seen, which was further aggravated by trauma from occlusion from the maxillary anterior teeth, which had prosthesis in relation to from one canine to canine, maxillary right canine to left canine. And complete scaling and root planing was done, coronoplasty was done, and patient was recalled after 4 weeks to proceed with mucogingival surgery. On the surgery there, pre-surgical protocols were followed and profound local anesthesia was established, and sharp dissection was done in relation to 3-1, 3-4-1 with using 15 number blade. The epithelialization of papilla was done. The exposed root surface was planed to remove any necrotic cementum. In this left palatal wall was the donor site. The graft was harvested and it was stored in the cold moistened saline. The donor site was later sutured. The connective tissue graft was trimmed according to the template foil to approximate the recipient site, and later graft was positioned and stabilized above the level of cement enamel junction, and it was held by sutures. Later, periodontal dressing pack was given to safeguard the area. And
that's all.
Yes, sir. 1 week follow-up was done, and it showed slight coverage of result, and patient was satisfied with the result.
Okay. Here I just wanted to ask you again regarding the case selection for the procedure. What kind of recession? What is the class of recession in the current case you're presenting?
Ma'am, in relation to 3-1, it was Miller's class 3 recession, ma'am.
Okay. And what is like the predictability of root coverage in such cases?
Ma'am, partial root coverage can be obtained, ma'am, in such cases.
In terms of objective measurement, how your patient, like from how much it reduced to, because your case is actually not giving an idea. It is little.
Yes, ma'am. Actually, ma'am, this case was done recently, ma'am. 1 week follow-up was done. 1 month follow-up has to be done still.
All right. And there's one more query. What is the most important, significant disadvantage associated with free gingival graft? Dr. Ashish?
मैं आंसर करूं मैम?
No, please ask your query. No,
madam, you have done a free gingival graft. You tell me the aim. What is actually an ideal use of a free gingival graft? For a gingival recession or to increase the width of that gingiva?
To increase the width of attached gingiva.
So, what makes you think that you will be able to increase your cover up recession with the FGG in this case?
Let's work.
What is principle of bridging? What is the principle of bridging? You know, when you use a FGG, first
Yes.
3 days it survives on plasmatic circulation.
Yes, sir. Plasmatic
And then
circulation.
blood supply
Very
starts
quickly.
forming, and by 7th day it is,
Yes,
revascularized.
sir. Yes, sir.
So what is the principle of bridging come into? What does that principle say? What was the thickness? What is the ideal thickness of the graft which you take from palate?
2 to 3 mm, sir.
3 mm. Madam, what is the disadvantage of a thick graft when you do a transplantation with a thick graft? Do you think the plasmatic circulation will be able to provide enough nutrients to such a thick graft when it is transplanted? Would it be able to survive?
Yes.
Yes or yes?
No,
And
sir,
another
it is
last
not.
question which I would ask you is, you said you did some coronoplasty.
Yes, sir.
Just by doing in what did you do in coronoplasty?
We have reduced the height, so since trauma from occlusion was there, sir, in relation to 3.1 and
So what did
4.1.
you do in what did you reduce?
Coronal height we have reduced, sir.
Do you know that when you do coronoplasty, you're not supposed to touch the incisal height of the tooth? You have to do it on the parietal side of the maxillary incisor, and you have to wait for 3 to 4 weeks to see if there is any improvement.
Yes, sir. Sir, he had prosthesis in relation to a maxillary anterior teeth, sir.
So that makes it rather easy. You could have reduced the prosthesis. So what?
Yes.
Anyways, thank you.
Thank you, Zoveria.
Thank you.
Yeah. Now Akanksha comes back.
I think we can directly go to questions now for her.
Yes, yes. I have only 2 remarks for you. Akanksha, are you there? Are you listening? Your question was pending.
Hello, ma'am. Can you hear me?
Yeah. My question to you is, in terms of documentation, I would look forward as a case report that how much resolution was there after the endo treatment, and where did you start for perio? Did you take radiographs after 3 months gap?
No, ma'am. We do not actually take a radiograph after 3 months.
That's necessary. The other thing, what in your view is the difference in the resolution of bone loss of endodontic origin or periodontal origin? Does there any difference exist in the resolution of both kinds, or they are just the same? They heal the same way?
No, ma'am, they do not heal the same way because the tooth initially, when we tested the vitality, it was non-vital, and we wanted to evaluate whether regeneration some form of regeneration would occur on a non-vital tooth as well.
No, and that's besides the point. I am just asking, how will you compare the healing of a periodontal bone loss and endodontic bone loss? That's okay. Ashish, your say, please.
Madam, yeah. Madam, both the cases were the tooth non-vital?
Yes, sir.
Why?
Sorry, sir.
Why? What was the reason for non-vitality?
I think
periodontal disease doesn't cause non-vitality generally.
So there was some form of trauma from occlusion in both the cases.
So trauma from occlusion, does it cause non-vitality? It will cause only non-vitality if it is a severe trauma. Normal TFO doesn't cause non-vitality. And if when you were presenting this, you said there's a periapical radial extension in the first case. Okay. Hello. Are you there?
Akanksha, unmute yourself. No, I think there is again some issue.
चलो हो गया, इसको बार की दोबारा क्यों बुलाना है?
Can Ashish, can we move on to the next?
Yeah, please.
Go ahead. Please
Next session,
Yeah,
49.
Yeah.
Dr. Smriti Gupta.
Yes, please.
The one before this. This is last one.
No, one before this. Surgical management of abnormal sized lingual pregnancy epilepsy.
Not
There's
this.
one more poster. Poster 49.
No, the one after this. No, I would request Dr. Smriti to share your screen and share the poster. Yeah. Backend team, please give her the access.
Hello. Hello.
Yes,
Yeah,
please.
please present.
Yes. Good afternoon, respected chairperson. Myself, Dr. Smriti Gupta. I am here
Be
to
little
present a
louder,
case report.
Smriti.
Yes. Good afternoon, respected chairperson. Myself, Dr. Smriti Gupta. I am here to present a case report on surgical management of an abnormal sized pregnancy epilepsy. Pregnancy epilepsy is a benign exuberant lesion occurring due to exuberation of a tissue reaction to local factors caused by hormonal influence during pregnancy. Its prevalence rate is around 5% and it is characterized by rapid growth corresponding to increased level of circulating estrogen and progesterone. Repeated mild irritation with gestational steroid changes may subsequently exacerbate the inflammatory response, leading to development of the proliferating lesion. Case description. A 27-year-old pregnant patient in her late stage of third trimester reported with a painless swelling in a lower front teeth region since 5 to 6 months, which was interfering with the speech and masticatory function. After intraoral examination, it revealed the exophytic pedunculated growth in relation to lingual gingiva of mandibular incisor in a region of ranging from 4142 to 4344. The clinical examination of the lingual enlargement revealed that it was reddish pink in color, fibrous in consistency with triangular shape, and loss of stippling was seen. Exudate was absent, and it was enlarged to the grade 3 enlargement covering 3/4 or more of crown. According to Buckingham and Bonhurst 1994 classification, it was measuring around 20 to 12 mm, that is around 2 centimeter its maximum diameter. But due to the owing to the large size of the lesion and advanced stage of her pregnancy, the radiographic investigation and excision of the lesion was delayed postpartum. Then, after postpartum, the preoperative preparation of the patient, including scaling and the root planing of the entire dentition and oral hygiene instructions, were given. Then lesion were excised with the help of diode laser of 980 nanometer in a continuous wave output, a power output of 1.5 watt using optical fiber. Then this is a picture showing the excised tissue with a which was sent for a histopathological examination in 10% formalin. And this is the histopathological stain section in 10x magnification. The overall histopathological feature was suggestive of pyogenic granuloma. That is, the histopathological section showed a overlying epithelium with extremely proliferating parakeratinized stratified squamous epithelium and numerous blood vessels, and underlying connective tissue stroma show numerous fibroblasts and moderate collagen fiber bundle. Then this is a picture just after the excision, and this is the post-operative picture, 6 months. The surgical site was examined for uneventful healing. There were no post-operative complication and healing was satisfactory. The patient was sustained with patient was satisfied with the oral with the results. Thus, I can conclude that excision with a diode laser is a conservative and non-stressful approach with minimal intraoperative bleeding and discomfort associated with uncomplicated post-operative healing. Thank you, sir.
Right. Smriti, in what time you took the case to be operated upon?
Ma'am, 3 months after.
3 months after the conception, first into the second trimester.
No, ma'am, just after the delivery, I have done after
Okay,
3 months after delivery.
3 months after. Why such a delay? The patient
Ma'am,
reported.
yes, ma'am. She reported after 3 months when her baby was around.
All right. All right. So, what is the nature of? You have seen the histopath. What is the nature of such a lesion? What histopath reveals?
Ma'am, according to histopathological examination, the epithelial is extremely proliferating and either parakeratinized or stratified squamous epithelium is seen with multiple arcades were seen. And underlying connective tissue was having numerous fibroblasts, and the collagen fiber bundles were moderate, and the blood vessels was
And how long? And how long did you follow up the patient?
Ma'am, 6 months.
6 months. Okay, fine for me. Dr. Ashish.
Ma'am, what is the scientific name for pregnancy epilepsy or pregnancy tumor? When the patient is non-pregnant, you generally call it as pyogenic granuloma or epilepsy. What is when you find it in a pregnant female? What is the name?
So pregnancy tumor.
Pardon?
Or granuloma pyogenic.
Pyogenic granuloma is called it otherwise also. Okay, if you what happens to this pyogenic granuloma if you leave it over a period of time untreated? What changes histopathologically and what changes clinically you will find if you leave this pregnancy tumor over a period of time for next maybe 9 months after the delivery? What changes would you find?
Yeah.
Madam, I can't hear you.
Yes, sir. It can increase in size and.
Okay, I'll ask you one last question, simply in simple terms. When you diagnose this as a pyogenic granuloma now, and if after 9 months of delivery, when you see, and if you see histopathologically, would you be able to diagnose it as granuloma, or will the diagnosis will be something else?
It can convert to fibrous, more of fibrous components, more of collagen, and maybe it
So
can convert to
would the diagnosis change or not? Histopathologically, would the diagnosis change or not? Okay, anyway, thank you so much. We'll go to the next one. Vishaka ma'am, tell me next.
Yes.
Backend team, the last. Backend team.
There's some problem, it seems. Yeah.
No. Yeah.
Last poster of session 5. Yes.
The same one.
Yes. Yes, please start presenting, Dr. Boma Kanti.
Dr. Revati.
I think we can move on to the next. We can pick her up later.
This was the last poster of this
Session
session.
5. Yeah, I know. But because we are already running late, it seems there's no
Yeah.
point wasting time.
Hello, ma'am.
Yeah, she's here.
Yeah,
And
please.
yes, Nida.
Hello, ma'am. Am I audible?
Yes, please. Go ahead. with it.
Yes. Okay. Good afternoon, one and all. My name is Revati. I'm here to present a poster on replantation of periodontally compromised tooth. Starting with the introduction of tooth replantation, it is a form of restorative dentistry in which an avulsed or luxated tooth is reinserted and secured into its socket through a combination of dental procedures. The purpose of tooth replantation is to resolve tooth loss and preserve the natural landscape of the tooth. Coming to the case report, a 26-year-old male patient came to our department of periodontics with a chief complaint of loosening of upper front tooth since 6 months. On clinical examination, there was grade 3 mobility, probing pocket depth of 13 mm, and developmental labiogingival groove in relation to 1-1. After taking proper case history, clinical photographs, treatment plan was made. Under phase 1, non-surgical periodontal therapy was performed. Patient has been recalled after 10 days. Under phase 2, after administering adequate local anesthesia, endodontic therapy of maxillary right central incisor was performed, which was followed by atraumatic extraction of concerned tooth. And then root and resection of around 1 to 1.5 mm was performed and preserved in normal saline solution until thorough debridement was done in relation to 111213, 212223. Then the tooth was placed back into its original socket. On radiographic examination, as there is angular bone loss in relation to 1-1, regenerative flap surgery was performed by placing G-graft and GTR membrane. Then flap was repositioned back using interrupted sutures. To stabilize the teeth in position, sling sutures were given, and at the end, palatal splinting was done in relation to 111213, 212223. And this is the last image after a follow-up period of 30 days. There was a reduction in mobility of replanted tooth and proper alignment of maxillary anterior teeth was noticed. And coming to the discussion, Hamanaka et al. Published a case report on replantation as treatment for extrusive luxation in Brazilian Dental Journal in the year 2015, where there is normal clinical and radiographic characteristics after a follow-up period of 49 months. Raina HK et al. Published a case report on surgical re-entry of an intentionally replanted periodontally
Okay,
compromised
ma'am, you
tooth.
conclude. Leave this discussion. You conclude.
Finally, I would conclude that amount of damage to the tooth and supporting structures, emergency treatment and follow-up period play a key role in the prognosis of replanted tooth. Thank you, sir.
Dr. Ashish, your say, please.
Madam, you tell me, why do you really want to reimplant a periodontally compromised tooth?
Sir, actually, patient is a young age person, so he doesn't want extraction. So we thought of replanting the tooth instead of extraction.
Ma'am, which book do you read for this thing, periodontology?
Karanza, sir.
Karanza's treatment plan chapter says you should not try heroic attempts.
Yes.
And
patient,
secondly, you tell me what is the aim of periodontal therapy? Is it only to save the tooth?
No, sir.
Or
To
the
maintain
function is
proper
important?
functioning is also important, sir.
Do you think he'll be able to function with this?
Actually,
This is the right treatment plan.
no, sir. Actually, the treatment was performed 2 months back. Still, we should see the follow-up period, and then we can come to a conclusion regarding that.
You tell me, is this the right treatment plan for a young patient with so much of a
no,
bone
sir,
loss?
Yes, sir. We can go for implant placement actually. So
why implant? Why can't you go for FPD? Why
yeah,
only
FPD.
implant?
Because
Why can't be
patient,
RPD? Nowadays, the only thing which comes to mind is implant.
yes, sir. But the patient, he's young patient and he's also affordable, so we can go for implant placement also. But we said that we can save the tooth, so he said that he's interested for replantation, and we said the consequences also, sir. It might be a failure, but we are just trying it. We said.
A patient might want anything, but you have to judge, no, whether it is really required or not.
Yes, sir. Yes, sir.
Educate also about the workable treatment options. Basically, longevity is the important question here.
Yes, sir.
That's okay. Thank you very much.
Okay. Thank you, ma'am. Thank you, sir.
We can proceed for the next session, Susan. Thank you.
Yes.
Next session, please.
Yes, please.
Dr. Ankita, Dr. Achal.
Yes, ma'am. Hello.
Yeah.
So with this, let's conclude the session. Then moving on to next session, the chairpersons for this session are Dr. Ashish Kumar sir and Dr. Vishakha Grover ma'am. Please, ma'am and sir, start the session. Thank you.
Yes, yes, please, Ankita. First presenting.
Hello.
Yes.
Hello, ma'am. Is it audible?
Yes, beta, please start your presentation.
Good afternoon, everyone. Myself, Dr. Anusha, and I'm here to present a case report. To begin with, the most important non-verbal method of the communication is the smile. So during the normal smile, 1 to 2 mm of the gingiva is displayed between the inferior border of the upper lip and the gingival margin of the central incisor. So excessive gingival display while smiling, which is commonly referred as a gummy smile, is one of the main cause of the aesthetic embarrassment for many patients. It in turn affects their psychological behavior. It can occur because of the various intraoral and extraoral etiologies. So the present case report depicts the aesthetic management of the gummy smile by the lip repositioning technique. A healthy 21-year-old female patient presented with the chief complaint of the gummy smile and incompetent lips post-orthodontic treatment. Our treatment goal was to minimize the gingival display in her smile. So the patient's medical history was non-contributory and was fit for the surgery. With an exaggerated smile, teeth were visible from the maxillary right second premolar to the left second premolar. In the picture 1, after administering adequate local anesthesia, mucogingival junction is assessed with the help of the probe, and then bleeding points were induced at the gingival zenith of all the teeth, which guide for the first incision. At about 10 to 12 mm, apical to the bleeding points, second incision was given. So both the incisions were connected in an elliptical manner, leaving the frenum intact in the midline, as shown in the picture 2. So the epithelium is removed carefully, and then we place the interrupted sutures along the borders of the incision to ensure the proper alignment of the lip. So once the flaps were stabilized, frenectomy was performed and sutures were placed. No postoperative complications were observed. A is here is a preoperative smile and B is a 3 months postoperative smile. Here are the few studies. Manjunath et al. In a case report described the surgical
You leave
lip
that, ma'am.
reposition.
You leave the discussion part. You just come to the conclusion if you don't have anything else to tell about the case report.
Yes. Okay, sir. To conclude, this technique is minimally invasive, less traumatic, and is a viable treatment option to improve the gummy smile and has a faster recovery time when compared to the orthodontic surgery. Thank you.
That's all. Fine.
Madam, this figure A is preoperative.
Yes, sir.
I don't see any difference between figure A and B.
Exactly.
Only thing difference I see is the in figure A is the central papilla is inflamed, figure B is little less inflamed. And you tell me one thing, I find this case to be a case of passive eruption, delayed passive eruption.
Again, the case.
This is not the case of. This is not the case for lip repositioning. If you had done a proper diagnosis and if you had done a seen a radiograph and done a crown lengthening with bone recontouring, it would have been resolved. This is a. I feel this is the wrong. You tell me what are the reasons for gummy smile? How do you classify the reason etiology for gummy smile?
So it might be due to the intraoral or the extraoral etiology, sir. Intraoral, it mainly depends on the delayed or either the passive eruption of the teeth and the disharmony of the dental arches and the extrusion of the teeth and the short clinical crown length. And extraoral, it mainly depends on the vertical maxillary excess or the short upper lip and the asymmetric or the hypermobile upper lip, sir. So actually, this case was performed after the orthodontic treatment.
You tell me what made you decide you should do a repositioning. I don't find any difference between preoperative and postoperative photograph.
True. That's not evident actually, Anusha. See, surgical skill is important at its own point, and where to apply that surgical skill is another important decision as a periodontist. So I feel case selection is important for this.
Okay. For anything surgery, if I teach a fifth class student also for 10 times, he'll do it. But the difference between him and you would be, you have to know where to apply that particular, how to choose the case or select a case.
Important. That's okay. Fine.
Okay. Next.
Yeah. Anusha, thank you very much. We can move on to the next poster. Yes. Yes, please.
Good afternoon, respected teachers. The topic of my poster presentation is periodontal status in postmenopausal females with osteoporosis. Osteoporosis is characterized by compromised bone strength, measured in terms of bone density and bone quality. Periodontitis is microbially associated host-mediated inflammation that results in loss of periodontal attachment loss. Both osteoporosis and periodontitis share a number of common risk factors.
Just a minute, madam. Just a minute. Vishakha ma'am, this is a case report or a case series? This is a study.
Sir, this was a study conducted by mistake. While submitting it, I pressed case report, and later on I realized that I had submitted it in the wrong category.
Yes, that is.
So that it doesn't come into this category, no?
Yes, sir.
Because this is not a case report.
No, sir. This is not a case report. It was my mistake. I submitted it in a wrong category.
GP sir, इसको दूसरे में shift कर सकते हैं क्या?
So that won't be possible right now.
Sir, because I had a talk with them, they refused it. They said it's okay, let it go like that only. I had a talk with somebody.
So we can discuss it later when we finalize the evaluation.
Okay, we proceed with the presentation and we can take a call later. Yes,
okay.
Roma, you can please share your objectives and conclusions, please.
Objectives and conclusions. Yes, sir. So my objective was the present study was conducted to evaluate severity of periodontitis in systemically healthy postmenopausal women with osteoporosis and with normal bone density. And so material and methods cross-sectional study was conducted in the Department of Periodontics in accordance with ethical standards. A written informed consent was obtained from each patient. Study population comprised of postmenopausal women with osteoporosis.
Dr. Roma, you can please share us the conclusions from the study.
Conclusion, yes, ma'am. Ma'am, the conclusion was within the limits of the study, it was concluded that postmenopausal osteoporotic females had higher attachment loss than females with normal BMD. However, BMD had no significant impact on periodontal inflammation measured in terms of bleeding on probing. Ma'am, should we discuss the results also?
Yes, I just want to see the gist of your study, that actually where did you reach when you took this topic?
Okay, ma'am. Results were there was a significant difference in clinical attachment loss between the two groups, the test group and the control group, with higher clinical attachment loss, that is 4.52 in the test group as compared to the control group. No significant difference in other parameters in both groups were observed. Sites with clinical attachment loss greater than or 5 mm were significantly higher in test group. Sites with further divided into two categories based on the probing depth. Probing depth less than or equal to 4 mm and greater than 4 mm. There was significantly higher proportion of sites with probing depth greater than 4 mm in test group. At sites with probing depth less than or 4 mm, periodontal parameters were comparable between the groups. At sites with probing depth greater than 4 mm, plaque index, gingival index were comparatively higher in the test group as compared to the control group.
Okay. So your takeaway from the study?
Yes, ma'am.
What did you conclude? I mean to say, what was your...
The conclusion was that there was a clinical attachment loss was more in postmenopausal female who were osteoporotic. That is, they had a bone mineral density greater than or equal to 2.5 mm.
What in your view is the clinical relevance of this study? What you as a periodontist need to do in this?
We can see as a periodontist, I can, if a patient comes with alveolar bone loss or a postmenopausal female, I can be more careful and I can guide her for medical consultation if required.
All right. Okay.
Ma'am, your group, control group was what?
Ma'am, sir, the control group was systemically healthy females who had a normal BMD, sir. Normal bone mineral density. That is P-score greater than or equal to -1, sir.
And they were all postmenopausal females?
Yes, sir. Yes, sir. With normal BMD and with osteoporotic females, sir.
Yeah. And did you match the oral hygiene status and the periodontal status of two groups?
Yes, sir. I matched them, sir.
Were they in the similar range?
Clinical attachment loss, bleeding on probing, sir. I took these parameters for periodontal examinations, sir.
Oral hygiene status?
Oral hygiene status was, sir, they were chronic, they were periodontitis was present.
See, two groups, did they have the similar oral hygiene status or not?
Yes, sir. Similar.
How did you measure oral hygiene status?
Sir, by taking the plaque index and gingival index, bleeding on probing, sir, was examined.
Ma'am, bleeding on probing, does it tell you the oral hygiene index?
No, sir.
Oral hygiene
Plaque
status.
index, gingival index, and probing pocket depth and clinical attachment loss were the parameters taken, sir.
Okay, ma'am. Thank you.
Yes, sir. Thank you, sir.
Yes, please move on to the next one.
Am I audible, ma'am?
Yes, please.
Yes, ma'am. I have come here to discuss a topic. Yes, ma'am. Am I audible, ma'am?
Yes, please.
Yeah, please.
Yes,
Thank
ma'am.
you.
Discuss a topic about a case report about bridge flap, a single stone for the management of multiple mucogingival deformities. Introduction is about gingival restriction of multiple antidiabetic is common concern due to the aesthetic reasons. Resistance or root sensitivity. There are various mucogingival surgeries for root coverage procedure, one of which is double lateral sliding bridge flap. The bridge flap is one of the technique used to cover the deteriorated root. It was first described by Samar in 1969 and modified by Margraf in 1981. It is a combination of coronary deposition flap and modified Edlund and Metzer vestibular plastic technique. The advantage of the technique here, it does not require both secondary surgical site and separate phenectomy procedure. A case report, a female patient of 45 age with a chief complaint of residing gums and sensitivity in lower infantile region for past 1 week. So that's we planned the case for bridge flap. Pre-operative image show the class 2 Miller restriction with the indicated with a Jiva in 3141 and R-shaped vestibular incision of 2 into gingival restriction plus 2 mm for the gingival margin. And the thickness flap was elevated in the apicocoronal direction and sulfur incision with contact with the first incision and the whole bridge flap elevated without any vertical incision, and then root conditioning is done with the EDTA and the placement of alloderm, and the flap is coronally advanced. Reposition of the flap coronally with the independent slings which are used. The result is with this technique, the two surgical sites procedures are combined in single technique to cover the multiple resistance in anterior region and simultaneously to increase the width of the gingiva and eliminate the etiological factors. I concluded that the successful treatment of multiple resistance is based on the use of predictable periodontal plastic surgery technique, appropriate case selection, and careful preoperative diagnosis are the prerequisites for improving the surgical success. Multiple gingival resistance is linked to different etiology, which should be carefully diagnosed prior to the treatment. The bridge flap method may be used for successful management of multiple recessions. Thank you.
Right, Dr. Arun, I have only one query because your case is documented well. Only thing I wanted to ask, what is the current status of evidence regarding root conditioning?
Conditioning.
Am I audible?
Yes, ma'am. Audible, ma'am.
Yeah. So what is the current status of evidence in context of root conditioning? No worries. Just look into the literature about that which you have used in your case. Dr. Ashish, your say please.
What was the recession pre-operatively in millimeters? Amount of recession?
Amount of recession is 4 to 5 mm, sir.
4 to 5 mm. And what was the recession at post-operatively?
So it's only the 2 months review only, sir.
So whatever, 2 months also, what was your recording?
It's normally reduced to 2 to 3 mm.
I don't see any difference in pre-operative, post-operative coverage. Well, at least, see, if you are doing a case, how would you, that if you do not know what is the amount of coverage you have achieved, then how would you evaluate a case then? How do we evaluate a case?
It is important.
See, for any treatment of recession, what is the ultimate aim other than coverage? You don't know initial 4 to 5, what was post-operative, you don't know even at 2 months, even when you remove the pack, then also you can measure, it is a visible part, so you can see how much of a recession is there.
So only 50% coverage occurs, sir.
How much it, you don't tell me the theory, you tell me how much of a coverage occurred in your case.
It is nearly 1 to 2 mm only, sir.
1 to 2, 4 mm, that is, you are just guessing, you have not measured it.
Yes, sir.
Thank you so much.
Thank you, sir.
Yes, Dr. Vaishali.
Yes. Good afternoon, everyone. I'll be presenting my poster on minimally invasive treatment for isolated soft tissue defect progressing to the mucosal fenestration using IPRF. The mucosal fenestration is clinical condition in which the overlying gingiva is denuded and the root is exposed to the oral cavity. The mucosal fenestration are considered an uncommon complication of the pulpal periradicular disease. The etiology of these defects are unclear. However, the predisposing factors include the buccal inclination of the root tips, very thin or non-existent buccal cortical plate combining with chronic periradicular inflammation. The incidence of the apical fenestration is between 7.5% to 20%, and it is higher in the maxillary than the mandibular tip. As IPRF shares the similarities with PRF in terms of tissue regeneration and minimally invasive treatment. So the aim of this study was to evaluate the effect of IPRF using the microneedle on soft tissue defect progressing to the mucosal fenestration. IPRF acts as a scaffold for the wound healing, and it comprises the well-controlled release system for growth factors that sustain the proper bioactivity over the healing period. And it plays a key role in the tissue repair, also induces the higher fibroblast migration and expression of the platelet-derived growth factor, then transforming growth factor beta and collagen 1. Clinically, the IPRF is used to increase the gingival thickness, to repair the gingival defect, and re-establishing the continuity and integrity of the keratinized gingiva. So I hereby report a case of 48-year-old male patient who was referred from the Department of Endodontics with a chief complaint of pain and discomfort. On clinical examination, it showed a thin mucosa exposing root surface on apical 1/3 of mandibular central incisor. Following diagnosis was given as isolated soft tissue defect progressing to the mucosal fenestration. Initially, the patient had undergone a root canal treatment. After that, frenal and muscle attachment were relieved. At the site of fenestration, IPRF was injected using microneedle, which was prepared by low centrifugation concept at 700 revolution per minute for 3 minutes at room temperature. Then IPRF was immediately aspirated using the microneedle, injected at the site till the blanching and the fullness of the gingiva was noted. This procedure repeated for 3 times and at an interval of 7 days. The patient followed after 1 month and reported a complete coverage of exposed root surface with an increase in the tissue bite. In coming to the conclusion, previously mucosal fenestration was managed by invasive procedures like free gingival graft, then connective tissue graft, and guided tissue regeneration. This case report shows a viable and alternative treatment option that can be effectively considered in the management of the cases that are progressing to the mucosal fenestration. Thank you, sir.
Dr. Ashish, please your say.
Ma'am, how do you think IPRF would stay at that place?
Yes, sir.
You injected IPRF, no, in that
Yes, sir.
fenestration defect.
Yes, sir.
How do you think it would have stayed at that place? What is IPRF? Injectable PRF? It is what form?
Sir, it is in the it forms the dynamic fibrin after injection.
Do you think it will stay there?
Yes, sir.
I doubt.
It coagulates after the injection, sir, and it forms the dynamic fibrin, which releases its growth factors, and then there is a healing or regeneration of the tissue.
And when this was referred to you, was the tooth RCT treated? Was the RCT
Yes, sir.
done?
It was initially RC treated. After that, then it is referred to our department. Then we relieved the muscle attachment and the which are coronally attached.
Okay, madam.
After that, we prepare the IPRF and injected at the selected site.
Vishaka, madam.
Nothing from my end. Please, thank you.
Okay.
Vishali.
Next one.
Thank you.
Good afternoon, one and all. Topic for my poster presentation is aesthetic outcome following surgical management of inflammatory gingival enlargement, a 1-year follow-up case report. Gingival enlargement are of special concern to the patient and dentist because they pose problem in plaque control, function, and aesthetics.
Have you directly
With the
come to,
most-
don't give a history, you directly come to the case.
Okay, sir. With the chief complaint of swollen gingiva in a 32-year-old female patient, for the past 6 months, which bled while brushing, she refrained from brushing and size increased further. No relevant drug history was reported and patient was systemically healthy. On clinical examination, gingival enlargement confined to interdental papilla and marginal gingiva on the labial side of anterior region of both the arches presented with a bluish red, smooth, shiny surface, and bleeding on slight provocation was observed. With the plaque index of 1.67, gingival index of 2.45, probing pocket depth of 3.79, and clinical attachment loss of 1.95. Pseudo pockets were observed. Radiograph revealed bone loss in both the arches. Now, after completion of the phase 1 therapy, surgical excision was performed in both the arches. Suture removal was done after 1 week, and patient was recalled after 1 month, later every 3 months for up to 1 year. Oral hygiene maintenance was reinforced at every visit. For results, knife edge margins with the normal shape and size of the gingiva were achieved after surgery. Interdental papilla receded, creating a black triangle which was anesthetic in the maxillary central incisor region. Patient was motivated to strictly follow the oral hygiene instructions, and after 1 year, interdental papilla fill was observed. This report highlights the success of surgical procedure and importance of the oral hygiene maintenance in gingival enlargement cases. There should be long-term follow-up to evaluate the tissue response and patient motivation in the management of inflammatory gingival enlargement cases.
Dr. Aparna, do you have the documentation after non-surgical therapy?
Yes, ma'am, I do have.
No, on the poster here.
Ma'am, no, it is not there in the poster.
Okay. All right. And the surgical approach taken for this, what was the surgical technique opted for this procedure?
Ma'am, it is the flap operation, which is a simple variation of the flap operation. Internal bevel incision was planned, and to excise the excess tissue that was there.
And since you could see no drug history, any other causes of the patient ruled out?
Yes, ma'am.
What all?
Ma'am, this case was diagnosis was confirmed on the basis of histopath report.
No, not histopath. In the patient's clinical history, did you ask or rule out any other?
Yes, ma'am. We asked for systemic conditions of the patient and drug history.
All right, Dr. Ashish.
Madam, you said what was the pocket depth and the attachment loss?
So pocket depth was 3.79 and clinical attachment loss was 1.95.
Ma'am, with the pocket depth of 3 point this thing and with pseudo pocket, do you think surgery was required? What does Linde's? What do you call that? Linde, you know something? Linde had given some critical pocket depth.
Yes, sir. Actually, after completion of the phase 1 therapy, there was a reduction in the inflammatory component, and
then, madam, then maybe pocket would have reduced still.
Yes,
where
sir.
does the surgery come in, madam? With 3, see, your pre-operative pocket depth is something. Okay, I say 4 also.
Yes, sir.
Is the surgery indicated when your pocket depth is 4 and when you have a pseudo pocket component also?
That is why I asked for the results of
sir, even after reduction of the inflammatory component, pocket depth does not reduced. Actually, it was the edematous component that goes off.
So
There was not much
you don't
difference.
require a flap surgery for that, madam. You don't require a flap surgery for that. Edematous component can be treated by gingivectomy, gingivoplasty.
So edematous component was gone after the phase 1 therapy. It was the
That is what I'm
fibrous
telling,
sponge
no?
tissue. It was the
Yeah,
fibrous
after
sponge
phase
tissue
1
that was left.
therapy, edematous component will go after phase 1 therapy. Okay.
Yes, sir. Yes, sir.
And little
Yes,
bit
sir.
swelling, whichever is written, if you want to reshape it, you could have used it. But with 4 mm of pocket depth, do you think surgery was indicated?
Because probably given a good non-surgical and a good oral hygiene instruction, maybe you could have avoided the surgery.
But ma'am, I have followed my patient with the phase 1 therapy. I have taken 5 or 6 sittings for the phase 1 therapy. And even after that, fibrous component was there, which was quite anesthetic in the anterior region.
So that is that fibrous component only I wanted to see. That is why I asked them after the non-surgical what was the picture. Because that would have
What is
been
critical pocket depth? Can you tell me that?
Yes, sir. For surgery, it is 3.9.
For you, because you want to justify, you had made it to 3.9. Very good.
No, sir.
So
No,
you are
sir.
questioning Linde. Wow. Very good.
Sir, actually, no, sir, 3.9 is not. It is 5 mm critical pocket depth.
Okay, madam, it is 4.5, but then you're contradicting yourself. No, if they say anything less than 4.5 or 5 mm, you really don't require a surgical treatment.
Sir,
Anyways, thank you so much. Thank you so much. Okay. Anything else, Vishakha ma'am?
No, not at all. That's okay.
So next one.
Please go next one. Go ahead with the next one. Yes. Yes, Dr. Deepika. Please start your presentation.
And please directly come to the case. Don't give us an introduction. Why, what is grade 2 furcation and all.
Dr. Deepika, are you here?
Yes, ma'am, she's here.
Okay.
Dr. Deepika?
Yes, ma'am.
Yeah, please start your presentation.
Yes,
now, show your case right away. What is the case?
A 22-year-old female patient was reported to the Department of Periodontology with the chief complaint of pain while chewing in lower left back tooth region since 2 to 3 months. On the clinical examination, their horizontal probing depth was 7 to 8 mm, and in radiograph, there was grade 2 furcation defect. On the basis of the clinical or radiographic examination, a case of grade 2 furcation associated with primary endo secondary perio lesion with respect to 3-6 was made. A clavicular incision was placed, followed by flap reflection. After thoroughly debridement, photosensitizer dye, toluidine blue was injected in the furcation region. Then irradiation with the 940 nanometer diode laser was done. Graft and PRF was placed in the furcation region. We have taken 15 days post-op. Then after 2 years, there was pocket depth was improved from grade 2 to grade 1 and from 8 to 3 mm respectively. Conclusion is this case report could lead future researchers to employ antimicrobial photodynamic therapy as a new regenerative treatment and evolutionary technique for preserving teeth instead of dental implant as an aggressive and expensive treatment. Thank you, ma'am.
Deepika, after PDT, you have gone for a graft placement also.
Yes, ma'am.
So why do we recommend PDT as a new regenerative treatment? Basically, you have utilized both these techniques.
Yes,
and I'm sorry to say your X-rays both. One of them, they are not in the same. You need really reproducible X-rays to see the change, especially in grade 2 furcations. You have to be really meticulous.
Okay, ma'am.
May I ask something? In the radiograph, preoperative, just besides the molar, you find a tooth which is partially cracked or restored.
Yes, sir.
Yes.
That is 5, I think so. Isn't it?
Yes, yes.
Yes, sir.
And the lower X-ray, the 5 is complete, total with no restoration, complete crown, and that looks to be natural tooth. Are the X-rays for the same patient?
And
yes, sir.
Yes, please, Deepika.
Yes, sir. Yes, ma'am.
Please explain what sir has asked.
Sorry, sir.
Madam, I don't think the X-rays are of the same patient.
Actually,
you see
they are put in the other way. One, I will say the reverse side of the X-rays. It's not the same side of X-ray.
But 5 don't look to be anyway. And the X-ray, I don't know the kind of bone loss which is seen. It was what kind of grade 2 perforation you say?
Sir, X-ray get.
But it does see one root shows bone loss almost up to the mesial root, if I say up to the apex in the application area.
Yes.
Okay.
Yes,
so
sir.
I don't think so. You would find a grade 2 perforation in this.
It doesn't look like grade 2.
It is absolutely grade 3 or if there was a recession, it was grade 4. It doesn't look to be grade 2 also.
Yes, definitely.
Now, what is grade 2 perforation?
Sir, grade 2 perforation is called Lee-Sack type lesion.
What does it mean?
Sir, clinically we can't appreciate, but radiographically we can.
Clinically we can't appreciate. What are you talking?
Sir, radiographically we can or not. Okay.
No, Deepika, by definition, grade 2, you're not able to share.
Sir, distinct horizontal destruction of perforation area.
What does, madam, clinically, if it is difficult to find a perforation, it will be grade 1, not grade 2.
Sir, partially penetration of probe.
Yes.
When you don't know, then do you think in this radiograph, it doesn't look to be grade 2?
X-ray does not reveal this to be grade 2.
Yes. And how much of a Photoshop has been done to cover up this perforation in this? The radiograph also doesn't seem to be the same.
No,
anyways, thank you so much.
Yes, sir.
Yes, please. Who's next? Presenting?
Hello, ma'am. Am I audible?
Yes.
Yeah.
Okay, ma'am. Good afternoon to one and all. Today, I'm here to present my case report about a multifaceted approach for the management of class 3 gingival recession by using a combination technique of splinting, coronally advanced flap, as well as vestibular extension procedure. So, coming to the case report, here I have a 37-year-old female patient with the chief complaint of tooth sensitivity and elongation, along with the anesthetic appearance. So, a clinical evaluation shows Bleedy Miller's class 3 gingival recession on 4142, 3132, along with grade 1 mobility on 31 and 41, with the vestibular depth was inadequate and inadequate attached gingiva, and the frenum was a papillary frenal attachment. So the treatment of choice was splinting, coronally advanced flap, along with the vestibular extension procedure. So coming to the procedure, first we did a pre-surgical therapy of splinting. First one was the pre-operative picture. The first one was the pre-operative picture, and the step 1 was the splinting. Here we did a composite splinting to obtain a pleasing aesthetic effect, as well as to obtain to reduce the mobility. And coming to the surgical part, first we made a horizontal incision on the mucogingival junction extending from the 4-2 to 3-2. Later on, a flap was partial thickness flap was carefully undermined from the mucogingival junction towards the interdental papilla by keeping the tip of the papilla intact. Afterwards, the PRF was placed under the undermined flap. A periosteal fenestration was also done. Afterwards, the lip mucosa was sutured to the inferior part of the periosteum, and the mobilized flap was stabilized by using anchorage suture on both the ends. Later on, the mobilized flap was fully stabilized by giving continuous sling suture. Here, the bite was taken from the periosteum and was anchored towards the tooth, and the continuous sling suture was placed. Afterwards, the co-pack was placed, and the step 10 shows the review after 1 week, where we can see satisfactory healing, and the step 11 we can see the review after 1 month. So here, by doing a single procedure, my case report presents that a combination of splending coronally advanced flap along with the vestibular extension procedure shows about 90% recession coverage, along with the advantage of increase in the vestibular depth, increase in the attached gingiva, decrease in the frenal pull, as well as decrease in the mobility, along with a pleasing aesthetic effect.
Dr. Ashish, please.
Madam, this first where you have shown this 12 photograph, first photograph and the second photograph, what does the second photograph show? I can't read it.
Sir, the first one was the pre-operative and the second one was after splending. I did a composite splending to obtain a aesthetic effect as well as to reduce the mobility. I just did a
how did you close these spaces between the teeth with splinting?
Sir, by using composites, composite build-up.
Okay, what was the pocket depth of these cases where you wanted to do the session treatment?
Sir, the pocket depth was for the 4-1 and 4-1 means 4-2 and 3-2. The pocket depth was 3 mm, whereas the 4-1 and 3-1 it was about 4.1 mm pocket depth.
Why have you not shown radiographs? What was the distance of bone from cemental enamel junction in these cases? Interproximal bone level.
So I have a radiograph, but the bone loss was almost 3 to 4 mm, sir. Hello?
Yeah. I'm listening, madam.
Yes. 3 to 4 mm was there, sir.
And what is the latest, what this is, you have said Miller's class 3 classification, no?
Class 3, yes, sir.
Now, what according to new classification system is the latest classification system we are supposed to use?
So it's Mahajan's classification, modification of the Miller's classification.
Which one?
Mahajan's modified Miller's classification.
Mahajan's in the new classification, Dr. Nisim. Classification 2017.
They have advocated the use of one particular classification for defining recession. Now, what is that classification?
RT1, RT2. What does that stand?
Sir, ma'am, I can't hear you.
Since your case is on this session, you must know those categories as given in the new classification. RT1, RT2, something. What is the grading?
Do you know any Indian authors who have proposed classification of recession? Anyway, thank you so much.
Nisim, you must read the literature, Indian as well as international, on classification of recession. Dr. Ashish himself has given a modified classification for gingival recession, and it is quite elaborate to almost cover each kind of clinical condition.
Okay, ma'am. Thanks.
All right. Next one, please.
Hello, I am available, ma'am.
Please present.
Yes, please.
Okay, ma'am. My poster presentation today and case report, aesthetic enhancement, smile design procedure with external bevel incision gingivectomy, a procedure. In the introductions, the appearance of the interior teeth has a significant psychologically and emotional impact on the patient, owing to their excessive gingival position within the dentition in the common aesthetic problem.
Come to the case, Dr. Chandrasekhar. Please tell us your case.
Okay, ma'am. A smile design procedure. And the methodology, the clinically the patients coming in the perio department and the patient complain in the excessive gingival display of the maxillary interior teeth. In this situation, the clinically 2 mm the gingival sulcus depth was recorded in the upper interior region, and then the biological width was calculated by transgingival probing under the local anesthesia. After the treatment plan was presented in the patient, and alginate impression was the taken, and was then for the fabrication stand is upper interior region according to the gingival zenith. In this situation, the fabricated template are placed in the intraorally and marking the gingiva of the excessive gingiva, and then the continuous external bevel incision and giving excision tissue. and then the removing the excision tissue, and then the reepithelialization of the remaining gingiva, and then placement of the periodontal plaque. And the follow-up patients are removing the periodontal plaque for 1 week and 3 months. And this is my case report is conclusion. The excessive gingival depth in the associated with the different etiological treatment, external bevel gingivectomy to remove the excess gingiva tissue and to restore the normal tooth dimension and the dentogingival relationship.
So
Thank you.
questions from my side, but again, I will highly recommend that you must look into the etiology of case. Case selection for such cases is really important.
Yes, ma'am.
I don't know why you tell me one thing, ma'am. मैं पूछूं एक question?
हाँ जी, please, sure, sir.
मैडम ये सर आप एक बताएंगे बात कि ये एक्सटर्नल बेवल जिंजिवेक्टमी के लिए आपने स्टेंट क्यों बनाया? मुझे समझ में नहीं आई बात. I couldn't understand that.
Sir, actually, sir, this is the smile design in the properly patient is want to aesthetic. In this situation, मैं sir जो aesthetic gingival zenith के accordingly मैंने gingivectomy किया.
What was the use of stent? What is external bevel gingivectomy?
The external bevel incision in the apical to the coronal.
Where have you marked the bleeding points? What was the pocket depth before deciding external bevel gingivectomy?
Your incision will be guided by what, your stent or the bleeding points?
And what is the prime indication you should look for before deciding external bevel gingivectomy to do crown lengthening? What is one prime indication which is to be looked at? If you have to really go in for private, you tell me that.
Okay, sir.
Okay, what okay? Okay, you have to look for.
Sir, this is the gingival zenith are measurement, sir, and alginate impression cast is prepared. And the gingival zenith according.
You tell me, boss, what is the bleeding point for? What was the pocket depth when you did external bevel gingivectomy? What was the pocket depth? What is the role of stent in the pocket in the external bevel gingivectomy?
Sir, total pocket depth is 5 mm, and then the removing the 2 mm of the gingiva.
So how did you do that? Where I don't see anywhere from the what do you say, bleeding points. Anyways, thank you so much. I will go to next one.
Thank you, sir.
Yes, please. Yes, please.
Yeah, please, next one. Can't hear, madam, can't hear.
Sanjay, please. Is there any issue?
If this is not, they will go to next one and then we'll come to the last
yes,
one.
Please, Sanjay. That's what I will say.
Yeah.
Hello, am I audible, sir?
Yes, please.
Good afternoon, one and all. I am presenting a case report on papilla reconstruction with platelet-rich fibrin. Coming to the case report, 22-year-old male patient came with a complaint of food lodgement in upper front teeth region. So after scaling and root planning, on examination there was a class 2 papilla loss in relation with in between 2-1 and 2-2. After achieving adequate anesthesia, we have given semilunar incision near the mucogingival junction, and from there, partial thickness dissection was done and a pouch was created. After that, a full thickness incision was given, circular incision was given, but keeping the papillary tip of the papilla intact, and from there, full thickness dissection was done, so that the gingivopapillary complex got released and it can for the coronal advancement. After that, 5 ml venous blood was taken and PRF plug was prepared, and it was tucked inside the pouch, so that the dead spray created by the coronal advancement of the gingivopapillary complex gets filled with the PRF. After that, the sutures were placed and periodontal pack was given. Here are the result after 1 week and 3 months. We can see that the 100% reconstruction of papilla was achieved in this case. Concluding that the use of semilunar incision with petal-rich fibrin for augmenting the lost interdental papilla in the anterior aesthetic zone gave good patient acceptability because of minimally invasive technique, plus platelet-rich fibrin was used. So there was no need for the second donor site morbidity. And enhanced wound healing. Thank you, sir.
Who gave this semilunar coronary position flap?
Turnau and ma'am, Turnau, sorry ma'am, Han and Takei gave in 1996. But they have used connective tissue graft with it.
So there is routine semilunar coronary flap also. And did you use a suture on this?
Yes. Yes, ma'am. I have given
what
5
was the need? What was the need of suture?
Because, ma'am, when I placed the plug inside the pouch, it was coming out, so it should stay in the place. So I have closed the pouch with the suture. Plus, for coronal advancement, also I have given the suture with the composite hold.
All right, Dr. Ashish.
Madam, how did you diagnose this case?
Sir, first I have done scaling and root planning, and after that I have seen that.
How did you diagnose that this papilla reconstruction requires a periodontal treatment? Papilla loss means there will be a space between the contact point and the the gingival 1/3 of the tooth. You will find this black triangle kind of a thing, no?
Yes, sir.
That is what you're talking about, no?
Yes, sir.
How do you diagnose that this requires a periodontal treatment? What made you come to conclusion that we should use a periodontal treatment to treat this black triangle?
Sir, after curettage also that space has not got closed, and there was the space, and plus
just
the contact
curettage will decide. Just because your curettage is not regenerated, you should do a surgical treatment. What was the? Did you take a radiograph?
Yes, sir. I have seen the radiograph. There was.
Did you see the radiograph?
I have not placed it in the poster, but.
What did you? Okay, you did not place it. What did you take the radiograph for? What all things were to be noted in that radiograph while deciding the treatment modality? Huh?
For the bone loss, sir.
Only bone loss.
If the
what was the distance? What was the distance between?
Sir, it was 3 millimeter from the contact point.
Wow, what a great distance it is. Then with 3 mm of distance, no, the gingiva should have covered the half of crown also. Up to 5 mm, you don't have a black triangle, madam. What are you talking? 3 mm, you know what the Starno study says? Up to 5 mm, you will find papilla in 100% of cases. And your distance was just 3 mm. That means gingiva should have overflown the interdental area and gone onto the tooth also. You don't know how to diagnose the treatment, how to come to a treatment modality when you have a black triangle and you directly go on to high funda procedures of papilla reconstruction, that too by PRF. This is really very, very surprising. Anyways, thank you so much. I have no questions. Vishaka ma'am?
No, nothing. Please, last one.
Hello.
Yes, Pooja,
Yeah,
that's
ma'am.
fine. Please move to the next poster.
Thank you, sir. Thank you, ma'am.
There's one more poster left, no?
Ranji, there's one poster 59.
Yeah, 59.
She
Anyone
has
there
joined.
from?
Hello, am I audible?
Yeah.
Yeah.
Dr. Bansal? Yeah.
Yeah. Good afternoon, everyone. The topic for my poster presentation is comparison of healing in frenectomy procedure with scalpel, electrocautery, and laser. The aim was to compare the post-operative healing in patients after frenectomy with scalpel, cautery, and laser. So in this, 3 patients with aberrant renal attachment in the maxillary anterior region was selected. And the first patient was a 25-year-old male patient. He was referred from the Department of Prosthodontics for crown landing in respect to 2-1. On clinical examination, we saw that there was an aberrant frenum attachment. The tension test was positive. Therefore, the frenectomy procedure was planned with the scalpel technique, where the area was anesthetized, the frenum was held with a hemostat, and excision was carried out by a number 15 blade. The wound was closed with 30 sutures, and a dressing was placed.
Doctor,
The
please
second patient was
let us know the findings. What differences you find amongst the 3 techniques?
Yes, results you tell. Yeah.
Okay. So the results showed that healing was with primary intention in the scalpel technique and with secondary intention in the electrocautery and laser technique. The bleeding was more seen in the scalpel technique and it was least seen in the laser. The patient did not require any analgesics to be taken after the laser procedure, and there was no post-operative swelling seen in all the 3 techniques. Therefore, in conclusion, all the 3 methods can be used successfully to treat the aberrant frenal attachment. As with scalpel technique, there was more intraoperative bleeding and postoperative pain. With the use of cautery, there was less intraoperative bleeding and postoperative pain, and laser provided better patient comfort in terms of minimal intraoperative bleeding, pain, and operative time. All these findings indicated that laser and electrocautery are ideal for frenectomy. Thank you.
All right. In your view, why using 3 techniques, three different techniques? Still, you could not find any differences. I'm say really significant differences amongst the procedures.
It was not that drastic, but the pain was less in the post-operative pain was less with the laser technique.
What I intend to say, what all factors actually, if you are planning to evaluate these 3 surgical techniques, what all factors will be determining that you may find, because your procedure is also a minimal, very minor oral surgery, and what uniformly you have come across is the oral cavity. Healing in the oral cavity is miraculous by the God's grace. So here, with such a minor intervention, I don't feel actually you will be able to find much differences here. So if you really want to analyze, probably the techniques should be a little you can say greater surgical intervention than this in such a minor surgery. Hardly there will be any differences anyhow. So that's all from my side. Nothing much. Dr. Ashish.
Madam, first of all, you have not used any objective criteria to evaluate healing. Swelling was less, pain was less, are all subjective criteria which do not give a correct result.
Yes, sir.
So what basis do you say healing was better? Secondly, if you say there was a primary closure in a scalpel case, and then you say healing was better in, you say in laser, pain was less. A secondary healing pain would be less compared to a primary healing. You could have easily used H2O2 test, or you could have used a toluidine blue test to test healing, whether the closure has taken place or not. As it was a secondary healing. You apply toluidine blue and see, you apply H2O2 and 3% H2O2, and you can very well see whether the healing has taken place or not. You have not used any objective criteria to test healing.
There are indices also to check the healing process.
And regarding primary closure, I don't know, but maybe I don't know frenectomy. I have not done frenectomies and surgeries, but in any frenectomy, primary closure is only on the side of the lip. The gingival side, you never get a primary closure.
Yes. True.
You have to leave it open. It heals by secondary intention only. The part of the part of frenum which is attached to the attached gingiva part and the gingival part, you don't get a primary closure on that. Vishaka madam, milta hai kya uske?
No, you are right.
So where do you say it is a primary closure?
It's on the lip side only.
Lip side only, and even at the base of the vestibule, sometimes you're not able to close it.
True.
And with the kind of photograph you have shown in the fourth one, you will never be able to close it with a primary closure. Anyways, thank you, madam. Thank you so much.
Thank you, sir. Thank you, ma'am.
Sejal, I think we are done with the session.
Yeah.
Yes, ma'am.
Last one.
Thank you, sir. Thank you, ma'am, for chairing the
Thank-
session. Take care. Stay safe. Thank you, sir. Thank you, ma'am.
Thank you for considering us good enough for this chairing.
Thank you. Thanks a lot,
Thank you.
Deepika. Bye.
Yes, ma'am.
Thank you, GP sir.
Thank you, Dr. GP and tech support.
And tech support. Thank you so much.
Thank you. Take good care. Bye.
We have completed exactly in 2 hours.
Yes, I saw that.
So, good afternoon to all of you. On behalf of Indian Society of Periodontology, I invite you all to the 19th. Yes. Hello, sir.
Sir has logged out.
Okay, so should I continue?
You continue.
Ha,
Yeah.
Okay, so beginning with the session, the chairpersons for the session are Dr. Komal Puri and Dr. Nandini Bhaskar. Dr. Komal Puri ma'am has completed her graduation in 2007 and post-graduation in 2012. She is a reader in the Department of Periodontics, Institute of Dental Studies and Technologies, Modinagar. She has presented various papers and posters in national and international conferences and has also chaired scientific sessions in the same. She has many publications in both national and international journals, authored a few books, and is also a reviewer of an editorial board member to reputed national and international journals related to the field. Dr. Nandini Bhaskar ma'am is a graduate and postgraduate from Government Dental College, Amritsar, Punjab. She is presently working as an assistant professor in the Department of Periodontics, Punjab University Dental College. She has few publications and paper presentations to her credit and is a reviewer to various dental journals. She has been a member of Board of Studies, Punjab University. Welcome, Dr. Komal ma'am. Welcome, Dr. Nandini ma'am. And we should get started. So please start the session. Thank you.
Thank you so much, Ankita. Thank you.
Thank you, ma'am.
Am I audible, ma'am?
Yes, please start.
Good afternoon, everyone. Topic of my paper presentation, poster presentation is management of endoperial lesion with a regenerative procedure using a GTR and demineralized bone metric xenograft, a 2-year follow-up study, a case report. Endodontic periodontal lesion is a clinical manifestation of pathological or inflammatory intercommunication between pulpal and periodontal tissues via open structures such as apical foramina, lateral accessory canals, and dentinal tubules. Severe periodontal disease may initiate or exacerbate inflammatory changes in pulpal tissues. Conversely, persistent infection in the pulp tissue leads to secondary infection and breakdown in periodontium. A 38-year-old patient reported to a Department of Periodontics complaining of pain and mobility. Clinical examination revealed gingival inflammation, post-discharge, deep periodontal pockets, and grade 1 mobility of 4-1 and 4-2. Vital pulp testing was done to assess tooth vitality, which were non-vital. IOPA radiograph of 4-1 and 4-2 showed angular bone loss extending up to apical third of 4-1 and 4-2. Based on clinical and radiographic findings, a diagnosis was made as primary periodontal disease with a secondary endodontic involvement in relation to lower anterior teeth with a severe attachment loss. These type of lesion treated by periodontal and endodontic therapy, followed by open flap debridement of the defect. placement of demineralized bond matrix and graft. A bioresorbable GTR membrane was then used to cover bond defect. Sutures are placed to secure the flap in original position. This combined treatment resulted in a minimal probing depth and maximal clinical attachment gain, as well as radiographic evidence of alveolar bond gain. This case report demonstrates that proper diagnosis followed by removal of etiologic factors and utilizing a GTR technique combined with osseous grafting will restore the health and function of tooth with a severe attachment loss caused by endoperioral lesion. Conclusion: GTR membrane technique combined with bone graft, the result was clinically successful after 2 years of follow-up period. From clinical and radiographic findings, the result of this combined technique was quite impressive, resulting in a significant bond fill and reduction of probing power. Thank you, ma'am.
Dr. Komal, आप पूछेंगे?
Yes.
Yes.
How did you come to the conclusion that your case was primary perio and secondary endo lesion?
Based on radiographic evidence, bone loss was extending from crest to apex, and present an absence of there was no loss of coronal integrity.
Why was it not the reverse, primary endo and secondary perio lesion, or a combined lesion according to you?
After RCT, the periodontal findings were not resolved.
No, I'm asking about the diagnosis, not the treatment part. So according to you, in such cases,
radiographic evidence.
Okay. So according to you, in endoperio lesion, which lesion should be treated first? Is it the endo treatment should be done first or the perio treatment should be done?
Endodontic therapy will be done first.
Why? In all the cases? In all the endoperio lesions, you go ahead with the endo treatment first? Okay, in your case, for how long did you wait after the endo treatment?
So 1 month.
Why?
Hello, ma'am. 1 month.
Why did you wait for 1 month? That's all from my side. Dr. Nandini, if you want to ask anything.
Which membrane did you use? Hello?
Hello, ma'am.
Which membrane did you use? GTR कौन सा यूज किया आपने?
मैम GTR membrane
कौन सा यूज किया? Did you secure it? उसको secure किया, कैसे place किया? And what is the role of vitality in case of endoperio lesions? Why vitality of tooth is important? Pulse vitality. ठीक है बेटा, next आ जाओ.
Good afternoon, ma'am.
Start.
Okay. My presentation is on squamous cell papilloma and hard palate. Oral squamous papilloma lesions are induced by these are benign proliferating lesions induced by the human papilloma virus. The lesions are painless. The lesions are usually painless, soft, and slow in growth rate progression. Which looks like which have appearance of cauliflower-like appearance, exophytic nodule. The most common site of occurrence is on hard palate, tongue, and uvula. These lesions are usually asymptomatic and which have slow progression. This case report presents the case of 50 years old male reported to the Department of Periodontics in the Dr. Sudha Nageshwara Institute of Dental Sciences. The squamous papilloma is present at the junction of hard and soft palate. For soft palate, and it was surgical excision was surgical excision was done and sent to the and biopsy was sent to the for histopathological analysis. There we found a proliferation of keratinized stratified squamous epithelium arranged in the finger-like projections into the fibrovascular connective tissue or to the core of the connective tissues. And also we have observed coelocytes. These are the virus altered cells which have pycnotic nuclei. Generally, the treatment of oral squamous cell papilloma are done with surgical excision, usually cryotherapy or electrocautery.
Okay. Which type of HPV कौन सा वायरस है जो commonly associated है with squamous cell papilloma?
HPV 6 and 16 are most commonly seen in oral squamous papilloma lesions, ma'am.
And do you have any information regarding the HPV vaccines?
Yes, ma'am. Ceradravix was used for. There are two types of vaccines, madam. One is used for normal papilloma, general. Another papillomas which are for genital papilloma, I don't know, madam. For normal papilloma, we will use Ceradravix like that.
Okay, Dr. Komal, आप पूछ लीजिए.
What is the pathogenesis of the squamous cell papilloma?
So usually there are benign, madam. Usually when they are left untreated, they will increase in size, madam.
No, but, what happens, like you're saying it occurs because of human papilloma virus. So what happens if HPV enters? What happens after that? Are there any receptors associated? Which cell layer do they affect?
I'll find it. I don't know.
Okay, are there any, like this is a benign lesion, so what are the chances of it being converted to a cancerous lesion?
In the malignant cases, it may convert it to the squamous cell papilloma, madam. In very rare cases, madam.
What is the percentage?
Yeah, it's a 4%, madam. A very rare, madam. But
okay. Next, please.
Thank you.
Hello, ma'am.
Yes, please continue.
Today's poster topic is clinical efficacy of collagen as a guided tissue regeneration membrane in treatment of localized gingival recession. So coming to the introduction, we know that gingival recession is defined as a location of the marginal tissue, apical to seminonormal junction with exposure root surface. So this can lead to development of signs and symptoms, which including pain from exposed dentine, root caries, and various aesthetic concern. There are lots of techniques for coverage of root gingival recession, and one of the most important predictable treatment options is coronal advanced flap. So when comparing with the traditional root coverage procedure, guided tissue regeneration based procedure achieves similar but also demonstrate a histologically new attachment formation. So here the purpose here is to evaluate the effect of the type 1 bovine collagen membrane in treatment of localized gingival recession defect. This is a 36-year-old female patient who came with a chief complaint of sensitivity and bleeding gums from the upper right back tooth regions in 6 months. And on clinical evaluation, we could see a gingival recession in that area. On treatment option, we opted here was coronal advanced flap with a combination with a collagen membrane, and we used here as Heligite membrane. So technique is, first we prepare the surgical area as with the local anesthesia, and we use a brazy curette to curette the exposed root surface before flap elevation. The first incision we have given is intracircular incision was given, made from the buccal aspect. It was extended horizontally, extending mesodistally, and two oblique releasing incision was made. We could get a trapezoidal split full thickness flap was raised with the periosteo elevated. The interdental papilla was deepithelialized to provide a bleeding connective tissue bed for the future coronally advanced flap. So type 1 collagen membrane, this was cut in the shape of the defect site, and we have placed it. And we have sutured it. First, we sutured 3-0 resorbable suture was used to secure the collagen in the recipient site. Then we used a 5-0 resorbable suture to secure the reflected flap. Vertical incision was sutured, first followed by the suturing of the papilla using a sling suture. This is the post-operative view of 3 months. From this, we can see that the root coverage after 3 months post-operatively is 80%. On conclusion, I can say that coronal advanced flap, when combined with resorbable collagen GTR membrane, has shown to be a promising and effective treatment modality for treatment of gingival recession in aesthetic areas of oral cavity. To further confirm the use of collagen membrane as a good alternative for treatment of gingival recession, more longitudinal studies are required in this field of periodontal plastic surgery. Thank you.
Did you measure the thickness of the gingiva in the area with the gingival recession? Or like, did you measure anything about like what is
Actually, ma'am, it was thick phenotype was seen, and thickness gingiva was adequate. So we have opted for coronal advanced.
And what was the like recession ka kitna tha amount? What was the amount?
Recession depth was 1.8 millimeter was the baseline, and after 3 months we could get is 0.01 millimeter.
Okay, and like, did you get that IOP done for this case?
Ma'am, probing depth was only 1.85 millimeters, so we didn't prefer going for IOP.
Okay, what is the role of IOPA in the case selection for recession coverage? Can you explain?
If you're giving for IOPA, the bone probing depth should be more than 3 to 4 mm, so we can at least see that bone recession is bone degradation is there.
Otherwise,
in case in case of
Dr. Komal, आप कुछ पूछें?
Yeah. Which classification did you follow to classify your recession?
Miller's class 1.
This was Miller's class 1?
This is Miller's class 2. Miller's classification I followed.
This is Miller's class 2?
Yes,
why do you think this is Miller's class 2?
It is extending toward beyond the mucogingival junction, so it is extending. Hidden recession was there. So,
what is the disadvantage of Miller's classification?
First main thing is they are not classifying palatal recession. Another thing is they are classifying mucogingival junction is the point to be criteria. So that is not every time measurable. Another thing is they are telling about class 3 and class 4 about the interdental bone loss. So they're not saying about severity of bone loss. So we cannot classify according to that. And
okay, what kind of regeneration do you expect from GTR membranes? With the use of GTR?
Here it is second degree, second regeneration therapy have obtained because of the resorbable membrane have been used over here.
What kind of regeneration? Please repeat.
Second generation.
What is second generation regeneration?
Ma'am, second generation is to overcome the first generation GTR regeneration, that is using a non-resorbable. Here they are using a resorbable membrane.
That is type of GTR membranes you're talking about. I'm talking about the regeneration that you obtain after healing. What kind of healing do you expect after the use of GTR membrane?
Can you define regeneration?
Define. Sorry, ma'am, definition is not.
Do you know the different types of healing?
Different type of?
Healing.
Primary and secondary healing.
Apart from that?
Sorry, ma'am, no, ma'am.
Okay. Thank you. Next, please.
Ma'am, we don't have the next participant. He's trying to log in. Can we have the next presentation after
Yes,
this?
sure.
And then we can have the current presentation in the last queue.
Okay.
Yeah.
Request to all the participants, those who are presenting may please switch on their cameras during their presentation.
Good afternoon to one and all. The topic of my poster is frenectomy and efforts to increase the attached gingiva. Introduction: aesthetic concern have led to an increasing importance in seeking dental treatment, and with the purpose of achieving the perfect smile, the persistence of an aberrant frenum being one of the etiological factor for the persistence of the midline diastema. The focus on the frenum has become essential, and for this management, frenectomy is the complete excision of the frenum, including its attachment to the underlying bone, and the whitening of the rationale of the whitening of gingival attached gingiva completes the enhanced plaque removal around the gingival margin, improve aesthetic, and reduce the inflammation around the restorative. Now, case report: a 40-year-old male patient reported to the Department of Periodontology with a stiff complaint of spacing between his upper tooth region. And on intraoral examination, there was a papilla type of frenal attachment was present. And after thorough examination, the phase 1 therapy has given, complete phase 1 therapy has given. Then we have choose the frenectomy procedures as seen in the photograph. The first one is the preoperative photograph, and then the frenum is held with the hemostat, and the frenum is incised, and suture is placed, and the periodontal pecto is placed. And after 1 week, the suture is removed, and after 1 month post-operative, the result is after 1 month follow-up, the frenal attachment was found to be relocated at an apical position with an uneven full healing. And conclusion is that after this frenectomy treatment, it enhanced the plaque removal around the margin, and also it maintained optimal gingival health. Thank you.
What type of the frenectomy technique you used?
Ma'am, I have used BY plasty technique.
And what are the other techniques for frenectomy?
Ma'am, classical technique, Miller technique, jet plasty.
Okay. And can you like differentiate, like what is the difference between frenectomy and frenotomy?
Ma'am, frenectomy, it is the complete excision of the frenum, including its attachment to the underlying bone. And frenotomy is the, ma'am, it's the displacement, like the, ma'am, it is only the change of the position of the frenum without involving the underlying bone.
How did you check the width of attached gingiva?
Ma'am, we will take the probe and we will measure from the gingival margin to the mucogingival junction, and
width of attached gingiva.
Yes, ma'am.
Because
yes, ma'am.
Writing an approach to increase attached gingiva. How you measured that your attached gingiva is not adequate, and there is a need to increase attached gingiva. How did you evaluate?
Ma'am, as the frenum is attached to the if the frenum is attached more closely to the gingival margin, it will give more pressure to the to the frenum, and it may cause the gingival margin away from the tooth. And if we give this frenectomy treatment,
how to like measure the width of attached gingiva? It's okay, Dr. Komal. Dr. Kumar? I think she's not there. Okay, beta, next room.
Thank you, ma'am.
Dr. Diksha?
Good afternoon, ma'am.
Hi, can you start the procedure?
Yes, ma'am. Ma'am, am I audible?
Yes,
Yes, you are audible.
Yes, ma'am. Good afternoon to one and all present here. My case report is on COVID-19 with oral candidiasis of tongue in a 64-year-old patient. The purpose of my report was to identify the importance of oral hygiene measures in COVID-19 patients. The aim was to assess the occurrence and the role of opportunistic infection in oral cavity with COVID-19 patient and its management due to the inadequate availability on periodontal modalities and due to current manifestations of fungal infections like mucormycosis and other conditions in the current pandemic situation. The report aimed to provide an inside knowledge for the same. From the ward of CG Hospital, Davangere, one patient reported diagnosed as COVID-19 positive with systemic conditions of diabetes, hypertension, and was on pacemaker. He complained of loss of taste sensation and whitish deposition on the tongue. On intraoral examination, we noticed pseudomembranous diffuse yellowish patch on the dorsal surface of the tongue on the 11th day of admission to the ward. He was advised to follow a regular oral hygiene maintenance along with mouth rinse that was povidone iodine mouthwash, which was 1% to be used twice daily for 30 seconds. Also, the patient was under a COVID-19 regimen, which included steroids and antibiotics from 2 weeks. After 4 days of noticing the lesion and the use of betadine, a reduction was seen in the oral amount of whitish deposition. So concluding with my report, few COVID-19 patients may show the signs of opportunistic infection like candidiasis in long duration of his course. Our case showed a good result when povidone iodine was used for the same. However, further study must be done to compare the use of various mouthwashes and its inclusion in the treatment regimen, and also due to the limited dental intervention and diagnosis of oral manifestation of opportunistic pathogens. The report was to highlight the importance and the role of oral hygiene measure and mouthwashes in COVID-19 patients. Thank you.
Dr. Diksha, this patient was positive at that time?
Yes, ma'am.
Okay. He was having positive report. He was not negative at that time.
No, ma'am. Ma'am, this is from the COVID ward, ma'am.
Okay. And what other than this, what can you expect? Like there are so many like research going on. What changes you can expect in case of COVID patients, especially on the tongue?
Ma'am, like ulcerations can be seen on the tongue. Ma'am, and like currently many fungal infections are seen, ma'am, like mucormycosis, aspergillosis. So here, since this was a candidiasis, so diffuse whitish patch was seen. Loss of taste sensation was noticed, which can be seen with ma'am in other lesions as well.
Okay. And did you like get it checked that it's a case of candidiasis? Like, did you go for?
And this was a yes, ma'am. This was a provisional diagnosis, ma'am, and I had limited time limit in the ward, ma'am. So we detected and we gave this treatment regimen, but the medical doctors had to take the call, ma'am.
Okay, and antibiotics. How long did he take the antibiotics and the steroids?
Yes, ma'am. From 2 weeks, he was under the same, and ma'am, like this patient was in to one of the regular ward, so we are not sure about his ICU admission, ma'am.
And he was diabetic. He was controlled.
Yes, ma'am. He was diabetic. He was hypertensive and was on pacemaker as well.
Okay, and he was a controlled diabetic or uncontrolled diabetic?
Yes, ma'am. He was being given insulin injections in the ward, ma'am.
Otherwise, he was like his sugar level was well maintained.
No, ma'am. His sugar level was also high, ma'am.
Okay. Dr. Komal, you can ask.
Yeah. What are the different treatment guidelines provided by the WHO for the treatment of dental patients?
Ma'am, overall dental patients or for COVID-19, ma'am, in particular?
COVID-19 in particular.
Ma'am, like based on the diagnosis, since they are already given so many drugs, ma'am, the emphasis should be there on some mouthwash in the schedule, ma'am. Like chlorhexidine or betadine mouthwash has to be included. Hello, ma'am.
What else?
And also, like, ma'am, currently they are given antiviral treatment, but in such condition, antifungal treatment, ma'am, drugs should be included. So,
what about the steroids?
Yes, ma'am, steroids are already included in the regimen, ma'am.
Okay, that's it. Thank you. Next.
Thank you,
Am I audible, ma'am?
Yes, you are.
Good evening, all. I'm here to present my case report title: Minimally Invasive Coronally Advanced Tunnel Technique with LPRF for Aesthetic Root Coverage in Multiple Gingival Recession. Moving to introduction, gingival recession is one of the most common aesthetic concerns which occur due to faulty tooth brushing, tooth malpositioning, and aberrant premolar muscle attachment. Multiple gingival recession is more challenging as compared to the isolated gingival recession. And minimal invasive coronally advanced canal technique, otherwise known as MICAT, is a modification pinhole technique in which this flap is coronally advanced with composite bonded sutures. This photograph showing up 2 case reports. And I'm here to explain the management of class 1 gingival recession. Patient, 32-year-old female, reported department who complains of hypersensitivity and unaesthetic appearance. The picture showing pre-OP class 1 gingival recession in relation to 2.2 and 2.3. We are planning to do MICAT with LPRF. First, after local anesthesia, horizontal incision of 2 to 3 mm with the BP blade, apical to the vestibule of the recipient side. Then the full thickness mucoperiosteal flap was elevated after insertion of a transmucosal papilla elevator through the incision. Then the flap was elevated coronally till the interdental papilla, and after the elevation till the 2 adjacent papilla get elevated. The LPRF was made. LPRF was collected from the blood of the patient itself, and we have centrifuged in 2,700 RPM for 12 minutes. After sucking of LPRF membrane, it was the flap was stabilized to coronally anchored composite bonded sutures. It's a picture showing after 1 month follow-up. Next case report is also same. A similar technique was done, MICAT with LPRF. This also patient complains of unaesthetic appearance of a picture showing after 1 month follow-up. I conclude by saying that this case MICAT is used as a predictable method for achieving optimum patient-based outcome in root coverage by eliminating vertical releasing incisions, the main advantage, and maintain the integrity of interdental papilla. LPRF also enhances root coverage by reducing growth factors and helps in angiogenesis, immunity, epithelial proliferation through the formation of the initial fibrin clot. Thank you.
What are the different techniques for the treatment of multiple recession?
Like pre-gingival graft, coronally advanced flap, and lateral position flap.
Why do you think this treatment was minimally invasive?
Ma'am, minimally invasive is done so that small incision, through the small incision, we can, with the help of a transmucosal papilla elevator, we can treat multiple gingival recessions.
Can you name a few other minimally invasive coronally advanced techniques?
Ma'am, pinhole technique, this is a modification of pinhole. Then Vista technique.
What is the disadvantage of using PRF membrane?
Ma'am, sometimes this dehydration occurs and the clot gets degraded.
What else? What is the resorption time of PRF membrane?
And, centrifugation is 2,700 RPM and 12 minutes, but in LPRF stays within 7 days. Other membranes only for the gel will occur only for 3 days.
And what do you think? How much time does it take for the healing to occur?
Ma'am, within 1 month follow-up, we got this much coverage, ma'am. 10 days, after 10 days, we did suture removal and composite removal. As this LPRF more growth factor release of cytokines helps in chemotaxis, more wound healing.
Okay.
What is IPRF?
What, ma'am? IPRF. Injectable platelet rich type.
What?
Injectable platelet-rich type. LPRF is leukocyte plasma-rich type.
Okay. And you don't have follow-up later than.
Follow-up is running this due to the pandemic. We couldn't.
Okay, you don't have any
1 month follow-up.
Like 3 months, 6 months follow-up, because recession will be more predictable after like 6 months follow-up.
Yes, ma'am. Next is 3 months follow-up. Now only 1 month.
Okay, fine.
Thank you.
Next, please.
Hello, ma'am. Hello, ma'am. Am I audible?
Yes.
Shall I start now?
Yes, please.
Good evening, everyone. Today I'm going to present my poster topic on clinical pathological mimicry in desquamatic gingival lesion. Desquamatic gingivitis is characterized by erythematous and desquamatic lesion of pre and attached gingiva. Common signs are erythema, intense desquamation, erosion, pain, gingival bleeding. Disease clinically presenting as desquamatic gingivitis are lichen planus, pemphigoid, pemphigus vulgaris, SLE, chronic ulcerative stomatitis, linear IgA disease, and dermatitis herpetiformis. I have done 2 cases regarding this topic, and in the first case report, a 50-year-old female reported to the department with the chief complaint of severe burning sensation since 3 months. Clinical examination showed peeling of gingiva, then surgical excision of the affected area done and incisional biopsy taken, and specimen is taken for both histopathologic examination and immunofluorescence assay. Microscopic examination showed subepithelial split and basal cell degeneration. On direct immunofluorescence, it was revealed that intense IgG deposition and faint C3 deposition on the basal membrane. And we got the final diagnosis as epidermolysis bullosa acanthosa. Moving to my second case report, 45-year-old male patient report to the department with a chief complaint of bleeding gums and burning sensation while having spicy food since 1 month. Clinical examination showed Wickham striae on the affected area, then surgical excision done and incisional biopsy specimen taken for both histopathological and examination and immunofluorescence assay. Microscopic examination showed hyperkeratinized stratified squamous epithelium and subepithelial split seen, and direct immunofluorescence assay revealed that both the IgG and C3 immunoreactants deposited on the dermal epidermal junction zone. And we got the final diagnosis as lichen planus pemphigoid. Treatment of desquamatic gingivitis consists of both non-surgical and surgical modalities. Non-surgical modalities include eliminating underlying causes, oral prophylaxis, multivitamins, antioxidants, topical or systemic corticosteroids, antifungal medication, laser biomodulation, ozone therapy, and surgical modulation include surgery using lasers, platelet concentrate, soft tissue grafting, and pre-gingival graft, connective tissue graft. And moving to my conclusion, desquamatic gingivitis can be a clinical symptom of some dermatitis and mucocutaneous disease, and underlying primary cause should be evaluated meticulously. Definitely, diagnosis of desquamatic gingivitis should be made by clinical examination, incisional biopsy, histopathological examination, and direct immunofluorescence assay. Thank you.
What treatment did you plan for this patient after biopsy?
I just surgically excise that affected area and give a co-pack dressing and antibiotics to be given.
Then what did you do with the patient? Like you just diagnosed that it is a case of epidermolysis bullosa and it's a case of lichen planus pemphigoid. And then what was your take on the treatment? That what treatment the patient should continue with? Like
we can I can give topical corticosteroids first, and if it is failed, then we can go through the surgical procedure.
Now you are talking about a long list for your non-surgical modalities to be included, and then surgical modalities to be included. But like, what did you do in this case? That is more important. You diagnose the case that it is a different case, okay, and then you have to plan accordingly what treatment you are going to give to the patient. And otherwise, so like, then what is the use of diagnosis if you are not going to treat the patient accordingly?
Yeah, soft tissue graft. The corticosteroid application can be done. No, medications can be given.
Yeah, but I'm not talking about that. What can be given? I'm talking about what did you do with the patient? So asking about what are the different treatment modalities. that you all
Yeah.
have written. I'm asking, what did you do with the patient? Like, what was your take on the patient?
Yeah, I just give medications only, topical corticosteroid medications, and
It's okay, okay. Okay. Dr. Komal? It's okay.
Good afternoon, ma'am.
Good afternoon.
Shall I start?
Please start, Aparna, and apna video on to you. Switch on your video.
Okay, ma'am. Good afternoon, one and all. The topic of my poster is titanium platelet-rich fibrin in implants. Considering the many advantages of titanium platelet-rich fibrin and scarcity of literature, especially in the application of TPRF in implant osteotomy sites, so this is the case report to show the effect of TPRF on osseointegration and as well as on the implant stability, as it has been established that the fibrin carpet formed with the titanium had a firmer network structure and the resorption in the tissue was longer as compared with the conventional PRF. So this is a case report of a 27-year-old male patient presented with a chief complaint of missing 3/6. Single stage implant placement was done and TPRF membrane was placed in the osteotomy site. Then implant stability caution values were obtained at baseline and after 1 month. So in this case, the use of TPRF accelerated the stability as well as the osseointegration by improving the peri-implant hard tissue healing. Picture number 1 is showing the preoperative edentulous site with respect to 3/6. Picture number 2 is showing the periosteal incision and the raised flap. Picture number 3 is showing the pilot drill, which was followed by the sequential drill, and then the parallelism was checked with the paralleling pin. Then picture number 4 is showing the osteotomy was completed. Picture number 5 is showing the TPRF membrane, which was placed in the osteotomy site before placing the implant. Then in picture number 6 is showing the implant placement was done. Picture number 7 is, as it was a single stage implant placement procedure, so healing abutment was placed. Picture number 8 is showing the implant stability caution value, which was 57 at baseline. I took this ISQ value with the Ostel device. Then picture number 9 is showing the ISQ value after 1 month, which was increased to 74. So the stability was good, ISQ value was good, so osseointegration was good after 1 month. So prosthesis was given after 1 month. Now where in conventional implant cases, it takes almost 3 months to get the implant to get osseointegration. So to conclude, in 2001, it was defined by Dohan et al. That TPRF activates the vascular system, angiogenesis, and it releases the growth factors like platelet-derived growth factors, vascular endothelial growth factors, and transforming growth factors, which are involved in soft and hard tissue healing. They attract the undifferentiated mesenchymal cells to the injured site and facilitate the angiogenesis, chemotaxis, and cell proliferation. Growth factors also control the synthesis and degradation of extracellular matrix, proteins, enhance osteogenesis, and potentially accelerate the peri-implant wound healing and osseointegration. Thank you.
How did you use? Oh, continue, please. How did you use TPRF membrane?
Ma'am, I withdraw the patient blood, 10 ml blood I withdraw. Then I use 2 titanium tube. I fill 1 titanium tube with the 10 ml blood and other one with the saline water, saline, 10 ml saline. Then I place both the tubes in a centrifuge machine. I centrifuge these tubes at 300 RPM for 12 minutes.
No, in the, how did you use it in your case? How did you prepare it? When did you use it and how did you use it? As a
ma'am, I
or as a
prepared.
membrane?
Yes, ma'am. I prepared the osteotomy first. Then after the final drilling, then after using the final drill, I placed this TPRF membrane in the osteotomy site, and then I placed my implant. I tighten up my implant over this membrane.
What is the difference between TPRF and LPRF?
Ma'am, TPRF is titanium platelet-rich fibrin, whereas LPRF is leukocyte platelet-rich fibrin. In TPRF, we use titanium titanium tubes. It is believed that, and in LPRF, we use the glass tubes or silica tubes. And it is believed that physicians said that there are some biohazard, there are some hazardous effects of silica, which is used in conventional PRF or in LPRF. Or advanced.
Difference in the PRF that is obtained.
What is the techniques? Sorry, ma'am?
The PRF, the
yes.
fibrin clot that is being obtained. What is the difference between the two?
Ma'am, the junction, which is the fibrin carpet, which is formed in case of in case of the PRF. In case of TPRF is firmer network which has the equilateral junctions. The fibrin threads have the equilateral junctions in case of TPRF, and it releases the growth factors for over 7 to 11 days.
Which is better out of the two?
Sorry, ma'am?
Which is better out of the two?
Ma'am, TPRF is better because we are not using the silica tubes in this case. Fibrin, ma'am, authors have said fibrin network is almost same in both cases, but there is the only difference between the silica tubes and the titanium tubes. In titanium tube, there is elimination of silica associated hazardous effects.
Okay.
Yes, ma'am.
Dr. Nandini?
It is not clear in the clinical picture, like where you are placing your TPRF.
Ma'am, in picture number 5, it is showing the TPRF membrane, and I'm placing this TPRF in 3/6 after completing the osteotomy.
Okay.
Yes, ma'am.
Okay. Thank you, Aparna. It's okay.
Thank you, ma'am. Thank you.
Good evening, ma'am. Am I audible?
Yes, please start.
Yeah. Good evening, everyone present here. Today, my topic for the presentation is laser bandage, a palatal donor site dressing material following free gingival graft. Free gingival grafts are used in periodontal procedures to augment attached gingiva and cover denuded root surfaces. It creates an open wound that heals by secondary intention. Palatal donor site protected by dressing materials such as synthetic collagen or oxidized cellulose or any other materials in combination with surgical stent. Sometimes these dressing materials cause allergies or foreign body reactions and retards the wound healing. Laser bandage, a biological bandage, is suggested which tend to ameliorate the wound healing and decrease the post-operative complication. In this study, a 27-year-old systemically healthy patient with inadequate attached gingiva in lower anterior region is included in the study. After a regional anesthesia, the free gingival graft is harvested from the palate. Then diode laser is used to create the biological bandage at wavelength of 810 nanometer at 5 watts in continuous wave mode. It is applied via 400 micrometer optic fiber, which is positioned perpendicularly in contact mode till the entire wound area is charged. Parameters such as post-operative discomfort is assessed using a visual analog score, healing assessed with a Landry wound healing index. The number of analgesic wound epithelialization are assessed at 3rd, 7th, 14th, and 30th day. Laser bandage provides faster hemostasis made by positive contribution to early healing, and patient also reported a reduction in pain after the 3rd day. Healing proceeded normally with no evidence of infection or any tissue reaction. To conclude, the use of laser bandage reduced the postoperative complication and accelerated the healing, obviating the use of laser bandage in the donor site dressing. Thank you.
Did you compare it with the normal donor site without any dressing?
Yes, ma'am. Like when we compared with the normal, with the regular procedure, it is a faster wound, early wound healing is seen, ma'am.
How did you evaluate the healing?
With Landry wound healing index, ma'am.
That's it.
Excuse me, pardon?
Any other subjective techniques?
No, ma'am.
Are you aware of any other techniques how you can assess healing?
Ma'am, we can use recently we use a wound healing score which is used, ma'am. In this we use Landry wound healing index, and the last two cases we did where we found a very good results, ma'am.
Both of these that you're talking about are the indices, right? Or the scoring evaluation. Any technique, any subjective method of evaluating?
Ma'am, for epithelialization we used hydrogen peroxide thing, ma'am, test, ma'am, where wound epithelialization was completed by day 14. That's it.
Any other palatal bandage techniques are you aware of?
Palatal bandage. There are other dressing unit, like regularly in a conventional way we use the cellulose sponge or gelatin foam which we place, and the donor area will be covered, ma'am, and then a surgical acrylic stent will be given for the patient. In this case we didn't give any acrylic stent also. Patient was comfortable at the third day only, ma'am. We just did a
Who introduced this palatal bandage concept?
Ma'am?
Who introduced this palatal bandage concept?
Ma'am,
first time this terminology, the palatal bandage, was introduced by an Indian author. Are you aware of it?
No.
Okay. Dr. Nandini?
Can you name some lasers that are used in dentistry?
Ma'am, diode laser, then erbium YAG laser, then neodymium ND-YAG erbium, then carbon dioxide laser. Which carbon dioxide, like in the previous study, the first study previously, they have used carbon dioxide for this laser bandage technique, ma'am.
And which was the first laser to be used in dentistry?
Carbon laser, ma'am.
Carbon? Okay. It's okay, Preeti.
Yeah, ma'am.
Thank you, Preeti.
Thank you, ma'am.
We do have one more presentation which was left earlier, Dr. Surendra Kumar Yadav. Yes, this one. No, the next one. The yellow one. Yes. Dr. Surendra, please present.
Yes, ma'am. Good evening, respected teachers. Today I'm presenting a case report. The topic is management of aberrant frenum by VY plastic techniques. Now, the frenum is a mucous membrane fluid so that attach lips and the cheek to the alveolar mucosa, the gingiva, and underlying periosteum. The frena may be related with the gingival health when they are attached closely to the gingival margin by interference in the plaque control or due to muscles pull. In addition to these, the maxillary frenum may present aesthetic problem or compromising the orthodontic results in the midline diastema case. It causes the recurrency after the orthodontic treatment due to the muscular pull. The muscles basically involved in the orbicularis oris, that is horizontal blends, and the oblique fibers. There are different types of frenal attachments, as in mucosal, gingival, papillary, and papillary penetrating. Now, the etiological factor is when the maxillary level frenum develops as a post-eruptive remnant of the ectolabial bands, which connects the tubercles of the upper lip to the palatal papilla. When the two central incisors erupted widely separated, no bone is deposited interfere to the frenum. Now, the frenum is characterized as a pathological, and it indicates by indicators for the removal when an aberrant frenal attachment is present, which causes the midline diastema, or when the flattened papilla, which with the frenum closely attached to the gingival margin, is present, which causes the gingival recession, and it hinders the maintaining the oral hygiene. And the next one is the aberrant frenum with an inadequate attached gingiva or shallow vestibule. These are all the considered as the pathogenic, and it is indicated for the removal. Now, there are various surgical techniques have been proposed for the correction of the abnormal frenum, and each have its own advantage and disadvantage. Now, the different techniques are the conventional classical techniques, Miller's techniques, VY-plasty, jet-plasty, and frenectomy with using electrocautery. Now, I'm presenting in this case report. A 28-year-old male patient reported with a chief complaint of increasing the midline space between two upper central incisors. On intraoral examination, it was found that there was a thick aberrant frenum extending into the interdental papilla between upper central incisor. Now, tension test was found to be positive, and it was considered for the VY frenuloplasty. VY can be catered in case of the broad frenum attachment, or it is in case of the papillae type of frenal attachment. Now, the techniques. The area was anesthetized with local infiltration by using 2% lidocaine. The frenum was held with the hemostat, and incision was made in the form of V or V on their undersurface of the frenal attachment. The frenum was relocated at the apical position, and the V-shaped incision was converted into the Y, while it was sutured with 4-0 silk sutures. The suture was removed at 1 week of the follow-up. After the 1 month, the frenal attachment was found to be relocated at the apical position. Now, in this case, the picture one shows at the papillary frenum, and the second picture shows that the incision by the held with hemostat. The third picture that is a V-shape incision, and after suturing it get the Y shape. And the last one picture is a picture after 1 month post-operative. Now, the conclusion, while an aberrant frenum can be removed by any of the modification technique that have been proposed, a functional and an aesthetic outcome can be achieved by a proper technique selection, which is based upon the type of frenal attachment. Thank you, sir.
Okay. Continue, ma'am. What can be the other reasons for, like you are saying that patient complained of spacing in the anterior teeth, midline diastema. What can be the other reasons for that, other than aberrant frenum?
Midline diastema, orthodontic treatment or other vestibular depth are decreases, attached gingiva are less. In case of the frenectomy can be proceed.
Did your patient has tongue
in
thrust?
Case of no, ma'am. I think. Sorry, ma'am.
1 month post-op, if you see this photograph, yes. 1 month post-op. Yes, like in this, I don't know, but the position is like that patient might be having tongue thrusting also.
Oh, yes, ma'am.
Did you get the X-ray done for this patient?
No, ma'am.
Okay. And age of the patient was 28 years. Like,
yes, ma'am.
If you see, the spacing is also there in other teeth also.
Yes,
the patient is not going to plan for ortho treatment in future?
Ma'am, he's agree for only the midline diastema spacing that he can concentrate for midline diastema, not for ortho treatment. His complaint is only for midline diastema.
Did you get the X-ray done?
No, ma'am.
you looked into the aberrant frenum and you performed the VY plastic procedure. Okay. Dr. Komal? Dr. Komal?
And we can proceed to the next one.
Hanji,
Logged out.
Sure.
Thank you.
Thank you.
So this brings us to the end of this session. Thank you, ma'am, for chairing the session. And we will start with the next session for today.
Thank you so
The
much.
chairperson for this session are Dr. Komal Puri, ma'am, and Dr. Nandini Bhaskar, ma'am. Thank you, ma'am.
Thank you, sir.
Hello, ma'am, am I audible?
Yes.
Good evening, everyone. Coming to my poster presentation, I'm here to present my poster titled Polypoid Gingival Enlargement, an Unusual Case Presentation. Gingival enlargement is a very common clinical presentation, and it can range from a simple plaque-induced inflammatory enlargement to sometimes even malignant lesions. The management strategies and prognosis primarily depends on the diagnosis of the condition. Thorough history taking, detailed clinical examination, and proper investigations are essential to come to a proper diagnosis. So coming to the case, a 22-year-old male patient was referred to the Department of Periodontics for the management of gingival enlargement. Patient presented with a complete swelling and soft tissue growth on the outer aspect of lower left posterior teeth since 1 month. There were frequent exacerbations with pain, bleeding, and an increase in size, all of which regressed on its own after each episode. According to patient's description, his medical history was non-contributory. And on clinical examinations, we noticed 2 reddish polypoid pedunculated growth of sizes 2x3 and 2x2 millimeters in relation to the buccal aspect of 3/6. First impression was that of pyogenic granuloma, but his oral hygiene status was quite good with minimal deposits. So we could not elicit bleeding on probing or any deep periodontal pocket in the associated teeth. Moreover, the growth was seen in the mucogingival junction, and it was completely detached from the gingiva. Careful palpation revealed a firm, tender, mildly compressible, non-pulsating lesion. And 3/8 was partially erupted, and the hardness was also noticed in relation to the buccal aspect of 3/8. So we did vitality testing of 3/6 and 3/7, and both were found to be vital. We took IOPAR and OPG, but we could not detect any pathological changes in relation to the site of the lesion. And but there was distoangular impaction of 3/8. So the provisional diagnosis made was chronic perichronoitis in relation to 3/8, tracking to the buccal region of 3/6 with proliferated granulation tissue. We have surgically excised the lesion along with removal of the 3rd molar. Now, the surgical excision of the lesion alone would have resulted in the recurrence of the problem, and we may have had to subject the patient to a 2nd surgical procedure. Now, this case could have been misdiagnosed as a pyogenic granuloma, but with the help of thorough clinical examination, we could rule out the focus of any periodontal infection, and careful examination of the adjacent structures revealed the presence of a chronic foci of infection. So this case demonstrates the importance of proper clinical examination and interdisciplinary management of the same. Thank you.
Did you go for the histopath?
Ma'am, we have sent for the histopath. We have not yet received it. The case reported in the 1st week of May. So soon after that, it was locked down here. So we've not yet received the histopath findings.
Okay. And even follow-up you don't have? Huh?
Not yet, ma'am. No.
Okay. So on what basis you came to the diagnosis of polypoid gingival enlargement?
Ma'am, it could have been misdiagnosed as a gingival enlargement. Actually, when it came to the department, it came as a case of gingival enlargement. But when we retracted the lesion, it was not on the acta gingiva, rather it was on the mucogingival junction. So it was not a clear case of gingival enlargement. It was more or like it had a foci of infection, which was not either 3/6 or 3/7.
Okay, histopath is still awaited. That will
yes.
support it. Okay.
Yes.
What other reasons can be there for gingival enlargement?
Ma'am, gingival enlargement, it could be, first one is inflammatory enlargement, but this patient had minimal deposits. Second one, it could be associated with a systemic condition, like in the case of leukemia, but we had the blood report of the patient and it was quite normal. And the third one was, it could be a drug induced, but the patient had a non-contributory medical history. So, or in cases of hormonal imbalance like pregnancy, but this is the main patients who.
Moreover, it is localized in in just a single area.
Yes, it was
induced, or it would have been leukemia. It would not have been limited to a single tooth like the case, like your case. It would have been different. Fine, absolutely fine. Okay.
Was there any lymph node enlargement?
No, ma'am. We could not palpate any lymph node. No.
And was it only a soft tissue lesion or any bony involvement was there?
No bony involvement was there, ma'am. The OPG and IOPR were completely normal, and it was just a soft tissue lesion.
And what is false enlargement?
Ma'am, false enlargement is. I'm sorry, ma'am. I look into it.
How do you assess gingival enlargement? Are there any gradings?
We have a grading system by Buckingham and Bornhorst in 1994. So it was like grade 0 when you do not have enlargement, grade 1 when it is confined to the interdental papilla, grade 2 when it involves the interdental papilla and the marginal gingiva, grade 3 is when it covers the 3/4 of the crown.
Do you have any recall for this patient? When did you, any follow-up or?
Not yet, ma'am. This case reported in the first week of May. So soon after the surgical excision, it was locked down here. So we haven't recalled, or we have not yet received the histopathological findings yet.
Okay. Thank you.
Thank you.
Good afternoon, ma'am. Am I audible?
Yes.
Good afternoon, everyone. So my poster presentation is on regenerative potential of platelet-rich fibrin in the treatment of combined lesion, a case report. So coming on to the introduction, so endoperioral lesion is as one of the most common reasons associated with tooth, which can complicate the diagnosis and the treatment plan. So the present case report, it discusses the clinical aspects being considered for diagnosing and treating the lesion. So the patient, 37-year-old male patient, visited the department with the chief complaint of pain in the upper left back tooth region for since past 2 weeks. The patient was systemically healthy. On clinical and radiographic examination, there was a periapical lesion seen radiographically, and clinically there was a periapical abscess, and also there was a vertical bone defect seen with respect to 2/4. So the tooth was non-vital with a grade 3 mobility. So coming on to the treatment procedure. So first, an emergency access opening was done with respect to 2/4 after being diagnosed as a periapical abscess. And then after that, scaling was done, and after 5 days of scaling, the access of the RCT treatment was done. So after 1 week of the root canal treatment, the root planing was done. And after 1 month of the root planing, the periodontal surgical procedure was carried out with an open flap debridement done with respect to 2/4. And then PRF was placed with respect to the distal aspect of 2/4, and sutures were placed and periodontal pack was placed. So the patient was recalled after 3 months. So the initial pocket depth at the baseline was 15 millimeters, and after 3 months, the pocket depth had reduced to 6 millimeters. So the results after 3 months, there was a significant gain in the clinical attachment level, and there was some amount of bone fill also seen in the radiographically after 3 months, and the mobility was reduced from grade 3 to grade 2 after the endodontic treatment. But so thus the surgical procedure was carried out, and after the periodontal surgery, there was no mobility seen after 1 month post-operatively. So coming on to the conclusion, so endodontic lesions have high predictability of healing than the periodontal lesion due to repair and regeneration, and thus the use of the PRF results in tissue remodeling, wound healing, and angiogenesis by the local delivery of growth factors and proteins. Thank you.
You don't have pre-op X-ray?
The pre-op X-ray, no, ma'am. That patient actually lost it after the initial thing.
Because it is tough to one should compare pre-op and post-op.
Yes, ma'am.
How can you say that there is a bone gain, bone fill?
Yes, ma'am.
And what happened to the tooth mobility?
Ma'am, actually, initially it was grade 3 mobile. So after the endodontic treatment, it reduced to grade 2 mobility, grade 1 mobility, and after periodontal surgery, there was no mobility seen, ma'am.
What is the latest classification for endoperial lesions?
Ma'am, according to the 2017 classification, they have been classified under the periodontal diseases under systemic conditions. So, so it is endodontic periodontal lesions only, ma'am. With given by and the classification given by Simon et al. According to 1972 is primary endodontic lesion, primary periodontal lesion, then combined lesions that includes primary endodontic with secondary periodontal lesions, then primary periodontal with secondary endodontic lesions, and 2 combined lesions.
So your case is primary what? Endoperial?
It's a primary it's a primary periodontal with a secondary endodontic involvement, ma'am.
Why?
Ma'am, because actually the pocket depth is also very high, like is about 15 millimeters, and it has reached the apex, ma'am. So even there's a connection between the periodontal pocket with that of the root apex, and there's no caries seen in this tooth, ma'am.
And what about you were talking about periapical abscess? What about that?
Yes, ma'am. Actually, there was a traumatic trauma from occlusion is seen with respect to 2-4, ma'am. So during the emergency access opening, they had relieved the trauma. So there was pocket formation when there was a trauma from occlusion.
Okay.
How much gain in level of attachment was observed in this patient?
Ma'am, initially it was 15 millimeters. So after after the root planing, that reduced to about 8 millimeters. And then at the end of the periodontal surgery, after 1 month, they have seen that there was a 6 millimeter of reduction in the pocket depth, ma'am. So there was no recession seen after the surgery.
No recession was observed even after there was so much of loss of attachment was present in this.
No, ma'am, there was no gingival recession seen.
And you follow up the patient for 3 months only?
No, ma'am. Actually, we've tried to follow up after 6 months, but due to this COVID situation, he couldn't come back after that, ma'am, and he didn't come back to the college after the frequent call.
But you think you will be able to, you were able to observe the bone fill after 3 months?
There was a little bit, ma'am, very minor amount of bone fill was seen after 3 months.
Can you appreciate bone fill after 3 months?
Very minimal, ma'am.
What is the minimum time required to appreciate the bone fill radiographically?
Ma'am, actually, at least we need a total of 6 months to see the complete amount of bone fill to be appreciated properly, ma'am.
And which PRF did you use?
The conventional PRF only, ma'am.
Okay, and which machine did you use to prepare this PRF?
That was at Remy machine, company named Remy. So that was used with 3000 RPM for 10 minutes.
There are many Remy machines available in the market. Which one did you use?
I'll look into that now.
What is G-force?
Yes, ma'am.
What is G-force? When you prepare PRF, you prepare it in a centrifugal machine.
Centrifugal machine.
So is G-force important for it or not?
Yes, ma'am.
Yes, ma'am, but you don't know what is G-force. How do you know it is important?
I don't know proper one, like how to define it.
Okay, thank you. Next, please.
Good evening, one and all. My poster topic is on a clinical manifestation and management of stage 3 grade 3 periodontitis with non-surgical periodontal therapy, a case report. A 26-year-old male patient presented with a chief complaint of generalized pus discharge from his gums, along with spacing in the upper front teeth for the past 1 year. Family history revealed that the patient's mother also had similar complaint of mobility, pus discharge, and spontaneous exfoliation of some teeth, following which she underwent total extraction by the age of 40. Under the 1999 classification of periodontal diseases, grading of periodontitis has been subtly incorporated into diagnosis as chronic periodontitis versus aggressive based on age of onset and rate of progression earlier in life. With the new 2017 classification system, grading estimates the aggressiveness of the disease by focusing on the factors contributing to progression rather than previously focusing on the identification of a form of periodontitis. So the primary factors for this were medical history is not contributory and rapid attachment loss and bone destruction was seen, and familial aggregation of cases. Secondary features like the microbial amount is scanty, which does not correspond to the severe periodontal breakdown. The non-surgical periodontal therapy was performed. A combination of systemic antibiotic therapy of amoxicillin and metronidazole for 8 days was administered. A recall visit after 3 months showed a significant reduction in probing pocket depth. And successful treatment of these type of cases depends on its early diagnosis. Such early diagnosis helps in prevention as well as the possibility of advanced tissue destruction and alveolar bone loss. And non-surgical therapy still remains the first line of antimicrobial therapy. And early stages of the disease with mild to moderate periodontitis may be managed entirely by non-surgical periodontal therapy with systemic antibiotics as an adjunct to mechanical therapy. Conclusion, an NSPT is the cornerstone of periodontal therapy. It is still considered to be the gold standard to all other treatment modalities. The key factor is that early diagnosis and NSPT is the key for the successful management of this type of cases.
What was the mobility? What about mobility?
There was a grade 2 mobility seen with respect to the maxillary and posterior teeth, ma'am.
And what about anterior?
Anterior incisors were also mobile, ma'am. There was a grade 2 mobility.
And what is your take on TFO?
Yes, ma'am. There could be TFO, but it.
Did you check?
Yes, ma'am. Fremitus test was negative.
Can't be negative. You see this second photograph about this central incisor and the mandibular interior's position. It's like it is hitting the palatal aspect, the anterior teeth. Okay, after the NSPT, what you are going to plan for this patient?
Ma'am, we need to check the response of the patient, ma'am, post response.
No, आप कह रहे हैं ना NSPT तो is good enough, like it is a gold standard. Then you should limit yourself to like NSPT, or you will further think about anything else in this case.
Ma'am, if there is residual,
age of the patient is just 26-year-old patient.
Yes, ma'am.
You see the aesthetics and everything. Like,
ma'am, if we have to evaluate the pocket depth, and if there are residual pockets, if it is still not residing with this NSPT, then we can think about the other surgical procedures, ma'am.
And what did you see in OPG?
Ma'am, there was a bone loss with respect to the this upper anterior teeth and the molars as well, ma'am.
And you are not going to do anything about it? Because your NSPT is not going to help it. Like it may help to some extent, but
yes.
So,
ma'am, it also has certain limitations, like in the inaccessible areas such as furcations, grooves, or concave.
I'm asking, like, what will be your next step after this?
Ma'am, flap surgery, ma'am. If the pockets are still persisting greater than or equal to 5 mm according to the critical probing depth we take, we can proceed.
Okay, what are the indications of flap surgery?
Ma'am, more than or equal to 5 mm pockets and residual pockets. If there is
indication for periodontal flap surgery, main.
Ma'am, if the pockets are not responding to this non-surgical periodontal therapy, residual pocket test.
Dr. Komal, you can ask.
Yeah. Why do you think your diagnosis was stage 3 and grade C?
Stage 3 periodontitis patient will have probing depth of greater than or equal to 6 mm, cal of greater than or equal to 5 mm, and may have vertical bone loss or flotation involvement of class 2 or class 3, ma'am. And grade A is slow rate of progression, and grade B is a moderate rate, and grade C is rapid progression rate, ma'am.
And what about the other factors that are associated with the providing staging and grading of periodontitis, like the number of teeth that are being lost or the modifiers that are present?
Yes, modifiers. There are no systemic factors involved other than these, ma'am, in this patient.
And what about the RBL?
That was normal, ma'am.
That was normal?
Yes.
How did you evaluate that?
Random blood sugar levels.
RBL, beta, RBL. When you provide the grading for the patient, right? In the current classification, you have to evaluate the RBL also, the bone level. So either you should be having the past bone level, or you should be able to evaluate it at the current level. How did you do that? Are there any disadvantages of the current classification?
Yes, ma'am. It is vast, and it is difficult for the clinicians to remember and apply it. And
that's it. Thank you. Next, please.
Next presenter, please. Dr. Abhigna. Madam, you need to accept the invitation.
Good afternoon, ma'am. Ma'am, good afternoon, ma'am.
Good afternoon. Please continue.
Ma'am, sorry, ma'am. There was a network issue. Can I start now?
Yes, please.
Good afternoon, everyone. Today my presentation is on aesthetic crown lengthening. A 24-year-old female patient was referred from the Department of Orthodontics to the Department of Periodontics and Implantology at Dr. Sudha Nageshwar Rao Siddhartha Institute of Dental Sciences with the chief complaint of excessive gingival display. The patient has no contributing medical history, and the extraoral examination revealed no significant findings with a normal lip line, and the dental examination revealed the patient with a class 2 malocclusion, and the patient was undergoing the orthodontic treatment. And as a part of the orthodontic treatment, the surgical orthodontic treatment, that was a maxillary osteectomy, was performed. Even after the treatment, the patient has an excessive gingival display of 4 mm, for which she was referred for the crown lengthening. Coming to the clinical examination, a transgingival probing was done to evaluate the biological width, and it showed a probing depth of greater than 2 mm, and there was no clinical mobility. The radiographic examination revealed a minimal interdental bone loss. After the complete examination, crown lengthening was recommended to increase the extent of the supragingival tooth structure and to allow the healthy and the optimal relationship with the surrounding tissues. Coming to the surgical procedure, after obtaining the profound local anesthesia and after performing the transgingival probing, the bleeding points were marked and the initial incision, that was the external bevel incision, was given, collecting the bleeding points, and the tissue which was obtained was excised. And this picture shows the immediate post-operative picture after the removal of the tissue. This is an excised tissue which was obtained, which was sent for biopsy, which showed no significant changes. And this picture shows the application of the co-pack. This is a 1 week post-operative and the 1 month post-operative pictures. This is a smile of the patient before orthodontic and post-orthodontic treatment and after the gingirectomy. Thank you, ma'am.
What are the various treatment options for crown lengthening?
Crown lengthening can be performed by gingivectomy, gingivoplasty, or laser gingivectomy. Flap procedures. This is based on the alter passive eruption. No? There are various options based on the width of the keratinoid tissue. If it is greater than or equal to 2 mm, a simple gingivectomy procedure can be performed. If it is less than 2 mm, then a flap procedure with osseous recontouring can be performed.
What is closed flap crown lengthening?
Ma'am, I'll find out. I don't know, ma'am. I'll find out.
The patient was undergoing ortho treatment or the ortho treatment was completed?
No, ma'am. Orthodontic treatment was she was undergoing, ma'am. The surgical treatment was completed, but the orthodontic treatment was not yet completed, ma'am.
So why didn't you wait till the ortho treatment was completed?
Ma'am, almost a treatment was completed, ma'am. Before that, they have referred, ma'am.
What is the ideal way when you should do this aesthetic crown lengthening when the patient is undergoing ortho treatment? That's it. Dr. Nandini?
What is gingival zenith?
It is a apical-most portion of the marginal gingival scallop, ma'am.
You were able to maintain it?
Ma'am, yes, ma'am.
Thank you, Abhinav. Thank you.
Okay, thank you, ma'am.
Good afternoon, everyone. The topic of my case presentation is on a case report, a mistaken entity, gingival pseudoepitheliomatous hyperplasia, which simulates squamous cell carcinoma. So this is a case report of gingival enlargement, and gingival enlargement can be due to many causes. It can be due to any inflammation, it can be due to infections, it can be drug-induced, it can also be false enlargement. So this is a case report of a 20-year-old female patient, which reported to our department, which was referred from Department of Orthodontics to our department with a chief complaint of swelling on the lower region of the gums. And on clinical and oral examination, we could reveal a solitary exophytic pedunculated reddish pink swelling, which with distinct borders and regular surface. The location of this swelling was distal to the left lateral incisor, with canine missing in that area, which occupied that area. And on periapical and orthopantomogram, it has revealed that there's an impacted canine in relation to the lesion. So the procedure for the first procedure done was we did a thorough scaling and root planing. After that, we planned for surgical excision of the area of the lesion. So treatment was planned under local anesthesia and using a surgical blade. The lesion was excised in fragments with thorough debridement of the area. And after that, a copious irrigation with betadine solution was introduced in the area. After which periodontal dressing was then placed in the operated area, and the post-operative instructions were given. After 1 week, the dressing was removed and healing was uneventful. The lesion was sent for histopathological findings, and in histopathological findings, it was revealed that it was a pseudo-epitheliomatous hypoplasia with marked irregular acanthosis and broadening of slit pecs in figure A, and in figure B we could see proliferating and anastomosing epithelial tongues entrapping the stroma. So in this case, coming to the conclusion, numerous lesions have investigated possible local and systemic factors contributing to the developing of pseudoepitheliomatous hypoplasia, but the exact mechanism of the pathology is still unknown. So in this present case, we ruled out that the impacted canine predisposed to the chronic inflammatory overgrowth, and we made the diagnosis strictly on the histopathological findings. Thank you.
How can you differentiate between gingival pseudoepitheliomatous hypoplasia and squamous cell carcinoma?
Ma'am, because this case was strictly on histopathological findings, we could distinguish this from firstly there were
Other methods.
Hello.
Okay. Other
Hello,
methods other than histopath, not.
Hello.
Hello.
Yes, ma'am.
Are there any immunohistochemical markers?
Yes, ma'am.
Name some.
Ma'am,
It's okay. Dr. Komal,
what was the differential diagnosis for this case apart from squamous cell carcinoma?
Yeah, at first we made a differential diagnosis of pyogenic granuloma, but because pyogenic granuloma can also be caused due to inflammatory
Any other apart from that?
It can be gingival fibromatosis also, ma'am.
Why is your this title a mistaken entity?
Ma'am, actually, mostly this lesion is usually being mistaken with squamous cell carcinoma, because here it's many times because the features of this lesion is almost similar to that of the pseudoepitheliomatous hypoplasia.
Okay. Next, please.
Good afternoon, ma'am.
Good afternoon. Please start.
Ma'am, this is Dr. Charishma, and I'm here to present the poster on bridging the multiple recession, a case report. To introduce, gingival recession is a apical migration of the gingival margin treated by several root coverage procedures on the aesthetic demand and complaint of dentinal hypersensitivity. Among these techniques, the double lateral bridge flap proposed by Margraf and this double lateral bridge flap utilizes the combination of coronally advanced flap and the modified Edan Mature technique, and showing the better root coverage predictability and aesthetics. And this case report presents surgical management of a patient with bridge flap technique. And coming to the procedure, a 45-year-old female patient reported to the department with Miller is diagnosed with a Miller class 1 recession and is after the clinical hematological and radiographic examination is decided to perform bridge flap technique. And initially an arc shape after adequate local anesthesia is achieved, and for the arc shape incision, the incision markings are placed from 2 into gingival recession plus 2 mm distance, and after followed by the arc shape incision, the circular incision is performed to the involved teeth, and these two incisions are combined apicocoronally by means of split thickness dissection, and followed by a displaced flap with good blood supply can be obtained, and this flap is positioned coronally to cover the denuded root surface and sutured, and tinfoil placement is done and the periodontal pack is placed, and 10 days post-operatively the sutures was removed, and during the surgical, after the surgery the patient is managed on antibiotics and analgesics and asked to use chlorhexidine mouthwash for the period of 1 week, and post-operative 1 month the technique resulted in complete root coverage and increasing the width of attached gingiva can be seen. And I hereby conclude that one-step bridge flap technique provides the satisfactory result with complete root coverage involving the multiple teeth, increasing the width of attached gingiva with the deepening of the shallow vestibule, and thereby decreasing the dentinal hypersensitivity without any significant complication. Thank you.
What kind of healing did you expect in this?
Ma'am, in the coronal aspect, healing can be by means of primary wound healing can be occur, ma'am. And in the vestibular part, wound healing by secondary incision can be occur. In Edlund-Mature technique, generally wound healing occurs by accumulation of the cells from the periodontal and alveolar bone and oral mucosal cells, forming a granulation tissue, and this tissue form the keratinization for new tissue formation.
Any disadvantages associated with this procedure?
Ma'am, this procedure cannot be performed when the gingival thickness is thin, ma'am.
Anything else? That's it. Dr. Nandini?
Yes, ma'am. The session was in like how many teeth?
Ma'am, it's involving the attachment loss involving 4 to ma'am, and the class 1 recession with shallow vestibule is present up to 3 to 4 to.
Like I can appreciate only in this single tooth. And what other you are talking about multiple recession. Anyways, what was width of attached gingiva before surgery?
Ma'am, before surgery the width is 2 mm, ma'am.
And later on after?
It's 3.5, about 3.5 to 4 mm. It's 3.5 mm.
How do we measure width of attached gingiva?
Ma'am, it's measured from gingival margin to mucogingival junction, subtracting, I mean, without the pocket depth, ma'am.
And how we measure vestibular depth?
Ma'am?
How we measure vestibular depth? Shallow vestibule, we talk about shallow vestibule. It's okay, Charishma. It's okay.
Thank you.
Next one, please.
Hello. Hello.
Sanjay, can you present? You are audible. Start.
Hello. Am I?
Now you are not audible.
Hello. Hello.
Yes, sir, you are audible.
Hello.
Yeah, please present your poster.
Good. My poster topic is the bone regenerative procedure of intrabony defect using hydroxyapatite bone graft and PRF. The intrabony defect occurs when the bottom of the pocket is apical to the level of the adjacent alveolar bone, and intrabony defect that communicates with the periapical lesion of the pulpal origin results in a combined periodontal and endodontic lesion. But intrabony defect, how can be combination of the periodontal endodontic lesion? First, if the normal gingival sulcus having the flux and calculus accumulation, and then inflammation towards the apex, the alveolar bone loss, clinical attachment loss was seen, and then the osseous defect was found. But in this type of angular defect, there are classification of Goldman and Cohen classification. The three types of angular defects generally found is one wall defect, two wall defect, and the three wall defect. There are also a classification of Kern classification 1984, and was given for the irregular angular defect, and the classification was crater. What the crater is the cup ball shaped defect. Trench is the 2 to 3 wall involvement in the trench, and the moat is the circumferential defect. There is the 1964 Simon et al. Classification for the periodontal and endodontic lesion. Is the number one is the primary endodontic lesion, then primary endodontic lesion with the secondary periodontal involvement, primary periodontal lesion, primary periodontal lesion with the secondary endodontic involvement, and the truly combined lesion. In this case, a 54 years old male patient came to complain of the mobility of the tooth. First, and patient had a history of the trauma in 3 years ago, a road traffic accident, and the pulse sensibility test reveals that the tooth is non-vital, and the IOPR reveals there is a first the RCT was treated, and the occlusal splint was placed for the restrict the mobility, and then after that treatment, the full thickness mucoperiostal flap was elevated, and debridement was done properly. PRF made and mixed with the hydroxyapatite bone graft. The root biomodification was done. First the chemical biomodification, then the mechanical. First the mechanical biomodification, then by the sterile aluminum foil. Then the hydroxyapatite bone graft placed, and the membrane was placed over that, which was placed. And this is the 9-month course of result in front of us. There is the has reduced into the 2 mm pocket depth, and IOPR revealed good amount of bone growth into the distal root of that tooth, and the tooth was totally stable. There is a grade 2 to grade 3 mobility in that tooth, and now there is a only physiological mobility on that tooth. Thank you, ma'am. This is my case report of the poster presentation.
Which membrane you have placed?
Ma'am, collagen membrane, collagen.
Which type of membrane? Which type of collagen it contains?
Ma'am, there is a type 1 collagen.
And root biomodification you done with what?
First, I have done with the root biomodification by my QDEC. There is a mechanical root biomodification. Then EDTA was used for the chemical biomodification, root biomodification.
Was there any particular something in your mind while choosing hydroxyapatite bone graft for this case?
No, ma'am. Actually, that time hydroxyapatite graft was available in that time. That's why I choose hydroxyapatite.
That is the only plain reason for choosing hydroxyapatite. Okay, thank you. Dr. Komal?
Yes. Which type of bone defect was present in your case?
There is a irregular moth type of defect in my case. There is circumferential defect. Four wall was affected.
What is the difference between intraosseous, intrabony, and infrabony defect?
Intraosseous, intrabony, and infrabony defect.
Yes.
Don't know.
Which bone graft did you use? Hydroxyapatite.
Hydroxyapatite.
What type of a bone graft is it?
Ma'am, it is a osteoconductive bone graft.
And what particle size was used?
0.8 to 1 millimeter. 0.8 to 1 millimeter particle.
1 millimeter?
Micrometer, sorry.
And how did you standardize your radiographs?
Ma'am, I couldn't standardize my radiograph because I had no grid in my radiopath grid. But I can say that there is a good amount of bone regeneration after 9 months with follow-up in my case.
Okay, thank you. Next, please.
Next presenter, please.
Good morning, ma'am. Am I audible?
Yes, you are audible.
Okay. Can I start now?
Start.
Hello?
You can start.
Yes. Good morning. Today I'll be presenting a case on the Zuchelli's technique. So as we know that there are several surgical procedures used for covering the root surface when there is a recession, like the free gingival graft, the coronary advanced flap, the subepithelial connective tissue graft, etc. And out of all these, the coronary advanced flap is the first choice of surgical technique. But in that case, there is the vertical incisions there hamper the blood supply and the healing to the area. The subepithelial connective tissue graft, it is considered the gold standard, but this technique requires an extra surgical case. And in 2000, Zuchelli and DeSantis, they came up with the Zuchelli's technique, which is a modification of the coronary advanced flap for multiple recession on adjacent teeth in the aesthetic zone. So this does not require an extra surgical technique. It does not require vertical releasing incisions, and it is less time consuming as well as minimal patient discomfort is present. So in this present case, there was a 50-year-old male patient who had come with a complaint of receding gums. So on examination, there was a Miller's class 1 with 12217 and 24227, and Miller's class 2 with 44246. Here we considered 12215 in this case. The recession depth was measured, the pocket probing depth was measured, the keratin tissue height was measured, and the CL was also measured pre-op and post-operatively. So coming to the surgical technique of this, local anesthesia was administered and a modified envelope flap was performed. The first incision being the circular incision at the recession depth from 1 to 1.5, which also included one tooth on each side of the teeth to be treated. The second incision was a horizontal submarginal oblique incision in the interdental areas. So a surgical papilla was created mesial to the flap midline. So there's a flap midline, and mesial to it, it was moved more apical and distal, and vice versa. So distal to the flap midline, it was apical and mesial. And this was raised in a split thickness. The tissue apical, just apical to the recession, was raised in a full thickness, and from there till the mucogingival junction was raised in a split thickness. Now this split thickness flap gives more thickness, whereas in the root coverage, where root coverage is desirable, and this also facilitates coronal displacement of the flap in the split to the mucogingival, with a good anchorage and blood supply to the surgical papilla. Now, the remaining tissue of the anatomical papilla was deepithelialized, and the flap was coronally advanced and sutured using sting suture, and a pack was placed. The patient was recalled after a week for suture removal. He was also demonstrated a tooth brushing technique, as this recession was caused due to faulty tooth brushing habit of the patient. Chlorhexidine mouthwash was then prescribed, and the patient came back for his suture removal. And after 4 months, he had come again, and we have recorded a reduced recession depth and an increased keratin tissue width. The healing was also satisfactory with a good aesthetic outcome. There was a good color match in that area and a good contour as well. So this technique was shown to be effective to increase the keratin tissue width and achieve root coverage in multiple teeth in the aesthetic zones. Thank you.
What is apparent recession?
Ma'am?
What is apparent recession? Which brushing technique you suggested? Post-operative?
The roll tooth brushing technique.
What is the reason behind roll technique?
Ma'am, post-operatively, post-surgically, we normally prescribe the roll toothbrushing technique.
What is the reason? Like, why do we prefer?
Because there's not much trauma to the tissues in that case, ma'am.
Dr. Komal?
What are the prerequisites of Zucchelli's technique?
Ma'am, it should be the multiple recessions in adjacent teeth, and especially in the aesthetic area, ma'am. So the aesthetic zone, it's normally for that.
Apart from that, keratinized gingiva, attached gingiva.
So the keratinized tissue width,
okay, how is Zucchelli's technique different from the conventional coronally advanced flap?
So here we prepare a surgical papilla for the coronal advancement, as well as there is no vertical incisions given in this case, as well as it's less time consuming, and the patient is more comfortable for this procedure, ma'am. So the blood supply and all is not compromised due to this no vertical releasing incisions.
How did you prepare the surgical papilla?
Ma'am, first we find the midline of the teeth. So if there's a multiple recession, we find a midline. From that, mesial to the surgical midline, we make a surgical papilla that is more apical and distal to the anatomic papilla, ma'am. So from there, there's an oblique incision, horizontal submarginal oblique incision that's given to the next tooth.
Why do you think this is the direction of the papilla is such? like mesial and the distal? Why do you think it is like that?
Ma'am, while coronally advancing it, it is much easier, like we de-epithelize the anatomic papilla. So when we do coronally advance it, it has a good blending with the anatomic papilla as well. And there's no excessive tissue on the tooth.
Okay, thank you. Next, please.
Good evening, ma'am. Am I audible?
Yes, please start.
Good evening, everyone. The title of my case report is Recession Coverage with the CAF, that is coronally advanced flap and platelet-rich fibrin membrane. Gingival recession can be defined as the apical migration of the gingival margin towards cemento-enamel junction, and the etiology is multifactorial. Although the main etiology for this gingival recession is due to the plaque buildup on the teeth. Autogenous platelet concentrates have created new possibilities for tissue healing processes and have been used as promising substitute for subepithelial connective tissue grafts. PRF, an autogenous material, retains a large number of cytokines and growth factors in a three-dimensional fibrin scaffold for cell migration, which allows their continuous slow release over a period of time. So by considering various advantages of platelet-rich fibrin, it was used with the combination of coronally advanced flap in the treatment of the present case. So the objective of the present case was to achieve root coverage by means of combination of coronally advanced flap with PRF membrane. So this is the case report of a 27-year-old male patient who visited our Department of Periodontology with the chief complaint of receding gums in its in relation to upper left canine. And the treatment which was planned for him was a combined approach of coronally advanced flap with platelet-rich fibrin. So coming to the preoperative part, the recession depth was measured. It was taken from the cemento enamel junction to the most apical extension of a gingival margin. Also, horizontal width of the defect was also measured between the mesial and distal margin of the gingiva. And conventional preparation of PRF was done. Coming to the surgical management, two horizontal incision, mesial and distal to the recession defect was placed, followed by two oblique, slightly divergent incision starting at the end of two horizontal incision extending to the alveolar mucosa. After that, the resultant trapezoidal flap was elevated, and all the muscle insertion in the thickness of the flap was eliminated, and root surface was mechanically treated with the help of surgical curex, and then the PRF membrane was placed over the defect and the flaps were approximated. To close the oblique incision, the flap was approximated using interrupted suture, while to approximate the horizontal incision, sling suture was used. After this, periodontal dressing was placed, and for suture removal, we call the patient after 10 days. And this is the post-operative picture after the 6 months recall period. So hereby, I want to conclude by saying that a combined approach of coronally advanced flap with platelet-rich fibrin membrane placement has given promising clinical results, and long-term studies are required to establish this treatment protocol for recession defects. Thank you.
Sabrina, why you have not used this stent for measuring the gingival recession?
Sorry, ma'am, but we didn't. Actually, this was during the time the patient was in hurry and he has to go for. He could not come for multiple visits. So.
Okay, how did you decide the size of membrane? You have placed PRF membrane.
Yes,
how did you decide the size of the membrane?
Ma'am, our main aim was to close the exposure of the defect. So according to that.
only according to that, like what we follow?
Ma'am, ideally we have to make a stent, and according to that template should be made and
Template.
yes.
Okay. Dr. Komal, आप पूछिए.
But is PRF membrane a GTR membrane?
Yes, ma'am, it is a GTR membrane.
Does it follow all the principles of GTR membrane?
Ma'am, it helps in cell migration of osteoblast and fibroblast. And it enhances the wound healing.
But what about space maintenance and all?
Ma'am, it is not that stable.
Does it maintain space? Which is the requisite for a GTR membrane? What is a prerequisite for a coronally advanced flap?
Ma'am, the requirement of keratinized gingiva, 1 mm should be there.
1 mm? Yours was a class 2 gingival recession. How much keratinized gingiva was present in your case?
Ma'am, it was more than 2 mm.
What was the pocket depth?
Ma'am, there was no pocket depth. The normal circular depth was there.
How much?
Ma'am, it was below than 2.
Below than 2.
Yes.
So how much was the keratinized gingiva if it was a class 2 gingival recession? And it's not 1 mm beta for coronally advanced flap. Read again.
Yes, ma'am.
That's it. Thank you.
Thank you,
Next, please.
Are any more presentees left?
One more is there, no?
Yes,
Number
ma'am.
80.
Okay.
Yes, ma'am. Ma'am, actually, I'm unable to share the screen. Ma'am, my screen is visible?
Yes,
Yes,
please
it is
start.
visible. Okay. Good evening, everyone. Today, the topic for my poster presentation is Gummy Smile, its diagnostic criteria and treatment modalities. So what is the excessive gingival display? As given by Silberg N in 2009, extensive exposure of the gingiva during a smile. And recently, Waller Diaz in 2020 stated that more than 3 mm of gingiva exposed is referred to as excessive gingival display. Now, coming to the classification of smile line, there is low smile line, ideal smile line, or average smile line, high smile line. Low smile line, when less than 75% of clinical crown is visible, it is known as the low smile line. And when around 75 to 100% of clinical crown is visible along with interdental papilla, then it is known as ideal smile line. When whole clinical crown are visible along with continuous band of gingiva, then they are high smile line. So what is the etiology of excessive gingival display? Altered passive eruption, hypermobile upper lip, short upper lip, and vertical maxillary axis. Altered passive eruption when they are short clinical crowns, and also if there is enough amount of keratinized tissue, then we can go for gingivectomy procedure with or without osseous reduction based on the distance from CJ to bone. Hypermobile upper lip when there is hyperfunction of superioris levator labii superioris muscle. Short upper lip when the distance from subnasal to inferior border of upper lip is measured and it is deficient, then it is short upper lip. And vertical maxillary axis as on extraoral examination, when face is divided into 3 halves, then when the lower third of the face is more than the middle third or upper third, then it is known as vertical maxillary axis. So these 3 cases has been carried out in my department: gingivectomy, lip repositioning, and lip repositioning with myotomy. Gingivectomy with the has been done as there was enough adequate amount of keratinized tissue without osseous reduction, as the distance from CJ to bone was 2 mm. In first picture, the incision was made, and in second picture, tissue was removed, and third is post-op image. Lip repositioning, when patient complain of anesthetic smile, it was a female patient, and then the gingiva visible in dynamic smile was around 8 mm. So incision was made below 1 mm to mucogingival junction, one horizontal incision, and above in the vestibular depth, second horizontal incision was made. Partial thickness flap was raised, and then the epithelium was removed. And this is third picture is of 1 month post-op follow-up. Third, lip repositioning with myotomy, as stated by Tawfiq et al., that there are better results we can see of lip repositioning when muscle severance can be done. So the patient was referred from ortho department. His gingival display on dynamic smile was around 7 mm. So here lip repositioning was done, as alveolar mucosa was removed of around 14 mm, and then the muscle severance was done, that is the muscle that is superior levator labii superioris muscle is being severed to get the proper results, better results. And third picture is the post-op image of the patient after 3 months. So in this we can say that in myotomy there are better there's less patient discomfort after surgery, and also there is the tension less flap closure after the surgery. Thank you.
Did you place any suture in lip repositioning?
Yes, ma'am. We have placed suture for lip repositioning and also with lip repositioning with myotomy, but I was unable to put that picture here.
Yeah, clinical pictures are not complete as it, no? Even like here you're measuring, the position is like this only, lips in pre-op?
Yes, ma'am. Yes, ma'am. These are the pre-op images.
Was visible.
Sorry, ma'am.
The first picture that you are showing in lip repositioning, this is the pre picture. Like
Yes,
here
ma'am.
you went with the probe. Otherwise, also this much of the tissue was visible.
Sorry, ma'am. I am unable to get what you are saying. Ma'am, actually, this is the first image, pre-op picture, where we have measured the gingival display, and then
yes, this much was visible. This
yes,
much.
ma'am. Yes, ma'am. Yes, ma'am. Yes, ma'am. Yes, ma'am.
And what was the changes on the gingiva in that case?
Ma'am, ma'am, here third picture is the post-op picture at 1 month follow-up in lip repositioning.
Pre-operative, this much of the gingival tissue was exposed. Now, what
Yes,
was
ma'am.
the clinical picture? Like, what did you see in the gingiva clinically? Like, some changes might be there.
Ma'am, on clinical examination, there was a shining of gingiva, no any stippling wasn't present. And in this picture also, the shining of gingiva is visible. So patient complained of anesthetic appearance of a smile only, as patient was a young female patient.
Even in third case, you don't have the picture of like suturing and all.
Yes, ma'am. Actually, due to the shortage of space, I wasn't able to put more pictures. Otherwise, we have with us other pictures also.
Okay, fine. Dr. Komal.
Are there any other treatment options for gummy smile?
Yes, ma'am. We apart from gingivectomy, lip repositioning and lip repositioning with myotomy, if patient has vertical maxillary access, then and we can go for orthognathic surgery also, and in altered passive eruption, if there is a narrow band of keratinized tissue, then apically reposition flap procedure can be done. And also we can analyze the distance from CJ to bone. If distance from CJ to bone is less than 2 mm, then osseous reduction is also accompanied in both the procedure in gingivectomy also, as well as in apically reposition flap.
What about Botox and fillers?
Yes, ma'am. Botox fillers are also they are also one of the procedure which is a non-surgical procedure. As many times patient doesn't want surgical procedure, so botulinum toxin A, these are the fillers. They can be their injections can be given in vestibules.
But they cannot be used in all the cases. And which type of cases will you give?
Ma'am,
Will you recommend
where there is hypermobile upper lip, where the activity of upper lip muscles is high, so they stops the activity of these muscles.
So all these treatments are done in the ortho patients. Were they done in the ortho patients?
No, ma'am. No, ma'am. Ma'am, only last case has been done in ortho patient.
When an ortho patient needs the treatment of gummy smile, at what phase of ortho treatment do you do the treatment of gummy smile? Before, in between, or after?
Ma'am, in between the ortho treatment, just before the patient is going for debonding.
Are you sure about it?
Yes, ma'am. Ma'am, means.
Okay.
Ma'am, because
Thank
in this case also, third case also, patient has been treated before the debonding of his wire.
Okay, thank you.
Thank you, ma'am.
Okay, so with this, we come to the end of the session for today. My sincere thanks and appreciation to our chairpersons for chairing the session and to the organizers and volunteers for conducting this event. Thanks to the technical support team, because of which the sessions went on smoothly. It was a pleasure to have you all on this virtual platform. And once again, thank you everyone. Take care and stay safe.
Thank you so much for inviting us.
Thank you so much. Thank you, Dr. Bhuman.
Thank you, Dr. Nandini. Bye. So nice to meet you.
Sim.